Good morning, ladies and gentlemen. In a short while from now, we are all going to be a witness. We are all going to witness a part of a glorious moment of our history as we commemorate the World ARDS Day. And nothing can be more gratifying than having it in our own country, in the city of Delhi, for the first time ever. We are fortunate and privileged to have amongst us today Professor Dr. B.N. Gangadhar, Chairperson, National Medical Commission, as our chief guest to commemorate this special day with all of us here. Without wasting any further time, may I request our ISCCM President, Dr. Pradeep Bhattacharya, to kindly escort Dr. B.N. Gangadhar to the stage, please. Please give a big round of applause. May I now kindly request our other dignitaries on the stage to take their seat. Our past President, Dr. Sheila Maitra, President-elect, Dr. Srinivas Samvedam, our Secretary, Dr. Bharat Jagyasi, Secretary-elect, Dr. Sachin, Dr. Vijay Mishra. And also Dr. Ritesh Shah. Thank you, dignitaries. May I now request our dignitaries to kindly light the ceremonial lamp lighting in order to dispel darkness and bring knowledge in this beautiful gathering today. May now request our ISCCM General Secretary, Dr. Bharat Jagyasi, followed by ISCCM Executive Member, Dr. Vijay Mishra, for the welcome address, please.
Thank you, Dr. Nivan, and thank you everyone for spending this morning with us. And as is already said, it's a very important moment for us. It's the first ever ARDS Day, what we're celebrating across the globe. And I'm proudly, I can say, this is the idea which has been proposed to the global critical care community by Indian Society of Critical Care Medicine. I request you all, please, applause for the Indian Critical. So as a General Secretary, I am proud of the strides we made in understanding this complex disease and condition. And it would be a request and suggestion and hope, let us use this day to renew our commitment to advancing research, improving patient outcomes, and supporting each other in this vital field. So together we can make a lasting impact. Thank you very much for making this event a grand success for us. Thank you.
Thank you, Dr. Jagyashi. May I request Dr. Vijay Mishra for his welcome address.
We want to make sure that the welcome is not incomplete or less, so we are doubly here to welcome you all to this inaugural ARDS World ARDS Day celebration. I take pride in standing here before all of you, the national and the international dignitaries to welcome to this event. And yes, the day is fully packed. We'll be talking about something that has happened over the last 57 years. 12th August 67, we all remember. So 57 years in 8 hours is going to be really tight, and we'll request all of you to be very precise while you're delivering your lectures. And I once again welcome you all. Thank you very much.
Thank you, Dr. Vijay Mishra. Now I would request everyone to participate in dedicating this program to the fervor of patriotism and of love for our country by singing the national anthem. May I request all of you to stand up for the national anthem, please.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तब जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।
Thank you, ladies and gentlemen. May I now request our ISCCM President, Dr. Pradeep Bhattacharya, to kindly deliver his welcome address.
A very good morning to all of you. Respected Professor B.N. Gangadhar sir, our chief guest today and Chairman, National Medical Commission Council of India, Dr. Sheila Maitra, our past President, Dr. Srinivasan, our President-elect, Dr. Bharat Jagasi, current General Secretary, Dr. Sachin Gupta, Secretary-elect, and Dr. Vijay Mishra and Dr. Ritesh Shah were coordinating this program. All past presidents sitting in the front, respected colleagues, cherished friends, ladies and gentlemen. Today, it is both an honor and a privilege to stand before you as President of Indian Society of Critical Care Medicine on this auspicious occasion of the first ever inaugural World ARDS Day celebration. This day marks a significant milestone in our ongoing journey in advanced understanding, treatment and care of acute respiratory distress syndrome, a critical condition that affects countless lives globally each year. A gratitude to Ash Baugh, who published his first report about this syndrome on this day in The Lancet in the year 1967. ARDS is a profound challenge in critical care medicine, demanding our utmost dedication, research and innovation to improve patient outcomes. Today, we unite as a community of clinicians, researchers, healthcare professionals, and advocates to shine a spotlight on ARDS to raise awareness of the condition and reaffirm our commitment to those who suffer from it. As we gather here, we remember the patients and families affected by this dreaded syndrome of ARDS during the COVID period. Their courage inspires us to reinforce our determination to push the boundaries of critical care medicine. Our mission is clear: to enhance the quality of care through scientific advancement, interdisciplinary collaboration, and nurturing the next generation of critical care specialists. On this inaugural ARDS Day, let us reflect on our strides in understanding this complex syndrome from improving diagnostic techniques to innovating therapeutic strategies. Simultaneously, we recognize the gaps that still exist in ARDS care and the necessity to address them with urgency and creativity. Here, we request our chief guest, Professor Gangadhar, to consider the importance of establishing independent closed critical care departments in every medical college in our country, the way currently the emergency medicine department are opening. These departments should be managed exclusively by trained critical care specialists rather than relying on allied disciplines. The complexities of critical care necessitate a dedicated team of specialists who are specifically trained to handle cases like ARDS. An independent department should ensure that these patients receive the best possible care, which is critical for improving survival rates and overall outcomes. So our path forward lies in embracing the technological advancement, fostering robust research initiatives, and promoting global collaborations. By working together, we can accelerate the development of novel treatments, improve early diagnosis, and refine patient care strategies to mitigate the impact of ARDS. Let today serve as the catalyst for action, a call to the medical community, researchers, policymakers, and the public to join in our endeavor to combat ARDS. Let us pledge our continued support for those affected and strive towards a future where ARDS is fully understood and effectively treated. So thank you to each and every one of you for your dedication and commitment to this critical cause. Together, let us make this ARDS Day a platform for hope, progress, and the relentless pursuit for medical excellence. Thank you very much.
Thank you, Dr. Bhattacharya. Now may I request our today's chief guest, Professor Dr. B.N. Gangadhar, to kindly deliver his address and to declare this meeting open.
A very good morning to each one of you here. Distinguished dignitaries of this event who have organized this program to observe and increase awareness to this important, potentially fatal condition, the acute respiratory distress syndrome, and all the distinguished audience who are here to deliberate on all the academics and other clinical aspects of this syndrome, to be able to help and make a plan as to how to mitigate risks related to this and also reduce mortality and of course provide treatment promptly to these people. So I wish you all the best. I also congratulate the team for taking it up as a first event to observe the ARDS Day. I wish you all the best. I also understand that the COVID episode taught us to become aware of some of these conditions which require attention, and that most physicians should come forward to update their knowledge and make sure that this is attended to very promptly. Critical care medicine has been going on, the ICUs are being updated, and during the COVID time many issues were strengthened to make sure respiratory conditions are attended. And it is here, I believe, that we need to empower all the physicians who are attending to intensive care services to be empowered to attend to these conditions which happen in crisis and be able to avert fatal outcome of this condition. I believe this is an event that could crop up anywhere in the society, any population. There are of course several risk factors that have been described. Of course, the risks increase with age. There are many other potentially contributory factors. However, when a case is identified, it could be anywhere. There need to be a methodology whereby we be able to advise the local physician who has some intensive care service to be able to give the treatment or manage this individual if it is going to be a very distant area where this person has to manage him. To me, it appears that this becomes more important. During the COVID time, we learnt this war room-like arrangements began. Of course, war room was set up, and of course, a virtual war room can always happen in the days to come, so that help is available, guidance is available to support these people who are in periphery, who are managing this condition, and experts, most of them who are available in larger, well-equipped hospitals, who can perhaps offer this service and be able to equip them, empower them, and be able to help them to manage the crisis, because hour to hour we will be losing time on this matter. So having said this, the war room arrangement which has to be talked about, it comes into operation in many acute conditions. ARDS is one of the examples, starting from cardiac or neurological conditions. This concept has been talked about. However, emergency services to be able to handle all these conditions which will have a race again, which we have to race against the time in giving this support. So, as a larger body of the National Medical Commission, I need to also think these multiple areas where time is a very critical factor, and how do we address each of these conditions, and how do we generate resources where resources are not going to be available. Having made this brief note, I also want to draw your attention if there are any work that has happened, although I tried and I couldn't really get it. What are the ways in which these could be prevented? What are the things that could happen to these individuals or in general public, where we can tell them how to reduce risks of going into ARDS? If something has been done as a research from the ARDS group, or those critical care medicine individuals, or those physicians who are working with the intensive care services, I am sure this is something that should be brought to the awareness of the public, so that they really don't get into the perhaps a difficult stage of ARDS when any of the other conditions are cropping up. So put together, prevention and early intervention by way of helping and building resources and building capacity into those physicians who are attending to critical care services are these two things which seem a priority if you are going to address this at a larger population-based scenario. So I wish this awareness by way of observing this day is going to be very, very helpful in terms of bringing it to the attention of all physicians that this should be attended, and how do we empower ourselves to be able to address this problem. So I stop here. I apologize for having been late to this event. I know there are a lot of academic events that have been lined up for you to learn more about this condition, and I wish you all the best. Thank you for inviting me, and I thank the organizers for letting me come over here for this meeting. Thank you very much.
Thanks, sir, for your kind words of wisdom. May I now request our President, Dr. Pradeep Bhattacharya, to kindly felicitate Professor Dr. B.N. Gangadhar. Thank you, dignitaries and ladies and gentlemen. Now we are going to start with our release of our souvenir as well as our guidelines. But before that, may I request our past president, Dr. Sheila Nayan Maitra, to give her few words.
Professor Gangadhar, Chairman NMC, Professor Pradeep Bhattacharya, President of ISCCM, dignitaries on the dais, ladies and gentlemen. It is indeed a very proud moment for me as I stand here before you as the immediate past President of ISCCM at the release of the the guideline supplement of Indian Journal of Critical Care Medicine, which is just going to happen. It was during my tenure last year that the guidelines committee, which was led by Dr. J.V. Peter and the coordinator was Dr. Deven Juneja, that exactly 1 year ago we met in Mumbai and we thought of publishing 12 guidelines, and it was not just guidelines but also position statements, and it was a little unique in the sense that we didn't want to reinvent the wheel and make position statements and guidelines on what has already been done, but we wanted to address things that are unique to our needs and situation. And we looked at various aspects of sepsis, peculiar to India. We looked at malaria, tuberculosis, dengue and various other conditions. In addition, we also had the end-of-life care guidelines that was updated along with the Indian Association of Palliative Care, and another landmark paper that is published, a position statement from the ISCCM on gender balance in critical care. So there are, in the 1 year period, and it's really a Herculean task to publish 12 position statements and guidelines from ISCCM, and I'm really grateful to the guideline committee and all the authors and especially the journal. Last but not the least, the editor-in-chief, Professor Atul Kulkarni, who's facilitated this, release of the journal with the 12 position statements and the guidelines. And thank you very much, Professor Bhattacharya, President ISCCM, for facilitating the release of this journal, special issue of IJCCM at this special day, the World ARDS Day. Thank you very much. It's really a proud moment for me, and I speak on behalf of all the authors and the Guidelines Committee. Thank you very much.
Thank you, Dr. Sheila. May I now request Dr. Atul Kulkarni and Dr. Deven Juneja to kindly join, and may I now request Dr. Sheila to request Dr. B.N. Gangadhar, Professor and NMC Chairperson, to kindly release the guidelines and release the souvenir and mark the commemoration of the World ARDS Day. Dr. Deven Juneja, please. Okay. Thank you very much to all the dignitaries once again. Now may I request our dignitaries to release the souvenir, please. Thank you very much, dignitaries. Now may I request all ladies and gentlemen once again to stand up for the ISCCM anthem.
Vigilant and strong we care, night and day. We are intensivist, fearless in every way. Passionate and compassionate, we stand tall. Guardians of life, we fight it all. Teaching and training, bringing forth the light. Pumping a stock heart, the heroes of real life. Blending science and healing, we always strive. Facing challenges to make our specialty thrive. We are ISCCM, our hearts ablaze. In the darkest hours, we light the way. We are the warriors, death we defeat. With our sharp knowledge and skills, hogi hamari jeet. होगी हमारी जीत. Amidst beeping monitors and ventilator chaos, deciphering code blues, 2 strokes we play on. With empathy we heal and care to remission. We are unstoppable in our quest and mission. ISCCM, you are the pride. May you shine a beacon through time. We are the warriors that we defeat. With our sharp knowledge and skills, hogi hamari jeet. Hogi hamari jeet. Hogi hamari jeet.
Thank you, ladies and gentlemen. May I now request ISCCM General Secretary Dr. Bharat Jagiasi to kindly deliver the vote of thanks.
Thank you everyone, and special thanks to the Professor Dr. Gangadhar for coming over here and spending his crucial time. He's been a busy man, and I am aware of the scheduled meeting he has all throughout the day. And all thank you to all the delegates and the international faculties who have made it for us, and to the President ISCCM, President-elect Srinivas Samavedan, General Secretary-elect Dr. Sachin Gupta, and to the ARDS Day Coordinator, Dr. Vijay Mishra and Dr. Ritesh Shah. So I'll not waste much of the time, and we will start with the scientific session because it's a very tight schedule, and the request has been made already by the Vijay Mishra to all the speakers kindly stick to the times please, because it's a very tight schedule thing. Thank you everyone.
As we come to an end of the inaugural function, can we request our President to kindly escort out our Chief Guest, Professor Dr. B.N. Gangadhar, and I request ladies and gentlemen to remain seated till that time. Thank you very much, ladies and gentlemen. Now we move on to our scientific program. Thank you very much for part of this historic moment where we commemorate the World ARDS Day for the first time, that too in our own country, and hope we all enjoyed it. Thank you very much.
In 1967, Asberg first described acute respiratory distress syndrome, a severe lung condition characterized by inflammation and fluid accumulation, published in The Lancet. Initially referred to as shock lung or wet lung, associated with sepsis, trauma, and aspiration pneumonia. The complex pathophysiology of ARDS, involving inflammatory mediators, endothelial injury, and alveolar damage, was elucidated in the 1980s. Researchers used acute respiratory distress, bilateral lung infiltrates on chest X-ray, and impaired oxygenation to identify ARDS over the next decade. In 1994, the American-European Consensus Conference first defined ARDS to broaden the understanding of this syndrome. During this decade, lung protective ventilation strategies to mitigate ventilator-induced lung injury also came up. From 2000 to 2010, several clinical trials highlighted the intricacy of ARDS and the importance of focused strategies including corticosteroids, nitric oxide, surfactants, and other anti-inflammatory agents with varied results. In 2012, the Berlin definition enhanced the precision of accuracy of ARDS diagnosis to facilitate research and clinical trials and gave way to more precise treatment approaches. A fresh period of optimism began in 2020 when the COVID-19 pandemic brought attention to phenotypes of ARDS and studies finding beneficial role of immunomodulators, mesenchymal stem cell therapy, and cutting-edge ventilation techniques. Ventilatory strategies have kept on evolving, with lung protective ventilation being the foundation. But research is exploring new ways to improve care for this complex syndrome. The key advances in mechanical ventilation over last 3 decades are the low tidal volume ventilation with individualized PEEP, using of driving pressure, recruitment maneuvers, prone positioning, extracorporeal membrane oxygenation, high-frequency oscillatory ventilation. The future is dedicated to the development of a personalized approach incorporating genetic information, phenotypic variation, biomarkers, and individualized ventilation and treatment. And finally, we have the new global definition of ARDS in 2023, but we still have miles to go. The pioneers in ARDS research are Dr. Luciano Gattinoni, whose work on lung protective ventilation strategies revolutionized ARDS management. Dr. Lauren Brockhart focused on the optimization of ventilator settings and the lung recruitment maneuvers. Dr. Arthur Slutsky, Dr. John Marini, and Dr. Leonard D. Hudson helped us understand the ARDS pathophysiology. Dr. Gordon R. Bernard established the superiority of low tidal volume ventilation. Dr. Michael Mathai focused on the molecular mechanisms of acute lung injury. Dr. Claude Gurin and Dr. Jean-Jacques Seroubi came up with prone positioning in severe ARDS and non-invasive ventilation. Dr. Warren Zapol and Dr. Marco Ranieri pioneered extracorporeal membrane oxygenation application in severe ARDS. Dr. Roger Bone, Dr. Caroline S. Calfi, and Dr. Giacomo Grasselli all focused on the role of inflammation and endothelial injury in ARDS pathogenesis and phenotyping ARDS. Dr. Niall Ferguson explored the role of biomarkers in ARDS. Dr. Margaret Herridge worked on the long-term outcomes in ARDS survivors. We invite you to celebrate the debut of World ARDS Day in India as we commemorate this significant milestone. Attend this exclusive event and witness the making of history as leading experts convene to illuminate ARDS. Don't miss the opportunity to explore the world of ARDS with global leaders and experts in Delhi.
Good morning once again. It's a rare privilege to start a scientific session before time. And we are here because ARDS is such a fatal condition. We'll start much on time. Our first speaker today is Professor Atul Kulkarni, and he'll be talking about the historical perspective of acute respiratory distress syndrome. Dr. Kulkarni, please.
Thank you very much for the kind invitation and the opportunity to speak here on the World ARDS Day. This is going to be the outline of my talk. I will start with Lennec, the time when clinical examination was supreme. Then there was something described as the respiratory lung syndrome around the same time as the SBOX series came out. Then the first case series of ARDS, about which we have heard so much, the AECC definition of ARDS, and how the understanding of ARDS changed following the advent of CT scan and its utility in management of critically ill patients, which led to the concept of baby lung. And to give credit where it's due, the first ever description of limiting pressures and lateral volume actually came from New Zealand, from Hickling and colleagues, and we don't seem to take their names at all. So I think the credit must go where it is due. So this is a book which was published by Lennec in 1821. This copy that I have got is a 1938 copy from the Google library, and this is the first time where he was actually writing about the diseases of the chest and the utility of auscultation. And this was translated into English. It was a French book translated into English. And if you read the preface, it says that within 1 year, they had to come out with the next edition. It had become so popular in the United States. So it's the first time someone described edema of the lungs, which was of idiopathic origin, not only because of the heart. And it said that it is often fatal by suffocation, and the suffocative orthopnea was because of the idiopathic anasarca or edema of the lung. This was also very, very importantly said that it was an inflammatory affection of the lung, unlike the hydrostatic cardiogenic pulmonary edema, and they also described no X-rays were there. They described that it occupied the posterior and inferior portion of the lung. So this book for the first time mentioned the non-cardiogenic pulmonary edema. So that is where it began more than 200 years ago. Then came this report, of which we have heard so much, published today, exactly 57 years back. And the description, if you go through the article, is very, very nice and still relevant today. So they said that it's a diffuse infiltration. Now we know that it is not equally diffuse on both sides of the chest. However, they described 12 cases. So apparently they have been noticing this in their previous patients, the problems with oxygenation, etc., etc. But if you look at the table, you can see that it came from various etiologies. The onset time varied from 1 day to 48 days or even longer. Many patients had hypotension, acidosis and fluid overload. They also described the respiratory data. Most of the patients were tachypnic, and the respiratory rate was, the median respiratory rate was around 40, very high minute ventilation, severe hypoxia, low normal because of hyperventilation to high PaCO2 when the patient became fatigued, acidosis, and very, very importantly, they described the poor compliance of the lungs. Around the same time, in the same paper, they also described the autopsy findings. So they said that the lungs were hyperemic, their distended capillaries, areas of alveolar atelectasis which are not contiguous and they are different, their interstitial and alveolar hemorrhages, and diffuse interstitial inflammation and fibrosis. They also talked about the gradual progressive deterioration, increasing reduction in pulmonary compliance and vital capacity, and most importantly, they also talked about the two phases, the exudative phase and the proliferative phase, where there was increased or marked edema of the alveolar and interalveolar septum, etc. After this came the AECC definition. Here, to differentiate between the cardiogenic versus non-cardiogenic part, they said that the pulmonary artery occlusion pressure had to be less than 18 millimeters of mercury. This is the first time someone said that they recommended that ALI term was coined depending on the degree of hypoxia. The most important advent, I think, in our understanding of the disease was, however, after the introduction of CT scans. So this study, published in 1988, looked at the lungs of the patient when they were given 0 PEEP and 5 to 15 increasing amount of PEEP, and they said that as the PEEP increases, the lungs cleared and the mass of aerated tissue gradually increased. And the accompanying editorial in anesthesiology said that the Gattinoni group, being the descendants of Leonardo, Vesalius and Fabricius, it is apt that they have matched the correlating anatomy with the understanding of disease. Following this, shortly, I couldn't actually read this because it was, I couldn't find this journal, but this is the first time they described the concept of baby lung in 1987. So it was all around the same time. And lastly, and this is my last slide, during the period of this study, this is a paper from Hickling, where they limited the peak inspiratory pressure rather than the plateau pressure. So that concept was not there, but they used tidal volumes as low as 5 ml per kg, which is very, very similar to what we are doing today. And they had, out of 50 patients, the mortality was only 2. So only 2 patients died in their entire study. So we must give credit. They also described the concept of permissive hypercapnia, and they suggested that by increasing PEEP, we should ventilate the patient with minimum FiO2 as far as possible. So I'll stop here. Thank you very much for the opportunity once again.
Thank you, Professor Kulkarni, for being almost on time, finishing in time. Our next speaker today is Dr. Rajkumar Mani from Ghaziabad. He shall give us some insights into ARDS. Dr. Mani, sir, please.
Right. So I would like to give a poetic celebration of ARDS insights. The ARDS story since Ashbog and Petty. Full 57 years and counting, yet not any the less fascinating. It's not moving. Yeah. Changing names and definitions, adding new inciting conditions to the elusive grail we have long traveled. Yet say the world's pundits today, no, we haven't quite got it. For long, It hasn't been just about correcting the blood gases, nor just about treating the causes, or about extracorporeal support resources. It's how on we live and hemodynamics we reflect, and how well the lungs from injury we protect. It's not moving again. Yeah, sorry. Tidal volume low, but how low is fine? It could be that it's only good if DP2 is below the line. On PEEP and airway pressures, we could do with some more light, as we are still unsure which numbers are reliably right. Gattinoni said years ago, ARDS is non-homogeneous. Now in his new concept, incredibly ingenious, he points to the mechanical power to monitor and keep lower. Of the region-wide stress and strain though, we still don't quite know measures that are for the lung less injurious. Between many a subphenotype, an individual genotype, innovations looking for evidence, pharmacotherapies awaiting clearance, novel bedside imaging and finer mechanics, and fine-tuning the analgo sedation NMB mix, we might yet find many an insight, however incomplete and imperfect, to close in on what we might term as precisely right. Thank you for your indulgence. I tried to summarize the insights in ARDS just to have a lighter moment, because we have a long day of deliberations on ARDS. Thank you very much.
Thank you, Dr. Mani. That was just awesome. Our next speaker for the morning is Dr. Elisa Estensoro from Buenos Aires, Argentina. Can we have a round of applause for her for joining us from across the globe? Elisa will be talking about the epidemiology of ARDS across the world. Next 20 minutes is yours, ma'am.
Well, first of all, I would like to thank the Indian Society of Critical Care Medicine for their so kind and warm invitation. Well, today we'll be celebrating ARDS, so you'll see this many times, because, well, today is the 57th anniversary of the publication of Petty and Ashbaugh definition. And it was the first, I would say, comprehensive definition of ARDS. And they stated that ARDS was a type of acute respiratory failure that was preceded by a catastrophic event. Now we would call that risk factor. And that it was characterized by a pulmonary edema that was not of cardiogenic origin. Clinically, its main characteristics are deep hypoxemia, bilateral lung infiltrates, and decreased compliance. And in that same paper, they stated which were the mechanisms of hypoxemia. Increase in pulmonary shunt and increase in pulmonary dead space. Well, why would we need a definition of ARDS? The problem is that we have no gold standard for ARDS. It was thought for years that there was a gold standard, was a histological one, the presence of diffuse alveolar damage. But some studies, especially this from Thiel, found that DAD coexisted with other different histological patterns. So we need still a definition, though we lost that gold standard we once had. And this is because every time we say ARDS, we think it triggers in us a series of behaviors, of monitoring therapeutic behaviors, and that is just use protective ventilation, track PO2, FiO2, target these two so important plateau pressure and driving pressure, look for complications through other therapies, and also counsel patients and families about this syndrome. So we've had so far, as has been said, 5 definitions of ARDS. And the most long-lasting was Petty's initial definition. And after this came the lung injury score from Murray and collaborators. These were 4 experts. And this was interesting because it was an intent of quantification of this definition, of a quantification of severity. And they took into account 4 different variables. And you see alveolar consolidation, PO2 and FiO2 for the first time for evaluation of hypoxemia, the application of PEEP, and the respiratory lung compliance. But as we see, just for experts, and these cutoff points that should be summarized in a mean or in a median of these values, the problem was that they were totally arbitrary. There was a consensus from these 4 experts for this, so this didn't last long, and then came the American European Consensus Conference. Again, acute respiratory failure characterized by bilateral lung infiltrates, discarding cardiac factors, and a definition of hypoxemia according to PO2 and FiO2 relationship. A broad category of acute lung injury, a broad syndrome with PO2 and FiO2 lower than 300, and then a subset, which would be ARDS, with PO2 and FiO2 of equal or lower than 200. But this definition was greatly criticized the moment it was issued, because it didn't take into account, first, the evaluation of PEEP. PO2 and FiO2 has a different meaning with or without PEEP. And many studies addressed this. This was one that we published many years ago in intensive care medicine with patients with ARDS as soon as they entered in the ICU and were diagnosed, and look at how patients change from category, from one to others, but these are the same patients. This is the effect of the progression of the disease and also of therapeutic measures. And the important thing was that both categories had the same mortality. The other problem that was, and has been always one of the weak points of ARDS definition, but it was started to be discussed after the American European Consensus Conference, was the great variability in the evaluation of pulmonary infiltrates. So there's a lot of intra-subject and also inter-subject variability. And really, again, this has been, this problem is akin to all ARDS definition. It hasn't been solved yet. Well, 18 years later, we had another important point. It was the Berlin definition. And again, we had an acute respiratory failure, but some novelties. The time of exposure from the risk factor to the appearance of ARDS was defined as 1 week. And of course, again, the bilateral infiltrate on chest X-ray, the definition of the exclusion of cardiogenic causes, and a graduation of oxygenation in 3 subgroups of increasing severity: mild, moderate, and severe ARDS, with 3 cutoff points of 300, 200, and 100. And one new point, ARDS could be also patients that were not intubated, especially in the mild category, that could be with NIV in those moments. And the other point was that PEEP was, again, in the definition. Now, this PO2 and FiO2 relationship has to have these values with PEEP at least of 5 centimeters of water. And the other important point in this definition was that the experts issued what they call the conceptual framework of ARDS that included other variables that were not present in the definition itself. And this was ARDS was thought as an acute diffuse inflammatory condition caused by increased pulmonary permeability. And you see, these 2 things are not in the definition. No inflammatory marker and no permeability pulmonary marker. And of course, well, they had hypoxemia, bilateral infiltrates, increased shunt, dead space, and decreased compliance. atelectasis was first recognized as a component of the syndrome, and the clinical presentation may have differences according to what we've been saying, no? Of therapeutics and evolution of the disease. And the problem of diffuse alveolar damage was recognized as such, saying that, well, there could be other also histological patterns in patients with ARDS. But what is the burden of the disease, the real burden of the disease for ARDS? Well, for this, the lung-safe study was really a hallmark, an important point in the definition of ARDS, because these were more than 3,000 patients from the 5 continents, and they stated that ARDS incidence was 0.42 cases per ICU bed over 4 weeks. This number is not very intuitive for us, but it's interesting how it is composed, no? Because if we see the frequencies or the incidence of ARDS through the different continents, we see that Oceania, for example, has the highest incidence, and it doubles that, for example, that of Asia. And really what we see here is, or we could wonder, what is the problem with low and middle income countries? Why do they have this decreased incidence? Is this a biological fact, or really what happens here is what is as a decreased access to healthcare and to ICU care in these regions? Probably this is the cause of this. And I will present you with some data from Argentina, which is an upper middle income country. And we did this study many years ago, and what we found was, our burden was that ARDS was 7% of all admissions and 18% of all ventilated patients. And when we look to similar studies, these numbers are pretty stable, you see. And the lung-safe study, well, finally established that it was 10%, ARDS was 10% of ICU admission, nearly 25% in ventilated patients. It's a big high burden. And this can change dramatically, as it happened during the COVID pandemic. Our ICUs from all over the world were flooded with patients with ARDS. And in a study we did in Argentina, in ventilated patients, the incidence of ARDS was 80%. Look at that, from 8 to 80%. Of course, this was transient, but it shows us how dynamic these things. And with respect to the risk factors, the lung-safe study established that the 4 more frequent ones were pneumonia, sepsis of extrapulmonary origin, aspiration of gastric contact, and shock. But when we speak of the force of the association, we found that pneumonia occurs AR occurs in 8% of pneumonias. And in shock, ARDS occurs in 18% of patients. And in burns that are admitted to the ICU, ARDS can be present in nearly 1/4 of patients. So one thing is the incidence, another is the strength of the association. In our study from Argentina, we found similar things, where you see that sepsis was the most frequent causes of ARDS, and pneumonia the most single common entity. But this has not always been the same, though, as I told you, the panorama is dynamic. We did this study, we published it in 1990, but these are patients from the 80s. And what we had here was the division in ARDS, septic ARDS and non-septic. Look at the septic ARDS, which is the greatest number, no? the column that is in the low part. And there, the most frequent cause of sepsis, of ARDS in those times in Argentina was septic abortion, which disappeared, luckily. But you know, things change. And we have had new risk factors. During the COVID pandemic, obesity was a very frequent risk factor, and we found it in our cohort of patients in Argentina in 44% of cases. This was the second most frequent risk factor. But really, this was not new. This had been already described during the flu pandemic in 2009. We and other investigators found this, that obesity, again, had been the second most frequent risk factor for ARDS. Sorry, something happened here. Well, what about the outcome of ARDS? And in the Berlin definition, it was defined that mortality was 40%, different according to the severity of ARDS. And this is very interesting, is the flow chart of the lung safe study. So before describing what happened with ARDS, they found that 4,000 and nearly 500 of patients had acute hypoxemic respiratory failure. And of these, 2/3 were ARDS. But the other third, what were these? These were pneumonias, unilateral pneumonias, and heart failure. And when we look at the outcomes are similar. So this has made some investigators say, well, does ARDS really exist? Or it is somehow, or it should be called acute hypoxemic respiratory failure? Well, the discussion is there. And another thing that also affects ARDS outcomes is where patients live. And this is what we are seeing here is survival, not mortality. But if you see here, the greatest survival occurs in US and Canada, the red ones, followed by high-income countries in Europe, and then we are there, the green ones, the low and middle-income countries. And of course, this is related to how, again, to how healthcare is managed in low and middle-income countries. And, well, this year we published this study. It was a meta-regression about mortality in Latin America. We could find 32 studies, not many during that long period, but what we found was that mortality was high for ARDS in Latin America, but we could split the population in two. Studies before the ARMAS study was published had greatest mortality, and after the ARMAS study was published, this fell, accordingly to the adoption, I would say, not universal, but slow adoption of a protective ventilation. And if we considered only those studies in which Berlin definition was used, mortality was even lower. What about the causes of death in ARDS? Well, this is a very old study, but a classical one, the study from Montgomery, that said, well, patients with ARDS die mainly of septic syndrome and multi-organ dysfunction syndrome, and only 16 die of irreversible respiratory failure. And what we found was exactly the same in our first study of ARDS. Look at that, only 14% dying of refractory hypoxemia. But with the flu pandemic, things changed dramatically. In our study, the numbers were reversed. 64% dying of refractory hypoxemia. Look at how lungs looked in that moment. And what happened with COVID? Well, we looked for this also, and we found that COVID was in the middle of this. 43% of patients died of refractory hypoxemia as the first cause. And this is important because we have to plan. Refractory hypoxemia requires other treatments, for example, ECMO, so that have to be developed, that are really scarcely used in low and middle-income countries. Well, not all the risk factors had the same prognosis. You see how shock is the most deadly one, and how trauma associated with ARDS has the lowest mortality, at least in our series. And we could say, we could enter now in this theme, what are the variables that predict ARDS outcome? And if we look at, this is one of the possible series, we look at this, that some of these variables are fixed. Patients bring them with them. So age, severe disease like, for example, neoplastia, immunosuppression, HIV. So this, we can't change this. But there are some other factors that can be changed, that can be modified, as the lung safe study showed. Some, for example, these are in the pressures in the first day, plateau pressure, driving pressure, and peak pressure, and also PO2, FiO2. They increase, mortality increased steeply from some particular values, and these can be modified. So we've seen up to the moment that there's a lot of heterogeneity in ARDS. And this was, I would say, masterfully analyzed by the group of Caroline Calfee. They used a specific technique, which is latent class analysis, and looking for patterns of variables, just not one variable, but patterns of variables that could be present. And they found that some ARDS patients, which they call inflammatory or pro-inflammatory phenotype, had some things in common. For example, they had inflammatory markers in common, elevated, but also they had, for example, elevated heart rate, elevated plateau pressure, or elevated creatinine. And this conformed this pro-inflammatory phenotype, as I have said. And patients were very different between these two subphenotypes. The pro-inflammatory phenotype had more men, more sepsis, more pneumonia, and most importantly, mortality was the double of this compared to the anti-inflammatory phenotype. So there have been other phenotypes described after this first seminal study, we could say, from Calfee, and I won't go deeper into this because we'll have a talk from her today. But the thing is that perhaps these different phenotypes are expressing different damage patterns of different, and perhaps different treatments could be used to go into what is called personalized medicine. Well, the great novelty in 2023 was the new global definition. And was it necessary? Well, yes, because there had been progresses, there had been advances after the Berlin definitions, but the thing was that they were massively applied during the COVID pandemic. So we had a different insight of this. And the new global definition, well, for the first time, it says that intubation is not required. There have been this new category, non-intubated ARDS, that these patients can use, as was said before, non-invasive techniques, but especially high-flow nasal cannula. The second novelty was that hypoxemia could be evaluated not only by PO2 FiO2, but also with SpO2 FiO2. We call it SAFI in Spanish. And this is because these two have a great intralinear correlation, so they can be used interchangeable. And this is more simple. As you know, this is the continuous oxygen saturation by pulse oximetry is continuous, it's cheaper, it's non-invasive, so lots of advantages. Bilateral infiltrates could be evaluated now with ultrasound, apart from chest X-ray and CT scan. And the most controversial statement was this: in resource-limited setting, you don't require any special respiratory support device. And this adds increased sensitivity to definition. And where does this come from? Well, this comes from the Kigali modification of ARDS Berlin's definition. Kigali is the capital city of a very small country in Central Africa, Rwanda, and they found that they had lots of patients, young patients with acute hypoxemic respiratory failure that could only be admitted to the ICU in a third of them. They had no blood gases available. They had only saturation by pulse oximetry and could measure that once a day. Less than half of patients could have a chest X-ray done, but ultrasound could be performed in all, and less than 1/3 could receive mechanical ventilation for lack of ventilators. So many of the criteria of Berlin definition could not be fulfilled. No PO2 FiO2, no PEEP. But these patients, of course, they had ARDS, and they have a very high mortality. So these investigators proposed that to the Berlin definition add the possibility of evaluating hypoxemia with SpO2 FiO2, no PEEP requirement because of this generalized lack of ventilators, and also the possibility of using ultrasound. And this is how the lower middle income countries, I would say, penetrated into the Berlin definition. Well, what about the future? Well, some very prestigious investigators have said, well, we really challenge the concept of this frame with the conceptual model of ARDS. Let's move to a different way of doing definitions. Let's move from the definition from using syndromes to using constructs. And constructs provide a shared meaning for different people. So they have to be developed following a very strict way, well, using phase validity, other types of validity, reliability, and feasibility. And some of these had been taken into account in the Berlin definition. So Following that line of research, Professor Markus Schultz, who is here, and also Professor Farashad Nasa, led a group of investigators, conformed a group of investigators to have a Delphi study in which we could have a response to this. First, to have really global opinions about definitions of ARDS, whether they are needed or not, and to assess each one of the variables that had been used before in all the precedent definitions, and also just to investigate further, deeper, into the role of subphenotypes with the hope or desire to develop new treatments, personalized treatments for this group of patients. Well, thank you again for your very kind invitation and attention.
Thank you, Eliza. Our next speaker is Dr. Yatin Mehta, and he shall be taking us through the Indian context of ARDS. While we are not giving you space to breathe between the talks, you're still free to get your coffee and drinks inside the hall and continue with the talks. Sir.
Thank you, Dr. Mishra. Pleasure to be here. I'm going to talk only about the experience, the publications from India. Well, this is stuck. Yeah, okay. So I bring you greetings from the best hospital in India. Okay. Now, these are the global burden has increased, we know that, tremendously. And the incidence about 13.5 to 28 per 100,000. And obviously, when the patient stays longer and gets ARDS, the cost of the care goes up substantially. So this was a publication from India. Prevalence was this was an autopsy study. 36.9%. Patients were mostly from 18 to 30 years of age. Males were predominantly more than females. The diagnosis was ARDS, sepsis, and LRTI, and so on. So this is ARDS in a surgical ICU. That was an autopsy finding. This is surgical ICU from Thomas Chandy's group. And here they found that mortality was 41%. The incidence was 30% once the patient went on a ventilator. And the most common etiology was sepsis again. The risk factors were higher Apache scores, lower pH, and higher PCO2. This was another paper, again epidemiology. Average age was 42, and they split into survivors and non-survivors. They found the survivors had a lower severity scores and were a bit younger. Mortality was high, 44%. So how do we differ in the data, Indian data from the Western data? Well, average age is lower, lower pre-existing comorbid conditions. That means in the Western population, there are elderly people with multiple comorbidities. Here it is younger patients with lesser comorbidities. Sizable population was tropical fevers and higher mortality than the West. Obviously, that is because of the resource limitation and the facilities available. Outcome, well, if in this particular study, scrub typhus and dengue were observed to have better survival. Advanced age, sepsis, septic shock, liver disease, and ventilation requirements were independently predicting mortality. These are the basic principles which you are going to see in the next few hours, standard of care, and these are the American Thoracic Society recommendations, what is strongly recommended, what is conditional recommendation, and what is not recommended. So these are the new things which are now recommended against lung recruitment maneuvers. These are not Indian papers, so I again will not delve too much. In neuromuscular blockade, I think Dr. Sheila is going to speak about that. VV ECMO has been conditionally recommended, which was not done so earlier. And these are the ESICM guidelines for management, and this is similar to what the American guidelines are. high flow nasal cannula is recommended in milder forms of ARDS. And these were you don't need to have a patient necessarily on ventilator, and these were the Indian guidelines for non-invasive ventilation. So for a mild ARDS, we recommended that we can try non-invasive ventilation, but obviously for a moderate to severe ARDS, it's better not to struggle and better to put the patient on a ventilator. There is a new drug which had just come. It's been there in the American market for a long time, not for ARDS, but vasoactive intestinal peptide. It is primarily for sarcoidosis. It has been approved for a long time. So during the ARDS times, this was approved in India by the DGCA. And then we did a study on this, and we had a case series of 3 patients. This is the first patient, as you can see from the left to right. The CT scan was pretty bad, the X-rays progressively, and the F is finally at the end of the day. So 3-day therapy works quite well in my opinion. This was case number 2. You can see the CT scans on the left side. On the right side, the X-ray is pretty bad, then it gradually improves. All 3 patients survived. And this is the third case. As you can see, radiologically, the patient is getting better. The oxygen requirement went down. Things got better. Then this was a patient of Trally, basically, which simulated, it looked like an ARDS, but he had a refractory hypoxemia. As you can see, the PF ratio was 121 on the day 0 of surgery. This is a major Bentall surgery patient had undergone, and 73 on the next day. And the patient did not agree for ECMO, so we administered this drug, and the patient, this was published in the American Cardiothoracic and Vascular Anesthesia, and the patient improved and survived. So this is the X-ray in the beginning, before administration of the drug, and you can see this was on the right side, this after patient has improved. Another drug was urinastatin, which has been used in this part of the world quite often for inflammatory and sepsis and things. So we did the study. It was a 30-day mortality was significantly lower. This was with Kapil Zirpe, Sobel and all. And we found significant mortality benefit in COVID ARDS in patients who were given urinastatin. Both got obviously the standard of care. So thank you very much for your attention. And I would request Dr. Mishra to take.
So thank you so much for finishing exact in time. Though we do not have much research from this part of the world in ARDS, but the intention is there. And next, Professor Divatia from Mumbai shall be talking about the intended research in the field of ARDS in India. So.
Yeah, good morning, and again thank you for the opportunity to be here on this occasion. So this is a forthcoming project on ARDS that we intend to do. So last year we had a research conclave along with the guidelines conclave which Dr. Sheila Mehta spoke of. And here we sort of said that, it's been so many years since the ISCCM was formed, it's high time we moved on from observational studies to doing some actual randomized trials, and some projects were presented, and Dr. Sumitra's proposal to do a randomized controlled trial of corticosteroids in ARDS was sort of taken up as our project. It is an unanswered question. It is of interest to all practitioners of critical care medicine, and of course there are certain features about Indian conditions and Indian diseases that cause ARDS, which may lead to a different answer or some answers on the use of steroids. So we all know that ARDS is a heterogeneous syndrome, and it's of course not very well understood, but there is inflammation, and that inflammation is in the lungs as well as a systemic inflammation. There's fibrosis, there's fibrogenesis, and there's dysregulated and persistent systemic inflammation. And steroids obviously have a role in inflammation. And they have anti-fibrotic and anti-inflammatory properties, and they've been used. There have been several studies on steroids in ARDS, and this was one of the sort of reviews which was done as part of the 2017 European American guidelines, and they reviewed many of the studies of steroids in ARDS. Many of the ARDS studies also included pneumonia, okay, and the SCCM and ESICM gave a conditional recommendation on the use of steroids. Okay. A Cochrane reviews at the same time, however, found no evidence of benefit with steroids. A more recent meta-analysis was published in 2020, looked at 4 major trials, including the VR trial, which was done in 2020, and they seem to find a benefit for early prolonged treatment with corticosteroids in ARDS. Okay. So with this sort of background, we thought we should do a trial of dexamethasone in ARDS. This is still in planning. It's not, but it's like ready to roll out pretty soon. And we are calling the India ARDS study that injectable dexamethasone in ARDS. Okay, so we'll have 2 groups. We'll have the steroid group, which receives conventional treatment, and dexamethasone. Now the dose that we are talking about is 8 milligrams from day 1 to day 7, and then 4 milligrams from day 8 to day 14, and then of course you'll have a control group which will receive a blinded placebo in the form of normal saline. Why did we choose dexamethasone? Well, it's got strong glucocorticoid and very little mineralocorticoid activity. It's long acting, it's cheap, freely available, ready to use ampules, okay, and you can make a placebo very easily. How did you get this dose of 8 milligrams, I mean, per day for 5 days? So we looked at some of the previous trials which have used steroids, and one was dexamethasone, which had used 5 milligrams, but that was largely in severe bacterial pneumonia. The DEXA-ARDS trial, they use a very high dose, that's 20 milligrams for the first 5 days and then 10 milligrams for the next 5 days. Meduri used methylprednisolone, and the dose that we are using is equivalent to what Meduri used. Okay. In COVID, we were all using 6 milligrams of dexamethasone, but so ours is somewhere around in that range. There were some objections to using the same high doses that were used in the DEXA-ARDS trial. Many people thought 20 milligrams was too high a dose, so we sort of used a moderate dose, which we often use in practice, especially in neurology, neurosurgery, and so on. So I think that seems to be the dose that we are using. The primary outcome will be mortality at 30 days. There will be a number of secondary outcomes. And we will include patients who are 18 years of age and who now fulfill the global definition of ARDS, right? So we know what that global definition is. And we will include patients who are on high flow nasal oxygen, also with the flow rate of more than 30 liters per minute. And we'll try and catch early, so with maybe 24, maybe 48 hours after meeting the diagnostic criteria for ARDS. Okay. My time is not running out, but the battery is. Okay, so just someone needs to plug it in. We'll exclude patients who are receiving steroids chronically, terminally ill patients, the usual ones, COVID-19, interstitial lung disease, patients who are receiving steroids for septic shock, physicians unwilling to introduce steroid therapy for various reasons, for different types of pneumonia or something which the patient may have, and of course if the patient requires steroids for any steroid responsive condition, we are not going to randomize that patient. We are calculate a sample size of 162 in each arm based on a mortality of 45% in the control group and aiming to reduce it by 15%. So we are looking for a 33% relative risk reduction, and to account for dropouts about 175, so 350 patients is what we are planning to do in about a year's time. We've formed a steering committee. There will be a data safety and management board. The ICU research net, which has got all the centers interested in ISCCM research, will be used to recruit patients. We are in talks with the George Institute in Delhi for trial management and funding. I think ISCCM has agreed to give a reasonable amount so that we can start off the study, and we will look for funding from other sources. So with that, we look forward to participation from all of you, and we hope that we can actually pull off this trial for India, for ARDS, for ISCCM. Thank you.
That was clinical. When we don't know where we are heading or we are heading nowhere despite the best, then going back to the basics is probably the best thing to do. And our next speaker is Dr. Narendra Rungta from Jaipur. So I will be talking about basic is the best. Dr. Narendra Rungta, sir.
Hello, good morning. Thank you, ISCCM leadership, for inviting me. We all know new therapeutic interventions in ARDS are very tempting and maybe mesmerizing. And in a corporate hospital, the CFO is definitely mesmerized by most of them. Inventing, presenting, and pushing a technology, newer technology particularly, is the business of industry. Of course, we are interested. Our business, however, there is a problem here. Yeah. However, our business is to save lives and practice safe, sound, and proven technologies. Basics have never lost their relevance. We all know, we all agree. And therefore, there is no place for hopping, skipping, and jumping the basics and to be tempted to carry out the most advanced interventions, which may call them so. And this is more relevant for a clinical condition like ARDS, where both the patient and the treating teams are on the edge most of the times. Accountability, answerability, outcomes are so crucial. I just discussed few rules or points. I have named them rules. Basic rules. Basic rules may be related to our specialty, critical care, may be related to ventilation, and few of them to ARDS. And we just cannot skip any one of them. Rules, few which are related to critical care. I have not enlisted the whole list of critical care rules. Critical care is a multidisciplinary work. It does not mean it's an open ICU, but we should have a complete team, because one or two persons, two consultants, one or two residents cannot manage a case of ARDS as well as we expect them to. Perfect prevention of infection strategy must be there in place. Continuous updating of your knowledge and skill is very important. What we usually ignore are the nursing teams. They are very important members of any ICU team when you are particularly indulging in management of very high-risk cases like ARDS. Fast Hugs BID is a wonder acronym which must be followed. I always emphasize when I take the podium to talk to my younger teams, HAI is a huge challenge. Therefore, I have particularly included this slide. CRBSI, VAP, catheter-associated urinary tract infection are very common. They are underreported, they are underdetected, and therefore very, very difficult to treat. And the organisms that are involved in causation of these clinical disorders are very hard to treat. Almost in India, we see resistance to almost every antibiotic that we have in our armament. A slide about fast hugs. We must take care of feeding, analgesia, sedation, prevention of thromboembolism, head up, prevention of stress ulcers, maintain glycemia to optimum levels, and spontaneous breathing trials must be carried out whenever possible. The few rules related to ventilation: use a ventilator and monitoring system which is
you and your team are most comfortable and in practice with. No specific machine has shown any significant improvement in ventilation outcomes of ARDS patients. Use a ventilatory mode which is commonly used by you and your team. No new mode, however tempting, fashionable, has not proven its utility over the long-standing assist control volume or pressure ventilation. Use ET with subglottic outlet, right size, at the right location, put it at the right location and cuff at the right pressure. Humidification should be immaculate and fiddling with airways should be minimal. Don't insert catheters and scopes into the airways. And there are few rules that I recommend related to ARDS. All patients of ARDS must get an early and fair trial of proning unless it is really contraindicated. NIV is not a choice in ARDS. Low tidal volume, high PEEP, permissive hypercapnia strategy should be practiced. Plateau pressure should not exceed 30 millimeters of mercury. Monitoring driving pressure and keeping it around 15 to 16 is a safe bet. Some consultants may choose transpleural pressure instead of driving pressure. That's okay. Maintain pH above 7.2 and don't look at PCO2 which might be rising because of your strategies. Keep modest PF ratio targets for every next few hours and SPO2 of anything around 85 to 88 may be all right initially. I'll just finish. Sacrificing recruited lung for speculative interventions like bronchoscopy and nebulization should be discouraged. Be miser in giving more fluids to ARDS patient. Using more than 60% FiO2 for prolonged periods than few hours is contraindicated. Historical data does not support our practice of depending on antibiotics, antifungals or corticosteroids. Discussion with your team, review of literature and even consulting experienced colleagues from other ICUs may be rewarding. Never forget to treat basic disease. ECMO has a definite place in management of ARDS. However, its use should be considered only after the patient is clearly proven refractory. It must also be documented that disease of the patient is reversible. ECMO should not overplay into our minds when we are managing a case of ARDS. There is no evidence as yet to believe that ECMO be applied early in ARDS patient. Thank you very much. Basics are therefore precious and the best while managing ARDS.
Sir, thank you very much. The next topic says it's interesting ARDS case. And when I asked the speaker, is it case or cases? He was like, 6 minutes mein kitna hoga? So it is Dr. Vinod Singh from Delhi. He'll be presenting an interesting ARDS case for us.
Thank you, Dr. Mishra, and good morning to all of you. I am presenting this case because it emphasizes that ARDS is complex, one. And second is that it came very surprised to us in our department. So a 25-year-old primee of 33 weeks, and she got admitted to a local hospital with a complaint of headache and breathing difficulty, which started 1 day prior to her admission. And she also had a swelling of the both feet since last 1 week. Now, because she was evaluated there in the previous hospital, they found that the patient has got anemia, she had a preeclampsia, she has got a abruptio placentae and absent fetal heart sound. So in view of these findings, the emergency cesarean section was done under GA, and the intraoperative findings were the patient has got a moderate size of retroplacental clot, she has got a macerated stillbirth, and during the operation she had a moderate blood loss. Now, post-operative day, the patient developed severe hypoxemia. She has got a bilateral chest infiltrates and thrombocytopenia. She has a hypertension, which require vasopressors. And in this condition, patient shifted to our Gangaram ICU. The initial investigations were there, and the HB was initially 6, then 7, then 12 at the time of operation. And when she came to us, it was 11. She has a TLC of 16,000 and platelet count was 65,000. A rise in BUN and slight rise in creatinine. Bilirubin was slightly raised. INR was almost normal, and she has a urine protein 3+. The initial evaluation, when we did, we found that the patient was got a hypotension, heart rate was 132, and the patient has got a saturation of 90% or the FiO2 of 100%, and she has got a urine output of 50 ml in last 6 hours, and she was sedated, neuromuscular blocker, pupil bilateral normal size, ABSG was hyperlactatemia, metabolic acidosis, severe hypoxemia, high PCO2, and bicarb was 22, and 2D EF was around 26%, procalcitonin was high, 40, and the TLC count was 14,000. With this, we received the patient, and this was a chest X-ray which we received in our intensive care unit. Patient has got a bilateral infiltrates. So we kept the possible diagnosis routinely. The patient might have peripartum cardiomyopathy with pulmonary edema, septic shock with ARDS, HELP syndrome, postpartum HELP syndrome is a well described, or quite possibility of TRALI also. Now what happened, the patient treated with the septic shock and ARDS, patient started on meropenem, and we proned the patient, 3 times proning, and after 3 times proning the oxygenation improved, the patient was vasopressor also stopped with the meropenem and all the antibiotic, and she was got supine on 6th, and chest X-ray was still having infiltrates. However, we brought the patient on the CPAP, and the patient's FiO2 was 0.6, and patient was on RRT for the renal failure. But what we found that the patient has got a persistent low platelet count, and she was having low hemoglobin, a high LDH level in such case, and there was a mild elevation of the hepatic enzyme also, and still the patient has got a renal failure for which she was in RRT. If you look at the table, you find that from the 3rd of the 3/10 up to the 11th, the patient has got a low platelet count. It was 40,000 on the 11th, and also HB was decreasing. And if you look at the LDH, it was high in our case, just 1225, 1225. So, and LFT also was started deranging. It was 2.29 from 1.52, and also OTPT has also increased slightly. So we did a peripheral smear examination, and to our quite surprise, we found a lot of fragmented cells in the peripheral smear, and also reticular count was high and low platelet count. And the cystocyte index was 7%, and there was a thrombocytopenia in peripheral smear also, and there was no any toxic granules in our patient. So we thought the patient is suffering from a postpartum thrombotic microangiopathic syndrome, which is quite rare, but has been described in pregnancy patients. So we started the patient on plasmapheresis on 10th of the October, and she received a 4 session of therapeutic plasma exchange. After starting, the LDH started decreasing, the indirect bilirubin also started decreasing, urine output started improving, or to our utter surprise, the chest X also started improving, and we were able to wean off the patient from the ventilator, and we extubated the patient from the ventilator. This was quite surprising to us, starting with the plasmapheresis. And we look at how the hematological parameters improved on the 21st and on the 20th of the October. The platelet has come to the 2 lakhs, and the HB has increased to the 9.3. And this is how the therapeutic plasma exchange helped to our patient by improving the HB and cystocyte index. And we shifted the patient, 2 more slides, and shifted the patient to ward on 21st. And that time the ADMTS 13 level activity came. It was quite low, less than 10%, and the antibody was also quite low, which was more than 40% in our patient. Sorry. So we look at the literature, we found that there are cases which have been described, the thrombocytic thrombopenic purpura, the TTP, which presenting like ARDS in some patients. And if you look at, there are, this is the largest number of series where almost 56 patients were analyzed, and they found that 7 patients has got ARDS and 4 received therapeutic plasmapheresis, and they improved. And so it is recommended in this study that those patients of ARDS who has got a persistent thrombocytopenia should be evaluated for the TTP, and plasmapheresis should be given because it is a therapeutic in such patients. And also, this is very interesting and very important also, because at one time you cannot differentiate whether my patient has got a HELP, TTP or other thrombotic microangiopathy. So you should give it, the patient should be given therapeutic plasma exchange in such patients. Thank you very much for this.
Sir, just 1 second, sir. Thank you very much. That was really interesting. We have time to take 2 questions. If
so, any question I will answer.
So, if anybody has a question or a comment to make on this particular interesting case. Madam has.
Ma'am, I have just focused on the ARDS because the patient has got a headache and preeclampsia also. She was separately treated for those things. Because I have only 6 minutes, so I have focused on these things also. But it was quite surprising the patient responded to plasmapheresis to us.
Okay, so I think we were not prepared to ask questions. Next we have another, thank you sir.
Thank you.
Next we have another interesting case on ARDS by Dr. Raymond Xavier from Chennai, and we'll have 2 to 3 questions after he presents his case. Thank you.
Very good morning to everyone. Feels great to be a part of this historic occasion. Thanks to ISCCM, thanks to all the organizers, and thanks for my 6 minutes. So I don't have anything too rare like what Dr. Vinod just impressed us, but rather I'm going to talk about something. I'm just going to quickly discuss, no numbers, no figures, no labs, nothing. Just tell you about something which is becoming increasingly common these days rather, okay. So I come from a background of a cancer hospital, and so it goes without saying ARDS in immunocompromised. Do you think in different ways? Is it the same as treating your regular immunocompetent host? Okay, so a tale of 4 to 5 weeks in 5 minutes. Good luck to me, good luck to you as well. So of course there's a lot that I need to keep telling about this. Basically, or in short, a young individual, no comorbidities, was evaluated for some sort of a back pain, lands up having an MRI, there's a lesion, he comes to us for a PET scan, which shows FDG uptake all over his body, multiple nodes, bones, vertebra, pelvis, sacrum, all over everywhere. There was a CT guided biopsy which comes up as a follicular lymphoma grade 1. It is stage 4 naturally. He was commenced on local RT for the disc lesions, and then he was subjected to the first cycle rituximab, went on really well. And then he had his second cycle with bendamustine, not going into too many details of those. Now what brings him to me is a little bit of shortness of breathing, about 3 weeks away from the second cycle. That's roughly when they also start manifesting some of these chemotoxicities, 2 to 4 weeks roughly. So he comes to us with shortness of breathing in the ER, where, you know, typically he's otherwise okay, excepting for profound hypoxia, which seemed to be manageable with an NRBM at that time in the ER, and then he was rapidly shifted over to the ICU. So there, you know, there's a catch about NIV for the use of acute respiratory failure in immunocompromised, okay. Nowadays, we get so many of these young individuals, no comorbidities and treatable or conquerable cancer. So I don't know if we still think of NIV in immunocompromised as really, you know, something that you need to still vouch on. If it is ARDS, if it is anything more than mild, you really cannot still be holding on to this. Time to revise our concepts. Of course, this fellow was started on NIV. We realized that he wasn't doing well. Pretty soon we were able to intubate him, and then typically after intubation is when all our problem starts. And he lands up getting multiple prone sessions. He was tracheostomized on day 9. I have a catch over there. We were able to switch him over to BiPAP assisted breathing within 2 to 3 days from the day of duration doing the tracheostomy, which came as a surprise to me. We were able to actually decannulate him even before discharge. We discharged him with some amount of proximal myopathy going on over there, but he is recovering very well. Okay, now the first X-ray, what you see over there, looks more like the bat wing opacity, maybe cardiogenic pulmonary edema. How many would already feel that it was ARDS with that X-ray? Of course, it's short duration, hypoxia, all those new global definition. How many would classify him as ARDS at that time? Yeah, so you can talk so many things. That's how PCP or PJP also presents. That's how so many of the viral pneumonias present, cardiac failure. But it can be ARDS as well. Naturally, so the second X-ray is after intubation, and then it just becomes very, very progressive. Now, the point for discussion here is his nasopharyngeal swab respiratory viral panel picks up adenovirus. How many would treat this? See, this was done in the ER itself. So we get it, it was done early in the morning and we got it by evening. How many would treat adenovirus here with a nasopharyngeal swab? Nobody? Okay. That's what we do in immunocompetent individuals, isn't it? But we were in a dilemma, okay, this guy is treatable, potentially treatable. Okay, we wanted to treat, but the treatment of choice happens to be one of the most nephrotoxic antiviral drugs. Cidofovir is a drug of choice, okay, carries 20 to 30% risk of nephrotoxicity. So we did, of course, we started him on other empiric antibiotics, PJP treatment. We wanted to cover him for CMV as well, but we didn't want too much of drugs over there. So we hadn't started Cidofovir by then, but PJP was started. We went on to do a BAL. Again, doing a BAL is not a joke in patients who are being ventilated with such tight lungs, very poor oxygenation. We actually did a BAL in his prone position. We quickly got him over to prone, and the BAL had to be done desperately in prone. We were so thankful that we did the BAL. We got all these things. So PJP was positive, CMV very high viral load. Interestingly, the BAL adeno was not detected. Now would you still start, we were still not convinced, because adeno in somebody with immune compromise, although we have recovered CMV, although we have recovered PJP, you need to be extremely careful. We didn't stop there. We went on to doing blood levels of viral DNA, and that picks up adeno. So now where is this adeno? But it is there in a sterile fluid, so there is no question you need to treat it. Just based on a viral panel, probably you wouldn't, but once it is there in your serum, you don't have a choice. The serial progression of X-rays. Day 9, I thought, quite often we see these ARDS people staying on with us for so long. So I just took a bad call probably. He was just coming out of his proning stage. I thought this guy is going to take another week or 2 or 3. Let's go ahead with a tracheostomy. And I don't know what did the magic. In 2 to 3 days, he just started turning around. And I was like, was I right, wrong about the tracheostomy time? Anyway, that's different. So he was a prone, he was doing good on prone. But then we had to do multiple sessions, 5, 6 sessions, and at least 20 hours of sessions each. The usual, the rest of the things, of course, we had problems with deep sedation, the requirement for country. When he required, he was like, hey doc, that's you. I could constantly hear you talking, chatterboxing around me. Okay, that was under deep sedation. So how do I monitor these guys? So there are so many things that I would like to highlight in this case. Of course, there are still people who ask us, is this pneumonia or is this ARDS? How do we answer them? Fine. And again, paralyzing. Now people have started using less and less of paralysis. We want to limit to lesser duration. We want to use only deeper planes of sedation without paralysis. That comes with a hemodynamic challenge. All those things. It looks like a discharge summary which says patient had ARDS and he was treated appropriately. I was like, oh damn, come on man. That was a struggle. Right? Likewise, prone. By the 4th day, we were thinking if we were still doing the right thing. 20 hours prone each day, and then he started developing some amount of pressure ulcers. That was when we were considering other options, but luckily he started turning around. Steroids, I'm not a proponent for ARDS, but luckily we landed up using it for PJP. I don't know if that helped with the ARDS, but again, using steroid in somebody who also has a CMV and an adeno going on over there, that was a big trick over there. Adenovirus has to be treated in patients who are immunocompromised. Cidofovir is the drug of choice. It carries a nephrotoxicity of up to 30%. It has to be given a lot of volume preload. This is a guy, sorry, just one more minute. This is a guy who 100 ml cumulative balance over 1 day, he starts decompensating, okay? And then the ID was like, no, you have to give the preload. So we discussed with the family, it's okay if he goes on to dialysis, but I'm not giving that fluid. We were just about fortunate. So Cidofovir was there. IVIG was used in him, especially because adenoviral diseases are known to cause significant hypogammaglobulinemias, which can impact the recovery. Okay, there's a lot of evidence that's just about coming up. You don't expect a big RCTs, and then the usual lung kidney tug of war. Tracheostomy, again, I don't know. Should I have just waited and directly extubated him, or was this something that actually helped him come out quickly? And yeah, we were fortunately able to discharge him after a 20-day admission period on cotrimoxazole, and valganciclovir, which is a lot less toxic and can be taken oral, is what we switched over to for CMV. We were able to follow him up in the OP, and there were 0 copies of the virus. And he could quickly resume his treatment. What you see, the first one is a PET scan showing extensive FTG uptake all over everywhere, including his, the first one on top is the dorsal vertebral column, and then you have the pancreatico-abdominal, and lower down you can see in the sacrum, the ilia. That's the one that was done last. There's practically nothing, and he's happy. In fact, he wished me good luck for today's presentation. Thank you. So there's more than just ventilation. Thank you. I may have exceeded the time for questions.
No, we are still asking you questions. Any questions from the audience?
So how many treat adenovirus? How many would like to treat adenovirus in immunocompromised? Maybe. Not even after this presentation.
Thank you, Raymond.
Thank you.
Next, we have Dr. Rajesh Chawla from Delhi. He shall be discussing with us, sharing his experience with ARDS. Sir.
Thank you very much. So, I love treating ARDS because for last almost 28 years, we've been treating ARDS, and we have seen the changes in the management of ARDS. I love ARDS because you do a thing and you find the change immediately. It is like a mathematics. It's very exciting. So, 1996, that's the time when Apollo opened, and we started doing ARDS management a little more. And all patients at that time were being ventilated with traditional tidal volume. And it could be 10 ml, 12 ml, but it was most of the time the aim was to normalize the ABG. Most of the patient would be sedated and paralyzed. And pneumothorax was common at that time. Mortality used to be very high. And most of these patients, when they used to come out, they would have critical illness neuropathy. And they would take very long time to go home. So that was in the early 1996. Then, we've been doing this, and then in 2001, when the ARMA trial was published, and after that, people started reducing the tidal volume, and we were not aiming for normalizing ABG. We were tolerating the pH of 7.2. There was permissive hypercarbia we were tolerating. And PEEP at that time, it was arbitrary most of the time. And then even now, we really don't know which is the best method to give PEEP in these patients. And later on, and even now, ARDSNet table, I find, is the best way to set PEEP in these patients. And we were very particular about the plateau pressure, keep it below 30 centimeter of water all the time. And mortality got better in these patients. And there was less number of patients who were developing critical illness neuropathy. In the same years, the sepsis guidelines got published, and the management of the primary disease, which was resulting in ARDS, got better. The management of infection in these patients, ventilator-associated pneumonia, and all these got better, and the survival in these patients improved. And that was a time when we were using NIV in COPD patients or cardiogenic pulmonary edema. But this was the time when we started using non-invasive ventilation in ARDS. And the problem we realized late, and then a lot of publication also occurred, that when you ventilate, it gives you a false sense of security that you are maintaining saturation, and in that process, you ventilate them late. And the mortality in those patients is very high. And towards the 2005 and 6, we started proning patients, and that made a very major difference in outcome of the patients. And then in 2009, when the H1N1 pandemic occurred, we got to treat a lot of ARDS patients. And in these patients, we were using NIV more often. That time, the HFNO was not there, so we were just using non-invasive ventilator. And barotrauma also, even in those viral infection, we saw quite often in these patients. And I remember a lot of patients, I had to put 2-3 intercostal drainage on one side because the lung was such that it would not expand. And then eventually, like COVID, this was also a regressive fibrosis, and all of them got better. And this was also the time when we started using the recruitment maneuvers and started proning even early. You know, that the moment the patient FiO2 requirement would be beyond 0.6, we would prone them early. And this is the time I bought the high frequency ventilator, but I was never happy with that. And in the same time, OSCAR and Oscillate trial were published, and sort of this machine is still lying there without being used. And that is the time we used the ECMO for the first time, and not a very good experience, but that was the first time we experienced with these patients. And the another thing which I learned during the H1N1 pandemic, have patience. Don't be in a hurry. Treat the ARDS length like a baby, because if you try to hasten up things, these patients do not get better. Just keep maintaining your infection control practices, do a safe ventilation, these patients would get better. And you know, as I was saying, the proning we started doing, this is a patient currently with us. This is a patient who was on a FiO2 of 0.8 and not maintaining saturation beyond 80. And he was on the norepinephrine of about 10 mics per minute. So one would think that he's on hemodynamically unstable, we should not prone him. But most of the times, I don't care about that, because that is the thing which will make a lot of difference, even if the vasopressor requirement goes high. So we prone this gentleman, and as you can see on the right side, this is the X-ray today morning, there is some recruitment that has occurred, the FiO2 has come down. So before jumping onto the ECMO, a lot of people present cases where they jump onto the ECMO without proning. And proning is something which has really made a lot of difference. And the another thing which has made a lot of difference is the mobilizing patient. None of our patients in an ICU for last 15 years is extubated without being mobilized. If he is on a ventilator for more than 2 days, they're all mobilized to the chair. And I hardly see a case of critical illness neuropathy. So one should have an aggressive mobilization policy in your ICU. Keep them dry. That is what I learned. Initially give them as necessary, because you have to maintain the blood pressure if they are hemodynamically stable. But then you keep them dry, and the FiO2 requirement would be low, and also care about the peripheral edema. You know, I remember Dr. Ram Raj Gopal used to say that you have to swell before you get well. But you know, extubation or weaning off becomes much easier if the chest wall edema and peripheral edema is less. So keep them dry, lung should be dry as well as outside if you want them to get better faster. We published also about H1N1, and we found that low PF ratio at admission and 24 hours later and higher PSCO2 at admission and use of steroids were associated with bad outcome. You know, H1N1, the steroid had a bad outcome. And it is only after COVID, the steroid have become a prime time, and now everybody's talking about steroids. We should be using steroid early in ARDS. This is another paper of non-H1N1 we published in year 2016, and we found that if the low PF ratio, shock, ARDS severity were the main determinant of using the non-invasive ventilation in patient of ARDS. And it should only be used in mild ARDS. The moment PF ratio is less than 150, please ventilate. Even today, even during COVID, I ventilated all patients the moment the PF ratio was less than 150, although many of the consultants used to object that you should not ventilate. But I feel you should rest these lungs, they are injured lung, and treat them nicely and they will get better. Then in COVID-19's, NIV and HFNAC delayed intubation. They were equally effective when there is hypercarbia. NIV is probably more effective. We are running ahead of time, so give me 1 or 2 more minutes. Thank you very much. Tolerate hypoxemia. Anything more than 80 is good enough. Do not aim for something like 93, 94. If it is more than 80, the COVID has taught us nothing will happen to the patient. You can give multiple prolonged session of proning. All of us have done, and this is what I learned from COVID. Steroid work in these patients, but give for short periods. Because, most of the study, they say that you should not give for a long period, probably along with sepsis, multi-organ, amikacin, and the neuromuscular blocking. This is a very important risk factor for critical illness neuropathy. So this also taught the low tidal volume strategy should be followed. Barotrauma can occur in spite of lung protective ventilation. Keep them sedated and use neuromuscular drug for 24 hours. Have patience. I'm saying repeatedly because don't hurry, treat them. And another thing which I've learned is COVID resulted in a regressive fibrosis. All patients, I have now 40 patients whom I ventilated. I have followed, I have the PFT of those patients. Spirometry has totally become normal. They had absolutely white lungs. But DLCO in most of them is still affected. And when they get sick for another illness, then they get little more hypoxemic than the other patients. This is an editorial we wrote down with a similar conclusion in ISCCM. So just to conclude, the treatment of the primary disease is more important. That's what I realized. You need to be a good physician. If you are not a good physician, ventilating with lung protective, ECMO, all this is not going to fail. Treatment of the primary disease is the most important. NIV and HFNO can be used, but have a low threshold for intubation. PF ratio less than 150, please intubate. Even if patient is appearing all right, family is happy, primary doctor is happy, SPOT is maintaining, please intubate. They will do better. Paralyze them for initial 48 hours. If not required, if patient is better, 24 hours may be enough. Steroid should be used early, but for short period. Because many a time, 3 weeks, 4 weeks, people were using steroid in COVID patients. Follow lung protective ventilation. PEEP, you can use the ARDS-net table or a best compliance. Avoid recruitment maneuvers after the ART trial, and you should only use very, very rarely. You've done a bronchoscopy, saturation is affected, only on those conditions. Prone them early, and do not put on ECMO before giving nice proning sessions. Have good infection control, because you need to have a good infection control if you want to save this patient. And ECMO, I feel, you should not do sporadic. Everyone says I have done ECMO, 2-3 ECMO in a year. Best done by expert doing routinely. If you feel, then if patient can be transferred, transfer that patient to that center. Thank you very much.
We may take a couple of questions if there's any.
Thank you, sir. Thank you for your sharing your experience. I'm Dr. Nagesh from STM. Keeping cool, that's the most difficult thing what we can do when we are managing the ARDS patients. My question is directly like a patient taking a large breath. How you will tackle this? Because whenever we try to mobilize them early, that we end up, the sedations will be on the lower side and they take breaths, many a times a huge breath. How do you do that?
Many a time people take large breath if he's having pain. The basic principle of any ventilation is you need to give them analgesia. So they need to be on a fentanyl or something like that so that their pain is managed. If he's taking large breath, probably he's not ready for mobilization. Because, people in COVID-19, initially they had a very high respiratory drive. They were taking liters of, you need to stabilize that. You need to see that patient is not having a high respiratory drive on lying down and his pain is being managed. He's conscious. Do you follow move. That means patient is mentally stable, he is off vasopressor, he can verbalize with you, then you move a patient and his myocardium is stable, M stands for that. So then you mobilize them. But if on lying down on a supine or in the bed patient is not stable, please don't move them. Only after you find that he is stable, then only move to the chair. And your system, our people are so trained that I ask them, I'm seeing the next patient, this patient is mobilized. So that's how, and it is just a practice, and your department, sisters, everybody knows how to move them. They have devised the system how to move them to a bigger chair. And always have a bigger chair, easy chair, so the patient can, because it gives the confidence to the patient and to the relatives also that the patient is probably being taken care of well.
Thank you, sir. If I can extend this to ECMO patients also, there also that the problem becomes very difficult because how much sedation and paralytic agent for how many days we will use. Here the tidal volume also does it's very difficult for us to control the tidal volume. I can talk to you later, sir.
Yeah, all right.
Thank you.
So hemodynamically unstable means how? Like 1 pressor, 2 pressor, like how much?
You know, it is your assessment. If patient has come, naturally he takes the first 24 to 48 hours the patient takes to stabilize. Now this patient, he was on a 10 mics of norepinephrine. When we prone him, he told me it is 18. So I didn't bother. Okay. And today morning it is 5 because his oxygenation got better.
Okay.
And you have to see, you know, many a time we have to do supine also once in a while, but many a patient is on a vasopressor and the physician will not prone. Please don't do that. Because, you know, if the hypoxemia keeps on worsening and then you start thinking of ECMO, probably proning is, I feel, is such a good thing which has happened to ARDS and it has saved many, many patients.
So 10 mics.
And I think it was started along with Dr. R.K. Mani, who's sitting here, Dr. R.K. Mani, and we were together. And I think in year 2002 or 3 we started proning.
So we should not be afraid of 10 mics or 15.
Yes,
Thank
that
you,
is
sir.
what.
Thank
Yeah.
you.
Thank you, sir. Thank you, Dr. Chawla.
Thank you.
Just a disclaimer, the timers and alarms are automatic. I have got nothing to do with them. So our next talk is about role of neuromuscular blocking agent in the management of ARDS. And I'm not going to introduce the speaker because she needs no introduction. Our ex-president, ISCCM, Professor Maitra. Madam.
Thank you. Good morning, everyone. And at the outset, I'd like to thank Professor Pradeep Bhattacharya and the entire ISCCM team for this innovative idea of conducting the first ever World ARDS Day, and also for giving me the opportunity to give a 15-minute talk at this symposium. I'm going to be speaking on neuromuscular blocking agents in the management of ARDS. I'm really proud to be a part of this endeavor of, the ESICM guidelines on ARDS, the definition, phenotyping, and respiratory support strategy that was published in Intensive Care Medicine in 2023. And you can see this was led by Professor Giacomo Grasselli and Caroline Calfi, both of who are part of this program, and it was a great honor for me, and it was a great learning experience working with such doyens in the field of ARDS. And I was very honored to be given, to lead the section on neuromuscular blocking agents in ARDS, so I'm really happy to be speaking on this topic. Now, if you look at the previous iteration of the guideline that was in 2017, and you compare it with the 2023 guideline, you can see the areas which are red were where there was no recommendation available. The areas in green is where there is a recommendation, and the yellow ones with the star are where there is a new recommendation. And as you can see, for neuromuscular blockade, there is a new recommendation, and that is why this is quite interesting and important for us to know. Now, why do we use neuromuscular agents in ARDS patients? Of course, in ventilated patients with the ARDS, it reduces the work of breathing and patient ventilator asynchrony can be managed better, and it may affect outcomes. However, on the other side, as we all know, when you use prolonged neuromuscular blocking agent, it's also associated with neuromuscular weakness. It requires deep sedation, which in itself, as we know today, can have adverse outcome. So you have to have a balance, the right balance. It doesn't, just because you have the benefits, certain ventilatory benefits of NMBA, prolonged use can also be deleterious. And that's why this is a very important question to answer, that should we be giving continuous infusions of neuromuscular blocking agents? Now, just taking you back to one of the landmark trials in the use of NMBA with, in ARDS, and this was the ACURATE trial, Papazian, that was published in NEJM, and it was a study of 340, but that was considered as a very large trial at that time. And they used cisatracurium continuous infusions for 48 hours, looked at 90-day mortality and 28-day mortality versus usual care. They also looked at ICU-acquired paresis, and there was no significant difference between the two groups. And here, there was a significant difference, between the two groups, and you can see the Kaplan-Meier curves, and you can see the separation here, cisatracurium and placebo. There were smaller trials done prior to this, but this was the landmark trial that really changed our practice with the use of neuromuscular blocking agents. And what they found, and they used patients where these patients were severe ARDS, less P2F ratio, less than 120, and with the use of continuous infusions of cisatracurium for 48 hours, there were significantly more ventilator-free days and more free days from organ failure during the first 28 hours, and pneumothorax also occurred in a larger proportion of patients. However, the incidence of ICU-acquired paresis did not significantly differ between the two groups. So this was a finding, and this was really practice changing. And subsequently with this study, which was a large driver, and the two smaller studies that had been done prior to this, a meta-analysis that was done by Walid Al-Hazani looking at the role of neuromuscular blocking agents in ARDS, and this was a systematic review and meta-analysis. And this included the Garnier study and the Floral study, which were done in 2004, 2006, and of course the Papazian study, that's the ACURATE study. And these were the three that were included in the meta-analysis, and you can see the number of patients, 340 here, and very small studies prior. So this was really the main driver of this study. And if you look at the forest plots, you will see that whether you look at mortality at 28 days, or you look at ICU mortality, or you look at hospital mortality at 80 days, it definitely favored the neuromuscular blocking agents. And you can see that everything is on the left side of the vertical line. And the conclusion of this meta-analysis is that a 48 hours continuous infusion of cisatracurium bacillate for patients with severe ARDS reduces 28-day mortality, ICU and hospital mortality, as well as barotrauma, without increasing our concerns of risk of ICU-acquired weakness effect. And that actually changed our practice. And this is a very nice, flowchart from a French review that was published on the early management of ARDS. And if you look, a stepwise way of escalating your therapies. And if you look at the recommendation of neuromuscular blockade, and this is how our practice had really changed, we were using neuromuscular blockade agent continuously for the first 48 hours after intubation of these initiation of mechanical ventilation, and also, as Dr. Chawla said, during proning the patients. So this was really our practice until very recently. And you see that the ROSE trial that I'm sure you are all aware of, that was published in 2019, did a complete U-turn, and this was also published in NEJM. Similar kind of patients, moderate to severe ARDS, with a P2F ratio less than 150. They used higher PEEP, and this was more than 8 in the intervention arm. So continuous infusion of cisatracurium, 48 hours was the intervention arm, whereas the control arm was, without neuromuscular blockade and lighter levels of sedation. So if you look at this trial, it is more akin to our practice now. We don't deeply sedate patients. We've moved to more lighter levels of sedation. And when you use neuromuscular blockade, of course, you have to keep your patient at deeper levels of sedation because you don't want awareness. And they actually had to stop the trial in between at 1,006 patients, so large number of patients. And very interesting, and here you can see this intervention arm is in light blue and dark blue is the control arm. And this is the percentage of patients receiving neuromuscular blockade. So obviously, the control arm got less of neuromuscular blocking agent. And if you look at the percentage of patients at lighter levels of sedation, it was, of course, the intervention group had lesser, patients with lighter levels of sedation. Now, when you look at the outcomes, at 90 days, and this was for the patient's survival to hospital discharge, and the lower one was for those who were discharged home. One is ICU and the other one is discharged home at 90 days. You can see that there was no difference. So the trial by Papazian showing a difference between cisatracurium infusion given for 48 hours, and this study, the ROSE study that was done, showing no difference between the two arms. And if you look at between the two studies, of course, there were differences in the Papazian study. In both the arms, deep sedation was used, whereas here in the control arm, there were lighter levels of sedation. In the ROSE study, higher levels of PEEP were done. There were several limitations also in the ROSE study. It was not a blinded study, and several limitations were there. Nevertheless, a large study showing no difference in giving continuous infusions of 48 hours. So what were we doing in this new guideline? We were looking at answering this question, especially after the ROSE study had come in and completely showed different results. It was very important to look at the data and do a meta-analysis. So our PICO, that's a population intervention comparison and outcomes, was we looked at patients of ARDS, both with and without COVID, and we looked at the use of neuromuscular blocking agents, continuous infusions, giving it continuously, and no use of NMBA. And our outcomes were mortality, ventilator-free days, pneumothorax, and also the incidence of muscle weakness. Now, when we looked at 90-day mortality, as you can see, there are only two studies. That's the two large studies that were included, and there was really no difference in the 98-day mortality. When we looked at 28-day mortality, there were more studies included. We had the earlier Garnier, Floral, Papazian study, Givelli study, as well as the ROSE, the Moss study, that is the ROSE by Moss, by the ROSE study. And if you can see again, if you look at the diamond, it's touching the line of infinity, and there was really no difference in the 28-day mortality. Pneumothorax, on the other hand, there is a protection with the use of, across all the studies, you can see that the outcome was much better when you used a neuromuscular drug. So definitely protection against those patients who are at a high risk for pneumothorax. And when we did the overall quality assessment for the various styles, and here you can see the number of RCTs included when we looked at 90-day mortality or 28-day mortality, or even ventilator-free days at 28 days, the recommendation was against the continuous use of neuromuscular blockade, though it was in favor for patients who are at a high risk for the pneumothorax. So just coming to the recommendations for the use of neuromuscular blocking agents, the recommendation was that we recommend against the routine use of continuous infusions of neuromuscular blocking agents, as was the practice, to reduce mortality in patients, and this is of course in moderate to severe ARDS. It was a strong recommendation, but with moderate level of evidence. And in terms of COVID, we were unable to make a recommendation for or against the use of continuous infusions because there was no study done in COVID to reduce the mortality in patients with ARDS due to COVID. So no recommendation or no evidence because of lack of evidence in COVID patients. So the take-home message, of course, it's important to remember that this was a study, this was comparing continuous infusions of NMBA for first 48 hours. It wasn't saying that you don't use neuromuscular blocking agents. So though the routine use of continuous infusions is not recommended, of NMBA is not recommended, NMBA can be used, of course, in patients with ventilator asynchrony, proning, and for other specific indications in a more individualized way. The real message is that, earlier with moderate to severe ARDS, first 48 hours, we used to use continuous infusions of neuromuscular blockade, and that is no longer required, and there's no evidence for that. But it's really important because there are a lot of research gaps, and future research should prioritize other outcomes, and this is including successful extubation, reintubation, paralysis recall, ICU-acquired weakness, and also other health-related quality of life indicators specific to ARDS. And an important area of research is a recognition of the poor patient-ventilator interaction that we all experience, and this has potential effects on clinical outcome, and we all know that, and this may represent a possible indication for the administration of NMBA and has to be better studied. And most important, in view of patients and caregivers, their views should be central to determining what our future research priorities and questions and outcomes should be. So I thank you very much for your attention. I'm leaving you with the recommendations for the neuroblocking agent. Again, to repeat, we recommend against the use of routine use, remember routine use of continuous infusions of NMBA to reduce mortality in patients with moderate to severe ARDS, and no recommendation for COVID. And with that, I thank you very much for your attention.
Thank you, Professor Maitra. Any inputs, any comments?
Thanks, Sheila, for the presentation.
Good morning, Dr. Kilnani from Delhi. Sorry. Please. May I?
Yeah, Dr. Kilani, please.
Yeah. So, is it wise to give a blanket recommendation of not using neuromuscular blockers in your guidelines? Because there could be several variety of parameters like triggering, peak pressure,
right,
type of ARDS, etiology.
Yeah.
So can you give us some more finer recommendation as to when to use or not to
So,
use?
very important question, and that was the first point of my take-home message, that this is only, the meta-analysis was only comparing routine use of continuous neuromuscular blockade in the first 48 hours. It was not looking at occasional uses of neuromuscular blockade. So, there is a recommendation against continuous infusion. Nevertheless, there are specific indications, like you rightly said, sir, when there's patient ventilation, especially during proning, we all used a neuromuscular blockade, and certain situations where it's difficult to ventilate the patients, and those are the situations where we will have to use. But the guideline doesn't say that you don't use neuromuscular blockade.
Like something related to triggering, something related to peak pressure, something
Right.
related to plateau pressure.
Yeah. But an important point to remember, a lot of people just paralyze the patient because there's patient ventilator asynchrony, and that's not what we should be doing. We should try to identify what the problem was and try to alter our ventilator, modify the strategies so that there's more synchrony rather than just giving muscle relaxant and trying to
I think committee and
abolish.
fraternity should look into the finer points of use of this.
Right, thank you.
Dr. Kelani, in continuation, after this, American Thoracic Society has also published guideline. And this is the only guideline where they differ. And they have said, we suggest, Dr. Kelani, we suggest using neuromuscular blockers in patients with early severe ARDS. This is AJRCCM.
So
published
it was,
2024.
I know this study, and it didn't include one of the studies, this meta-analysis and the guideline, and it was pretty much at a similar time, but it was a weak recommendation. If you take these papers that have been published, including the rows and in the meta-analysis, there was no benefit of giving a continuous infusion. Yeah.
What do you
Yes,
think about monitoring the depth of a neuromuscular blockade in the ICU?
Right. So I think that's really important, especially, and we are recently, and Sharmili is also here, we are recently working on a guideline on this. And I think it's important, nevertheless, from a logistic standpoint, especially from a nursing standpoint, and also availability of the monitor for neuromuscular blockade, it can be a little challenging, but definitely if we could do that, I mean, it would be beneficial, especially because you're giving an infusion, but you're not sure, and you're just using clinical parameters to assess whether it's really working. And I think more importantly, the awareness is an issue, because we are using lighter levels of sedation, and people aren't using deep sedation when they paralyze these patients, and we're not sure how many patients really have awareness. Thank you.
Thank you. Thank you, ma'am. Our next speaker is a very senior intensivist, Dr. Manimala Rao from Hyderabad. Ma'am will be talking about the ventilatory strategies in ARDS.
Very good morning, and thank you very much for inviting me even at this stage of my life. And I give you all the very best to take care of your patients. Well, this particular thing is very commonly used, and this is to show the oxygenation is poor, because between the alveolar and epithelium and the capillary endothelium, there is only 1 micron difference, and now it increases, so the oxygenation is really bad, and you have a lot of inflammatory mediators which are coming, that causing the ARDS. And the Berlin definition, basically to find out how severe or mild or moderate, so that we can plan out our ventilation strategy. So when we are monitoring ARDS, you have to literally monitor, because as Dr. Chawla said, I very much agree with him, because you have to be a clinician at the bedside. So that is in everything. whether it is history, whether it is, the clinical outcome, whether it is whatever you are seeing. So the heart rate, the respiratory rate, the axillary muscle usage, SpO2 with higher and lower oxygen concentration, and you can take the SpO2 by FiO2 ratio, and in between ABGs. This is done in the emergency, and the PF ratios from ABG. The ETCO2 when the patient is getting ventilated. Sometimes we do get ETCO2 otherwise also. And of course monitoring the pressure, volume, flow and the IE ratio. So this monitoring many times we tend to, a little bit overlook, and that gives us all the problem. So, sorry, I think. Okay, so if it is a mild ARDS, we can always see what is the PF ratios, how is the patient looking, is the patient restless, what is the heart rate, respiratory rate and all these things, and the ABG. Then you can always try your NIV in that particular situation. But you have to be guarded about it. And then you see for an hour, is the rate, respiratory rate, tachycardia and things like that, patient is feeling better, then you can continue for an hour or two and then take an ABG. You can't just sit and say, okay, his saturation is improved, so I am happy. So suppose if you find there is any problem, then you may have to not to hesitate to intubate these patients. Because most of the time the problems are coming because we take time to intubate. Then suppose, sorry, where is it? Okay, now suppose if you have to intubate, you have to literally look at everything. Like usually we try to give either propofol, rocuronium or xylocord according to the body weight and intubate. Fix the tube correctly, because many times I see the next day the tube is down into the almost the right bronchus. Assess the tube placement with the ETCO2, and then sometimes it will be easy if you can sort of put a little 4% xylocaine into the, we have done a study which I will be showing in the end. Monitor the cuff pressure, very important. It should be less than, I feel 18, okay. After setting up the patient on the ventilator, start the infusion of fentanyl and cisatracurium. Because it is not possible when the patient is a severe ARDS. The pressures have to be controlled, the volume has to be controlled, and you have to control, otherwise they will pull the tube out. We know about it, but sometimes we'll only say because this particular thing said like that and so and so. But in the first few hours, you will require the, ventilation has to be done with the patient with a little bit of cisatracurium. Why do we select cisatracurium? Is because it has got a Hoffman degradation, and whatever the degradation products are not really acting on the neuromuscular junction. But if it is long, which is more than say 48 hours or 72 hours, you can have other problems with laudanacin. So these are another important thing which I also do is assess the airway column width when you intubate the patient with the tube. So once you know this one, at extubation that will be very easy for you. We'll come to that later. So what are the criteria for, moderate to severe ARDS, extrovert breathing, tachycardic, restless, sometimes they are, not answering to your questions or they are irritable, PF ratios less than 150, tachypnea and more than 30 per minute. Many times we think that it's okay, PF ratio is looking all right, but if it is 30 or 35, that means the respiratory rate, he is really struggling to breathe. So you have to understand that one. So this is I usually put them when there is a severe ARDS on 6 ml with pressure control ventilation and trying to keep the pressures around 22 to 24 and then see what is the amount of the volume which we are generating. And then we will also try to keep the respiratory rate to around 22 to 24, so that the ETCO2 is maintained in the normal level. And then you increase I usually put them on 1:1 ratio. So what is it in ARDS? You have got hypoxemia. So you want a little inspiratory time. If it's more, it is giving a little more time for the exchange to go into that. So these are the various things. And then in case the inverse ratio you have to go, then you will be seeing the ABG in another hour or two. Then you increase the ratio to 2:1. And if the patient is doing better, you continue and then you do whatever is necessary for the patient. But if in spite of all these, you still it's not improving, then you have to prone. There's no point in wasting time. And I very strongly believe in proning, because we have seen the proning had helped a number of patients and they come out much better. But the time to proning is in your hand. Don't keep on listening to, nahin, thoda der mein karenge, uske baad mein dekhenge. All that is not going to happen. You have to have a definite protocol and see that you do it in the proper perspective. So that is for the proning. And then you do, within about 12 hours, you are still not able to, and then you have to prone. And the proning is also, I mean, this is what is the usual thing they say, how you go ahead with each thing. This, everybody knows about it. So what is the prone ventilation? It has definitely shown some mortality benefit. Early proning is beneficial, don't waste time. 16 to 18 hours to prone, and take a time in such a way that when you come back to work in the morning, the proning is done at that time, and when you are going back from the work, again you reprone them. So that is, you can put a good team and do everything which is in a very religiously in a correct methodology, so that you don't have. So usually you do proning for about 3 to 4 days, and by that time you should see that there is improvement. You know it. Once the improvement is there, there is definitely you can go ahead. If there is no improvement in about 4 or 5 days, then you have to think about ECMO. So these are then from the day you put any patient on ventilator, we always say you have to be weaning. So what are you weaning? Weaning the FiO2. So that is what is the usual thing which we do. And then if you are having the pressure control and inverse ratio and PEEP. So these are the 3 things which you are trying to keep in a proper perspective, and then slowly wean one after the other. FiO2 only up to 0.6. I don't go down, because you don't have to worry that it will cause some oxygen toxicity. Then you start weaning your pressure, then you start weaning your PEEP. So this is how you can go ahead, and the respiratory rate you can see, and then slowly go on to, you are anyway on the assist control. So finally I do the PEEP is the end. So finally you come to pressure support and PEEP. Many times I come to the minimum pressure support of 10 to 6. So if the patient is able to manage on 10 and 6, I think he can manage on the NIV for a few hours. So usually I don't take a completely put him on a, on the tube, giving him more difficulty and he is more awake. All these problems are there. So you can wean and extubate after again doing a air column width. If it is less than say 0.9 or 0.8, then what you have to be is give a little bit steroid and then again do it and extubate in the morning. Otherwise, you will get a stridor. We have done the most of these studies, so that's why I am able to tell you. And once you plan extubation, and then finally, if nothing is coming in this 4 or 5 days, then you have to tell people who are doing the ECMO, if you are in your place only they are doing, and you have a good team for it, then we will go ahead and ask them to do that. So these are the various trials. Trials will come, trials will go, but most of the time, sometimes the trial may give you something very beneficial, but sometimes it may give you something which is not going to give you anything much. You will, in a sort of a discuss whether should I do it or whether should I do not. So like the same trial which is neuromuscular, I think the first 24 hours you have to give in a patient who is severe ARDS. Otherwise he'll pull the tube, again you have to do all the things again, okay, and you lose what you have gained. So for about 36 hours, you can slowly bring down this one, and then usually I use, if the blood pressure is okay with the patient, a small dose of dexmedetomidine, so that it is not, it does not give delirium, it does not cause many of them, and then you can have light sedation, you can talk to the patient, and that is how we can manage our patients. So I just want to say that over a period of times, even when I was at NIMS in 2000, so we had about, total number of cases in that particular year, about 625, ARDS were about 80, and sepsis ARDS was the highest as it is, and in severe ARDS, the mortality was about 40%. And in the trauma ARDS, the minimum mortality was there. So this is how we could sort of manage the patients, but in that time, we did not have the pressure control or inverse ratio, all these things. I think just the 6 ml tidal volume just came in around 2000, this thing. So this is a data which I had from Yashoda Hospital where I worked. So you have mild, moderate and severe. Mild, of course, you can always get a mortality of 14%, and ARDSNet trial showed about 27%. So I think what is most important is how you are going to take care of the patient, monitor the patient, look at each and every step. Make the students sit with them and write down and then say, this is what you have to note down. So what is the point in telling fast hug? Unless you monitor every day, at least in the morning and evening, I don't think it makes any difference at all. So moderate and severe, this used to be our this thing. So these are all the references, like the installation of 4% prone position in H1N1 patient, laryngeal seal. Yeah, it's over. These are all oxidant stress. We have done a lot of things, and I published in the various journals because I had a lot of interest in this ARDS. And thank you very much for asking me to share my this.
Thank you so much, Professor Rao. I invite 1 or 2 questions, and I think the questions are ready.
Ma'am?
Yeah?
I am Dr. Sanjeev from Patna.
Yeah.
Actually, I just want to know that you have installed the cuff of the endotracheal tube with the 4% lignocaine. So is there any added advantage of the?
Yeah, what is the most important thing is this 4% lignocaine. We did a study in about 100 patients who had 4% lignocaine, 100 patients who did not, only had air. What I found was there is a little bit of this thing leaks into the trachea, keeps it a little, anesthetized there, okay? And then the amount of bucking on the tube is less, and also the amount of sedation which you are giving. This is what we found. So I use it because I have done that study.
But it is the inside the cuff, so how it will be the any benefit?
There is a, you can please go and read my this thing. It just goes out.
Okay, thank you.
It diffuses.
Thank you.
Thank you so much, ma'am. We move on with the day's sessions, and I've taken over from Dr. Vijay. We're moving on time. On this International World ARDS Day, apart from the many international faculty we have with us, we also have 4 special messages, and the first one that we will be putting up on the stage, on the screen now, is from President-elect ESICM, Dr. Jan de Wil. He is a full-time professor at University of Ghent in Belgium. Professor
Dear
Jan.
colleagues and friends at ISCCM, congratulations on organizing the World ARDS Day celebration. ARDS remains a significant challenge in intensive care, impacting countless patients worldwide. This day marks an important milestone in raising awareness and enhancing collaboration within our community. ARDS management has evolved significantly over the years. Our understanding and approach to ARDS continue to improve, and research has been pivotal in driving these advancements. I'm happy to see the collective efforts of our global community making a real difference. The European Society of Intensive Care Medicine has been at the forefront of promoting research and education in ARDS. Our recent ESICM guidelines offer comprehensive recommendations for the diagnosis and management of ARDS, reflecting the latest evidence and expert consensus. These guidelines are an essential resource for clinicians worldwide. However, there is still much to do. Future directions in ARDS management include personalized treatment plans based on individual patient profiles and leveraging cutting-edge technologies like AI to predict outcomes and tailor therapies. International collaboration is crucial to advancing our understanding and treatment of ARDS. By working together across borders, we can share knowledge, resources, and innovations to improve patient outcomes globally. Intensive care requires specific skill and competencies, and it is vital to recognize the specialized nature of our fields. Multidisciplinary collaboration is key, and I encourage all of us to continue working together, pushing the boundaries of what we can achieve. Thank you to ISCCM for organizing this important event and for inviting me to share my thoughts. Let us use this opportunity to recommit to excellence in ARDS care and continue our journey towards better outcomes for our patients.
Thank you so much, Professor. As we have been hearing about some of the most important management principles of ARDS, I next invite Dr. Shubhal Dikshit from Pune. He needs no introduction, and he will be synopsizing the management of ARDS, the 10 commandments thereof.
Thank you. I'll be not talking anything different. This is a paper which I found out, and this was excellent publishing in Journal of Intensive Care about a couple of years ago by late Professor Pelosi. And really he summarized the whole management of ARDS into just 10 points into it. The first one, he said that when a patient of ARDS is there, definitely it's a syndrome. You should know that it's caused by inflammatory response, which could be caused because of a bacterial, virus, whatever region it is. It is usually associated with altered vascular permeability with increase in the water content, and there is severe gas exchange failure with acute onset of hypoxemia. So depending upon this, he came up with the Berlin definition. There was again the modified Berlin definition which came up, and they helped us to classify it into the mild, moderate, and the severe form depending upon the PF ratio, what we all of us monitor. So the first rule, what Professor Pelosi and Denisi Belgatti in the paper, they said that help us to classify the severity of the disease in what you are really dealing with, whether there is associated fluid load from mild, moderate, and severe. The second rule itself is the tidal volume, the plateau pressure and the driving pressure. They have come up with concepts into it that yes, everybody of us, normally the conventional ventilation we used to start off with 8 ml, 10 ml to 12 ml per kg body weight. Various studies were taken into consideration and much has been seen what were the detrimental effects what they saw whenever they use high tidal volume in patients of ARDS, and they conducted a multi-center randomized controlled trial, and this trial after enrollment of almost 860 patients had to be stopped early because they definitely found that all patients of ARDS giving low tidal volume was much more beneficial. So lower tidal volume is the key, that is about 6 ml per kg body weight. Definitely we titrated to using the baby lung concept and sometimes even go down below to about 4 cc per kg body weight. They have also come up that you always monitor the plateau pressure, see that the plateau pressure does not go above 30 centimeters of water, and there is a new concept which is a driving pressure, see that it remains between 12 and 15. That helps us really to avoid the villus injury or the physician or the ventilatory associated lung injury. The third point is a much debated point. The PEEP, all of us know, is an essential component in the ARDS management. All of us know the beneficial effects of PEEP, that it helps for alveolar recruitment and also for reduction in the intrapulmonary shunt and helps us to improve the arterial oxygenation, and this is very important. Various studies were done where the low pressure volume, the pressure volume curve, the various CT scan indices were taken into consideration as to what is the best optimum level of PEEP which was there. Various studies were also also done by Amato and all, even Gattinoni worked into it. But the current guidelines were seen that reserving high PEEP only for patients with moderate or for severe cases of ARDS and avoiding it in the mild cases. The exact best PEEP is not yet optimized. You cannot define the best PEEP, and really it needs to be individualized from a case to case and every patient to patient, because the PEEP is beneficial. Recruitment maneuvers, we have just heard in the talk that yes, it is a fascinating concept. There have been the recruitment maneuvers of using a high PEEP for about 20 seconds or 45 seconds. The recruitment maneuvers, all of us know, they decrease the intrapulmonary shunt, they improve the oxygenation as well as the compliance, and thus they are mainly considered as a very open lung approach concept in mechanical ventilation. Mind you, you must always remember that whenever you are using recruitment maneuvers, a hemodynamic stability really needs to be ensured, and you should also avoid over distension, but using it very judiciously can sometimes be beneficial, but the hemodynamic effects and over distension, what it can cause, really that can be caused at electrotrauma, and they can be detrimental. Fourth, Sheila just covered the use of neuromuscular blockage effects. Yes, all of us, we know that ARDS is a disease which require aggressive ventilation. These patients really need to be inhibiting, we need to ventilate them completely by inhibiting the active breathing, and therefore using neuromuscular blocking agents in these patients is mandatory. Neuromuscular blocking agents reduce the patient ventilatory asynchronies, the oxygen consumption, and they increase the further compliance. The functional residual capacity increases, and the regional distribution of the tidal volume is better, resulting in the anti-inflammatory effects. They also play a very critical role in limiting the de-recruitment and maintaining the PEEP, and thereby reducing the fluctuations which are occurring by the strong inspiratory effort of the patients and the alveolar collapses which are there. But most important side effects you must see is the muscular weakness, which can be detrimental. So therefore, interruption of sedations or early morning interruption plays a very important role. You should monitor it and use it very judiciously, what we have just heard from the previous speaker, and you should try to get out of it as fast as possible. The sixth is the assisted ventilation. The spontaneous breathing has got favorable effects such as reducing the wasting of the respiratory muscle and improving the oxygenation compliance, and therefore it is much more reasonable to maintain the patients on continuous there and neuromuscular blockade. And for controlled mechanical ventilation, try to use assisted ventilation as early as possible and fast. Proning, Gattinoni has shown that yes, the trials are being beneficial. All of us know that proning is beneficial. You should prone for as long as possible, and taking into consideration the hemodynamic side effects, and also a good patient care is important for all patients, and they improve oxygenation and they'll help us to reduce the oxygenation requirements or delivery of oxygen to these patients. A proper care is required, and selection of the patient is important. Rescue therapies have been tried, but these rescue therapies have got a plus or a minus effects. Again, selection of these rescue therapies really need to be taken with a pinch of salt, and they are not much beneficial. ECMO patients, the trials have failed to demonstrate a significant difference in a 68-day mortality between ECMO as well as a control group. So again, selection of the patient and the selection of the right patient is very, very important in ECMO. And once the patient is quite stable, you definitely, once the cause of ventilation is there, you must definitely try to analyze the patient to wean off from mechanical ventilation as fast as possible. And weaning definitely has to be categorized, but it can be simple, difficult, and it has to be prolonged, and it has to be protocolized, which is very important. Thank you very much.
Thank you so much,
Thank
Dr.
you.
Dixit. We will move on to the next lecture.
Okay, thank you.
Thank you so much. So many treatment strategies for ARDS. Next, we will have Dr. Patricia Rocco, who's professor at University of Rio de Janeiro. She has a lot of work and research on management of ARDS, and she'll be talking to us about pharmacological therapies for ARDS.
First of all, I'd like to thank the committee for the invitation. And today we'll talk about the pharmacological therapies for ARDS. I have no conflict of interest related to this presentation. ARDS is a syndrome and not a disease. and since the first definition of ARDS in 1967 until 2023, all pharmacological therapies were developed according to the inflammatory process, damage of epithelial and endothelial cells, increased the pulmonary vascular permeability, oxidative stress, and fibrosis. So as you can see here, all these drugs that were developed, and for instance, in this case, to reduce the inflammatory process, to repair the epithelium and the endothelium, to reduce the fibrotic process. Corticosteroid was initially used in order to reduce the inflammatory process as well as the fibrosis. And they used in high dose at 30 milligrams per kilo and observed no significant difference in the mortality rate comparing methylprednisolone at high dose at the early phase of ARDS with placebo. And then they decided to use methylprednisolone in low dose at late phase of ARDS. And again, no beneficial effects. More recently, they decided to use dexamethasone. And they compared dexamethasone with placebo in moderate severe ARDS patients. And they observed a significant increase in survival. In a recent guideline, they suggest administering corticosteroid to adult critically ill patients with ARDS. But conditional recommendation is moderate certainty. They suggest using at the early ARDS dexamethasone or methylprednisolone at low dose. And in resolving ARDS, they suggest using methylprednisolone. Interferon is an excellent anti-inflammatory drug. And in the first study, they observed that interferon increased survival. But then, in 2020, there is no significant difference between interferon and placebo concerning the mortality rate. So, again, no beneficial effect. And what about vitamin C and D? They also observed no beneficial effects with vitamin C or vitamin D. As you can see here, this is a phase 3 trial, and no beneficial effects. And aspirin, they thought that using aspirin in a dose of 325, it may reduce the risk of ARDS. But unfortunately, this phase 2 trial stopped because no beneficial effects was observed. And civelastat sodium is a neutrophil elastase inhibitor that reduces the inflammatory process, but also reduce the release of elastase in order to damage the epithelium and the endothelium and the matrix. And unfortunately, the use of civelastat reduced the survival rate when compared to placebo. Statins indeed reduce cholesterol, but statins may also reduce the inflammatory process because of a reduction in neutrophil migration and ROS regeneration and a reduction in the vascular permeability. And they observed no beneficial effects and at the early phase or in long-term outcome. And they also observed no beneficial effect with rosuvastatin. The beta agonists were thought initially it may induce a beneficial effect because of the bronchodilation and inflammatory effects and repair of the epithelium and endothelium. But unfortunately, beta agonists reduce survival rather than increase survival. In order to reduce the edema, they decide to analyze the effects of surfactant. And they observed that with Exosurf or cofactant, no beneficial effect was observed concerning the mortality rate. Then they decide to evaluate drugs that may act in pulmonary vasoconstriction or pulmonary vascular permeability. And then they decide to use nitric oxide. Indeed, the nitric oxide increased PO2, improved oxygenation. But when we analyze its effect in mortality rate, again, no beneficial effect was observed. Even in phase 3 trial, no beneficial effect. In the more recent guideline, they suggest using nitric oxide in order to improve oxygenation and before the use of ECMO. More recently, the use of nebulized heparin seems to reduce the risk of ARDS, as you can see here. And there are several studies ongoing trying to evaluate whether or not heparin may induce a beneficial effect. Other therapies have been studied, such as mesenchymal stromal cells. It seems good because to reduce the inflammation, reduce the fibrosis, the repair of the endothelium, the repair of the epithelium, the reduction of edema. In this study, this multi-center randomized double-blind trial conducted in 60 moderate severe ARDS. Unfortunately, in this clinical trial, they observed no beneficial effects. More recently, in 2022, they performed 3 different cohorts. And in this cohort number 3, high dose of cells compared to placebo, and no beneficial effects concerning the mortality rate. They decided to use another source of cells, the umbilical cord. High dose, analyzing oxygenation index, and no beneficial effect. Well, we don't know if we have to stop using or studying the use of mesenchymal stem cells. But we are in the tip of the iceberg. We don't know whether or not we may use one or more dose, which is the best dose, similar for all patients, which is the best route of administration, which is the best moment to begin cell therapy, and which is the best cell source. Another drug is cisatracurium. We know that cisatracurium is able to block muscle contraction, but it may also decrease the inflammatory process. In this study published in 2010, they observed that in severe ARDS, pH ratio lower than 120, the survival rate seems to be higher with cisatracurium compared to placebo. But when pH ratio is higher than 120, no significant changes were observed between cisatracurium and placebo. Then they decided to compare cisatracurium with light sedation in patients with pH ratio lower than 150, with PP higher than 8, for less than 48 hours. And in this case, no significant changes were observed between cisatracurium and light sedation. The results of Acrosis and Rose trials suggest that neuromuscular blocking agents should not be used routinely in all patients with severe ARDS. However, it's possible that neuromuscular blocking agent may be beneficial in cases of severe ventilatory dysynchrony or to facilitate placing patients in prone position. So we are facing a therapeutic challenge. All these drugs were developed in order to reduce the inflammatory process, reduce the edema, repair the epithelium and endothelium and the matrix, but no beneficial effects. So probably we have to focus on the personalized pharmacological therapy. Probably this is our future. ARDS pharmacotherapy has focused on reducing lung inflammation and edema, promoting vasodilation, and improving epithelial, endothelial, and extracellular matrix repair. Although preclinical studies have shown benefits, to date, no drug has been able to reduce ARDS morbidity and mortality. Personalized therapy targeting different subphenotypes has been suggested as an option to improve ARDS survival. Identification of ARDS subphenotype is required when selecting patients for clinical trials to increase treatment efficacy. Probably our future is focused on genomic, metabolomic, transcriptomic, proteomic. These technologies provide new opportunities for ARDS personalized therapy. Future trials should include biochemical and biological parameters and consider comorbidities, risk factor, disease severity of each patient. We have to focus on all these parameters. One important issue. The future of ARDS therapy lies in precision medicine, innovative approach to drug delivery, immunomodulation, cell-based therapies, and robust clinical trial design. Thank you very much.
Thank you. That was a really nice synopsis of the present pharmacotherapy of ARDS. Pretty glum, the last statement that till now no drugs have shown a mortality benefit. I'll invite Dr. Deepak Govil next from Gurugram to tell us about something that we can do and perhaps has shown more benefits. Dr. Deepak.
Good morning, dear friends. First of all, I would like to thank Mr. President and General Secretary for giving me this opportunity and inviting here. So in next 6 or 7 minutes, I'll just go through you the journey of proning in ARDS. As we all know, proning is a good term all around, no doubt about it. Many studies have proved. This is the first literature published in the American Review of Respiratory Critical Care, Respiratory Diseases in '74, where this gentleman has showed that in the proning, if they are doing prone in the kids, it's beneficial. Same time, this editorial appeared in the same article, same journal, American Review of Respiratory Diseases, where they have said that it's a devil's advocate and they are supporting that physiologically it helps to improve the physiology of respiratory system in the ARDS patients. Then comes another study published in 1976 in Critical Care Medicine, where they have proned with this bed, which is rotating bed. Around 5 patients were proned into this, and they found some beneficial effect, although there was no mortality benefit in those patients, but in 5 patients they found some improvement in their oxygenation while proning, and not only the oxygenation improvement, they were able to do a better respiratory toilet as well. So secretion clearance was better in this system. And after that, this study was published in 1976. In the 6 patients were taken. It was by William Douglas, published in American Review of Respiratory Diseases in 1977. Study was done in 1976. 5 patients were intubated on mechanical ventilation. 1 was not intubated. And out of these 6 patients, 5 patients were proned around 4 to 4 hours, 4 hour proning, 4 hour supine, and 1 patient proned for 33 hours. They found some beneficial effects, but again, up to this time, it was just a proof of concept type of studies. Small group of patients were being done. Then comes this study. It was a clinical study, prone positioning in ARDS by Gattinoni et al., where they have proned these patients for 2 hours, and after 2 hours they did the gases, and as you can see, after 2 hours of the proning they found some benefits in the oxygenation, but again failed to show any mortality benefit in this study as well. They have taken 13 patients who are having severe, moderate to severe ARDS in this study. Then comes the experimental studies. There are few experimental studies, again by Gattinoni, published in 1991, where he has taken 10 patients with ARDS, acute lung injury, he has categorically said, and 10 healthy volunteers. And they have been proned and CT scans were done just to prove, just to give the concept that This proning will help in the respiratory mechanics. Proning also helps in the ventilator-induced lung injuries, preventing that, and improves the lung mechanics. Another study is a laboratory study published in 2005 in Critical Care Medicine, where they have done the proning in the rats, and they have shown that it delays the progression of ventilator-induced lung injury in the rats. And they have these are exactly the proof of concept type of studies where people were trying to establish that proning helps. Then comes the era of randomized controlled trials starting from 2001 to 2013. Various randomized controlled trials and meta-analysis were published during these 12 years. I have taken these 5 studies which are landmark studies just to highlight how the journey of proning has progressed during this era. So this was an early paper published in 2001 in NEJM, where they have studied the effect of prone positioning on the survival of the patient with ARDS, again by the Gattinoni multi-center randomized trial, compared conventional treatment along with the proning, and proning was done 6 or more than 6 hours for 10 days. And good number of the patients were enrolled. 304 patients were enrolled in each group. But again, although placing patients with acute respiratory failure in a prone position improves their oxygenation, but it does not improve survival. So that study also failed to show any survival. Probably this study was not powered enough to show survival. They were more concentrating on the benefits of the oxygenation. Then another study published in JAMA in 2004, where they have done this study around 791 acute respiratory failure patients in 21 general intensive care units. The trial demonstrated that no beneficial outcome is there, but there is a lower incidence of VAP in these patients. Another study published in 2006, where they have concluded that prone ventilation is feasible, safe, and may reduce the mortality. This study published in JAMA 2009 by Tacconi et al., it failed to show any mortality benefit, so it was a relatively negative study. Then comes this, you can say, the ultimate study as a ProSeva trial, where they have taken a multi-center prospective randomized control trial. 466 patients were recruited, more than around 14 to 16 hour proning was done, and there was a reduction in the 28 and 90-day mortality. So this was final study which promoted the prone positioning, which established the role of prone positioning in the management of ARDS. But the journey of proning is still a long way to go. As we can see, this one study published in 2016, where only 16% of the doctors are using prone position. So it's a long way to go. Thank you very much.
Thank you, Dr. Govil. We have time for questions, if any. If not, thank you so much. We move on to the next talk by Professor Javier Perez Fernandez from Miami. He is the president-elect of the World Federation of Intensive and Critical Care, and he will be talking beyond low-volume ventilation in ARDS.
Welcome everybody. I'm Dr. Javier Perez Fernandez, the President-elect of the World Federation of Intensive and Critical Care. I'm a pulmonologist and a critical care specialist working in Miami, Florida. And I'm joining today this fantastic group in order to discuss on aspects of ARDS. Obviously, the day has been full with different and splendid speakers. And I will give a different vision if you allow me to share the screen. We will begin soon. Our journey about some other aspects on the management of ARDS. As you all are aware, mechanical ventilation in ARDS is essentially very much promoting the use of low volume, limited volume ventilation. I will give you some different aspects today, and I'd like for that to be my entire presentation. So if you look at the graphic today, you can see the mortality in ARDS for the last 3 decades have been essentially unchanged until the beginning of 2000s. And obviously that is in great part due to the pivotal study that we will be discussing, not today, but has been discussed during the day, and of course you are aware. Now, that trial, which is the ARMA trial, made a different aspect of the management of ARDS patients with mechanical ventilation. Now, it is important to mention that during these previous years, these previous decades, and I was involved in multiple studies regarding the management of ARDS, there were limitations, significant limitations in the studies, in great part due to the inaccurate diagnosis. So what was ARDS, what was not ARDS is different depending on the inter-observer variability. Sometimes the interpretation of the X-ray was one way, sometimes the interpretation of the X-ray was other ways. As well as you know, time-dependent diagnosis. So it depends on when the moment of the diagnosis the patient presented with ARDS or not. So those aspects limited significantly the studies, heterogeneous populations, and so the mortality in great part is biased by multiple aspects. But the ARMA trial came to make a different change on the way we manage patients. So before the ARMA trial, everybody's ventilation was essentially set at 10 milliliters per kilogram. The ARMA trial was an attempt to limit the volume, and in great part, this was a significant different mortality. You see there, hospital mortality in the ARMA trial was 31% versus 39%. So it's a 25% reduction in mortality. And this was done in a multi-center study, also proved to be successful on the mechanical ventilation of 3 days. Those aspects created a significant change in the paradigm of how we manage patients on ARDS. And of course, this came to refresh our minds on the concept of biotrauma, the volutrauma, barotrauma that was essentially known before, but then also the story with atelectrauma and these particular aspects of areas of the lung that were exposed to different forces of expansion, non-expansion, and that caused biotrauma, which was in general beyond the lungs. Now, a concept that is being lately associated with the damage is the concept of driving pressure. As opposed to just limiting the ventilation to the plateau pressure, we're now looking into what other aspects could be essentially exercising an impact on the injury on the lung, parenchyma. And one of them is the use or the measure of driving pressure. As you know, driving pressure is simply the subtraction of the plateau pressure minus the PEEP. And again, an example of the difference that driving pressure can cause on the lung, you can see there a lung in which the left lung is ventilated using no PEEP and the right lung is using PEEP. With a PEEP of 0 on the left lung and maintaining both lungs on the plateau pressure of 29. So again, plateau pressure is adequate, the volume is adequate, but the PEEP was 0 for the left lung and 5 for the right lung. The damage caused in the left lung ventilation was significant and indicative that maybe the driving pressure was excessive on the left lung as opposed to the right lung. So multiple aspects really are important and involved on the patient on ARDS and our ICU. And of course, we're not going to reflect all of them, but some of the issues that happen is really considering when we have a patient with ARDS, what are the p-values that we're looking at? Perfusion, positioning, protective lung modalities, protocol reading, preventing complications. And one aspect that is important is prioritize recovery. And this is one of my last 5 minutes on the presentation will be regarding that. Well, so looking at ventilator strategies, I think that everybody has on their mind how we manage patients with ARDS. Now, the tidal volume needs to be limited, the plateau pressure needs to be less than 30, so essentially 29, assuming obviously normal chest wall mechanics and interestingly, recruitment maneuvers are a subject of significant discrepancy, whether we use PEEP, whether we use tidal volumes. And again, lately, the concept of driving pressures to be below 20. And again, this is ultimately one of the latest aspects. But I think one of the important issues that we look is in prioritize recovery. And prioritize recovery is maybe reflected by this ABCD bundle. And this is an evidence-based bundle, which is not related to airway breathing circulation, but it's really aimed to move mechanically ventilated patients throughout the trajectory of the critical illness, and again, helping the human aspect and the body aspect and the body recovery. And those are reflected here. As you see there, goes from assess the patient, spontaneous awakening trials, spontaneous breathing trials, which is B, and the C, with its choice of analgesia and sedation. As you know, it is reflective of the recovery process for the patient. The D that goes into the delirium and what we call sometimes the post-ICU syndrome. E that reflects the early mobility, and F, family engagement and empowerment. And those are aspects that sometimes we forget in our agitated life as intensivists. And examples of that, again, is the daily sedation interruption, that in this case decreases mechanical ventilation duration. Now, this is very important because we need to obviously apply daily sedation interruption to our patients. I know this might be, again, an aspect of a jump into some areas of the unknown for some of the intensivists. Our students, our fellows sometimes are very reluctant to do this in a patient that is very sick. And this is the same kind of a change in the paradigm that we did when we moved our ventilation management from 10 mLs to 6 mLs. So it's important that when we apply this daily sedation interruption, studies have shown significant reflection of the diminishment of the length of mechanical ventilation, the length of the ICU stay, and of course, an improvement on post-traumatic stress disorder, so what we call the ICU syndrome. So important, again, this is again successful screening test. When we assess those patients for awakening, for sedation holiday, as we call it, and this is a study into 300 patients. Interestingly, those patients who receive an interruption of the sedation had a better or a faster mechanical ventilation discontinuation without affecting their outcomes, obviously. So spontaneous awakening trials need to be performed, and again, with a safety screen, so we need to protocolize that. This is not just someone going there and turning off the sedation and waking. It's better to have a protocol to have it ready and perform it. If the patient is successful on this, then we go ahead and start the next step, which we'll mention immediately. If it's not successful, if the patient fails, then we return again to the sedation using less dosification to see if the patient tolerates less dose, and then again we do it again tomorrow. Now, spontaneous breathing trials are important. Spontaneous awakening trials is one aspect, but then if the patient passes, then we go to the spontaneous breathing trial. And in spontaneous breathing trial, there are multiple protocols how to do it. This is not about how to teach you how to do it, but this is more about, again, indicative of we need to do it. And if the patient passed the spontaneous breathing trial, but obviously we go ahead and consider extubation, but if it fails, then we go back to the spontaneous awakening trial, etc. Now, interestingly, this is a small study, but it was well conducted and published in The Lancet back a decade, more than a decade ago, indicative that the spontaneous awakening trials, spontaneous breathing trials, and early mobility has a better chance of improvement in those patients. And again, this is studying physical therapy and occupational therapy as early as 1.5 days after the patient is intubated. And this is very important because, again, you make the family actually participate in these aspects too, and they feel really great into the progress of the patient, and this is important. I'm going to finish here. I know it's short on time today, but again, I hope that this will be good to understand there's other things beyond what we do with our medications and what we do with our ventilator to improve patients. Again, being more human, maybe more close to them and their families might be a good way to communicate and a good way to improve them. Now, important to know that after 2000, when was this ARMA trial published, which was clearly redundant on benefit for our patients with low volume ventilation, the use of low volume ventilation, the use of lung protective strategies remain suboptimal. A study done in 459 ICUs in 50 countries recognized that essentially a significant number of patients, 60% of the patients, only receive measurement of the plateau pressures. Again, this is key element to understand low volume ventilation, protective lung strategies. So even after 2 decades of clear evidence, we're still not able to conduct these in most of our intensivists and most of our ICUs, and a significant portion of that. So, in conclusion, again, low protective strategies are necessary, obviously, but I think as a summary, ABCDEF bundle is easy to implement, it's easy to make it effective, and it's clearly done on the benefit of our patients. I'd like to thank you for the attention. Obviously, there are new global definitions for ARDS. I want to call the attention of everybody about this because they reflect some of the aspects that we criticized in the last decade or so. And so I'll move everybody, and I know that it will be covered during this particular day. So I'd like to invite and extend an invitation for all of you to participate on the next year, 2025, next year, September 16 to 19, Congress of Intensive and Critical Care. This will be the World Congress of our Federation. This will be a fantastic meeting in an incredible venue in Vancouver, Canada. Please go onto the website, whether it's the World Federation or the Canadian Association, Critical Care Society, sorry, and then you'll receive more information. But thank you everybody for your attention, and again, welcome to this fantastic day.
Great, and that was a very nice lecture. As we're all listening to the lectures, I'm sure all of us are getting the underlying tone that most of the speakers are setting here, that close clinical care is most important, and it's humbling to see that in spite of there being some interventions that are evidence-based, the implementation still leaves a lot to be desired. That slide showed that severe ARDS can lead to severe mortality. We'll next go to Professor Luciano Gattinoni speaking about severity assessment in ARDS. Professor Gattinoni, of course, needs no introduction. Minimum father of the baby lung.
Okay, my duty is in 12 minutes speak about ARDS severity assessment. Okay, let's go. ARDS is an old story. No? I start with Petty. Petty is this one. And Murray, the upper picture, who described a syndrome, which is a collection of symptoms, that they found in 11 patients who arrived from different diseases, but the terminal picture was the same. So they had all this patient was characterized by what? By the inflammation of the lung. So they call adult respiratory distress syndrome, not acute. The original name was adult, just to compare for the neonates ARDS, which was due to the lack of surfactant. Anyway, the picture was an inflammation and edema, and with the years we understood this is due to the biology, that means to the time course of the disease, and also some doctor's intervention, which may contribute. Then we have a loss of compartmentalization in the lung, and we have this sort of lung sepsis. That means a sepsis which is limited to the lungs, which we have a progressive increase of edema and a progressive decrease of the gas volume, because the edema steals space to the gas, and so the baby lung, which is the small lung volume, becomes smaller and smaller and smaller, with mild, moderate, and severe ARDS. Mild, moderate, severe ARDS were defined according to the oxygenation, for practical terms. Okay? And so these are the progressive definition of ARDS that we had from Asbach, the original. They say, okay, oxygenation very bad, X-rays bilateral involvement, compliance, that means lung mechanics, respiratory mechanics, deeply altered, and at autopsy, very high lung weight. These were the symptoms that were characterized, the first description of Ausbach and Petty. Then in Chicago, I had the opportunity to follow all this evolution. In Chicago, just before to take a plane to come back, we decided, okay, let's see. Well, let's call acute lung injury this 300, 200, 100 of a PF. And we call ARDS 200 below 200. And we leave the bilateral X-rays as a sign. Then we say, okay, no, in Berlin, after years, we say, okay, no, let's go mild, moderate, severe ARDS and keep the X-rays as a sign. Now, why we have all this kind of evolution? Which are the reason for the syndrome? I think the reason for the syndrome is that more or less at this terminal stage of a different disease, when you have the lung involvement, the therapy which is required, which is mechanical ventilation, is really common. And why we change over time? For one very simple reason. There are no particular physiological reason, but to make more feasible the RCT. So we have a less restrictive entry criteria, which increase the unhomogeneity. So we have two balances. On one side, we have more patients, less homogeneous, or lower number of patients, more homogeneous. Still the problem is unsolved. So, with the continuous, we arrived until the last ARDS global definition. Global definition sounds very scientific, in which say, why to use PO2 and FiO2? Just use SpO2. At this point, I am wondering, the global definition of ARDS is when the doctors say, okay, this patient have an ARDS. So we have a progressive decrease on criteria to which the ARDS has been defined. But in the other side, we recognize that in this big group, under this big umbrella, which is based on oxygenation, we start to read a subgroup because we do not take care of population. We take care of the single patient. They say, okay, let's see. So we have primary versus secondary. Are they different? We have the patient with higher or lower recruitability. Are there difference? We have inflammatory. We have patient with COVID or with non-COVID. And so in this big soup, bouillabaisse of RDS, we start to recognize some possible subgroup. And remember, when we say higher and lower, means that we do not know exactly the number, what kind of number to put in. Higher and lower reflect our ignorance. It's not 5, 7, 8, 10. I'm not precise number. And then we have under this umbrella also the other subtypes. Do they require different therapy? We have the inflammation, primary RDS, recruitability. We have which kind of pill level, COVID, which kind of people we need. You know, the problem which come out with the years, that the mechanical ventilation safety does not depend on oxygenation, but depends more on the lung mechanics. So we have a start, this big confusion between definitions and how the definitions are reflected in the normal therapy. Because the intensity of therapy should be related to the severity, okay? From this, the importance of definition. And this is a sort of ideal picture, no? When you have this kind of, let's say, mild ARDS, well, what do you do? FiO2, spontaneous breathing, FiO2. What is the risk of FiO2? Oxygen toxicity, okay. So if the FiO2 goes too up, well, we start to put some pressure, and respiratory pressure, and we have spontaneous breathing and CPAP. What is the risk? If the patient, the severity of the disease increases, we may have the muscle fatigue, we have the patient self-induced lung injury, so be careful, we have to use some energy from outside to provide, to substitute the muscle force. And we have non-invasive ventilation and mechanical ventilation. Then, if in this condition we have an excessive stress and strain, we have to use and to add and to substitute some alveolar function. And we have, in this condition, the extracorporeal CO2 removal and eventually ECMO. But remember that still we are concentrated on oxygenation. But is it really the right way to look at the problem? Let's see, the oxygenation, as an example, takes the top of the problem. The top of the problem is when we have to use extracorporeal support. That's great. This is example 79. The entry criteria for the first randomized trial in intensive care done by Warren Zippel was based on oxygenation, PO2 less than 50, for some, or immediately or after some times. Now look at the Yodia trial, which is already for years, and are still the same criteria. Through the others trials done are all based on oxygenation. And you say, okay, so the oxygenation is very important. Is that true? Okay, tell me here, which are the patient with ECMO and the patient without ECMO? Can you see any difference between treated and control in PO2 or in people? So, if I can provide the same oxygenation, why should I use ECMO? So that means there is something strange, because ECMO had some advantage. All the people working with ECMO perfectly recognize that. But what is different? It's not the oxygenation. Look here. These are the PaCO2 and a minute ventilation. That means the ECMO allow you to provide a more gentle ventilation of the diseased lung. That means you might decrease sharply the minute ventilation, okay? And that means all the stress and strain, which are the basic, overall the strain, the basic of the lung damage during mechanical ventilation, are decreased. And look again, this is the most important slide that impressed me quite well. Let's see. We have this patient, these are more than 250 patients, divided mild, moderate, and severe ARDS, okay, the classical criteria. And we went to see the respiratory system compliance. And you see the respiratory system compliance was not different in these three categories of the patient. And you say, okay, look at the lung stress. That means the transpulmonary pressure. And you have still are similar in mild, moderate, and severe ARDS. Then you look at the lung strain. That means these are the basic of the damage of mechanical ventilation, and lung strain is exactly the same in mild, moderate, and severe ARDS. And the mechanical power, which is sort of summary variables, which include all the possible known causes of lung damage, are once again similar to. So, if we have to look at the story of ARDS, we start, ARDS makes sense as long as the common therapy is the mechanical ventilation. Mechanical ventilation makes sense, it may provide, to buy time, maintaining the life, provide adequate oxygenation at the lowest iatrogenic cost, so without adding further damages. And the damage is what? The barotrauma, and which allowed the permissive hypercapnia. Then we discovered the volotrauma. Then we discovered the atellect trauma. Then we discovered the ergotrauma. But no one of this is linked to what we call, and on what we classified as ARDS severity. And you say, okay, but ARDS severity is related to mortality. Of course. But look, also the age is related to mortality. Also the SOFA scores, also the Apache score are related to mortality. So mortality is a complicated issue. The problem is, for what the ARDS is concerned, what is important is to find the possible best approach, less dangerous approach to the mechanical ventilation. And this is not based on oxygenation, but is
Okay, that seemed a bit abrupt, but I'm told that was the end of the talk. Next is something we've all been looking forward to. This is a tribate, and we are going to debate on the pros, cons, and then have a balanced view on driving pressure in ARDS. I invite Professor Rahul Pandit from Mumbai to speak in favor of using driving pressure in treating ARDS.
Good afternoon, everyone, and thank you, the ISCCM leadership, for the kind invitation. I'm going to talk in the, excuse me, how is the slide moving? Thank you. So I'm going to talk in the favor of driving pressure, and then of course my colleague Dr. Chatterjee would talk against it, and we should have a balanced view on that. So I'm going to put up a rationale for it, why we should be using it, and then of course some evidence which sort of goes with that. Whenever we see this kind of lung in ARDS, we are all worried about we should not be causing more damage to it. So the ventilatory induced lung injury is a big problem. And if you look at the various types in which we actually can cause a problem, the polytrauma and the barotrauma seems to be the two biggest one. And then of course you have the other ones where shear injury is there, recruitment, de-recruitment, so on and so forth. But whatever comes down to the mechanics. And what do we look into mechanics? We look at the plateau pressures as well as we look at the over-distension, and then we now use the protective lung strategy where we go with lower plateau pressure of 30, tidal volume of 4 to 8 mils per kilo, and we have this baby lung syndrome which we now know very, very well. And where does this come from? This comes from reasonably good, robust evidence which has changed the practice for us. The ARDS-NET low tidal volume trial, which was a positive trial, was basically stopped in the fourth interim analysis because of overwhelming difference between the mortality between the two groups, the group favoring the low tidal volume. And similarly, we had a PEEP FiO2 trial, which was not a very positive trial, but we know that it sort of didn't make a big difference. But generally, we need to have a PEEP which is sort of a little bit higher than what you would normally have. And that number sort of goes around 10 to plus, or maybe up to even 14 or 16. And where does it come from? Why are we sort of looking at low tidal volume and a moderate to high PEEP? Is because of this baby lung concept, which was done several years ago by using CT scans. And what we realize is that it's in an ARDS patient, the lung sort of looks like a 5-6-year-old lung where it is around 300 to 500 grams aerated. It is not only stiff, but it is also small. And what we need is gentle ventilation. And here you can see that the potential to cause damage is very high because you only have the upper part which is sort of inflated. Rest of it, if you try to open up too much, you might be actually causing harm than good. We also know that if we start applying a standard PEEP across all of these patients, and that's where the difficulty begins, you may actually have alveoli which will be completely differently opened up for different patients. Not only that, within one patient also you may have over distension or under distension, and optimal use of that will be very difficult. So this is the rationale which I am building through. So what are the variables which we can actually monitor and change? That comes down to only tidal volume, PEEP, respiratory rate and plateau pressure, and a bit of I ratio modifications. However, you change one, it comes at the expense of actually having a change in the other one as well, and we really don't know whether it's going to benefit or possibly cause harm. So this is what a standard recipe for ARDS ventilation would look like before we actually started looking more deeper into driving pressure. Until this gentleman, Mato, came out with a retrospective analysis, and he found that if you ventilate these patients with a driving pressure, which is the difference between your plateau pressure and your PEEP, and you try and keep that number below 15, beg your pardon, those patients had a better outcome in terms of mortality. And then the safest zone of ventilation was in patients where we could keep the plateau pressure below 30, keep the driving pressure below 15, and then you can sort of come up to a PEEP which was at a safe level, and have that probably may not be an optimum peak, but if you keep these mechanics better, and we just heard Professor Gattatoni talking about oxygenation is not the main problem, it is the mechanics which is the main problem. What we do with the patient is one of the main problems as well. You will be able to actually have a better outcome. So if I put this down into a table, and I have the plateau pressure to begin with, if it is rising with the same PEEP, and driving pressure increases, we know that the mortality increases. This is all coming from Amato's paper still. If you have driving pressure rising, PEEP rising, but the plateau pressure remains the same, the mortality does not change, neither increase nor decrease. However, the moment you have a plateau, moment you have a driving pressure going down, your mortality also starts to go down. So if you actually look at that as an individual parameter, which seems to be a better variable to look for, mortality difference is seen. So what is it? It is basically the difference between your P plat and the PEEP. It is also a ratio of the tidal volume to static respiratory compliance. So you could also say driving pressure equals to volume upon the respiratory compliance. That's another way of looking at it. However, again in the red which I have said, one retrospective analysis put up a lot of emphasis on that and said that it actually one of the key variables to look for in mortality in ARDS patients was driving pressure. Then came the lung safe trial, which was sort of recruited around the same time when this paper was being talked about, and they sort of looked at 29,000 odd patients who then went into having an actual analysis of around 2,300 odd patients. And if you look at the way the ARDSNet trial had already been established by that time, so you had a 6 ml per kilo tidal volume and the plateau pressure was supposed to be between 15 to 30. So if you keep a safe zone of ventilation, this is the zone in which majority of those patients should have fallen down, 2,300 patients. But look where it was, scattered all around. So a lot of patients were actually not getting the ventilation strategy as per the ARDSNet protocol or the safe ventilatory strategy which we talk about. But in the same paper, if they looked at independent variable as a driving pressure, there was definitely a mortality benefit when the driving pressure was below 14. So I think driving pressure again came out as one of the variables in that trial which looked at that. And when they compared it with the plateau pressure, again driving pressure seemed to be an early indicator of patient getting either better or worse, and the mortality difference was quite evident when we looked at driving pressure. So if I now put it up into a graph and look at the traditional 6 ml versus 12 ml, this little zone here between 6 ml and 12 ml is the best point of ventilation for me, and the driving pressure seems to be the minimum at that time, and that's where the well expanded alveoli is, and that's where I can actually get a very good ventilation happening for my patients. So evidence started to pour in. People looked at association, again going back and doing retrospective analysis of number of trials. This is a 6,000 odd patient, 7 studies looking for a risk analysis. That was again in the favor of driving pressure. Then we had to see whether there was an impact in various different patient strategies. So somebody who was obese versus non-obese. And this was interesting that in contrast to non-obese patients, driving pressure was not associated with mortality in the obese ARDS patient. That might be to do with the compliance and the mechanics again, which might be completely different for obese patient. Yeah. So just last 1-2 slides. Driving pressure, basically if you look at can a randomized control trial been done, this trial showed that you can actually do a randomized control trial quite well. The drop study again talked about a reasonable amount of understanding between PEEP as well as FiO2 ratio and the driving pressure, but it did say that you can't use driving pressure to set up optimal PEEP. So we know that now. And if you sacrifice a bit of tidal volume to optimize the driving pressure, it still had a favorable outcome in terms of driving pressure. This is the trial which basically showed that in 2021. So in conclusion, it makes a lot of physiological sense to go with the driving pressure. I do appreciate that randomized control trials looking just at driving pressure in large population have not been done, heterogeneous population have not been done. There are trials which are on the way. However, it costs minimal, and a little bit of tidal volume sacrifice or a little bit of plateau pressure up and down to sort of bring it below 30 will actually give you better results. Thank you. And I will have my friend come and talk against us, and we'll see what comes through. Thank you.
Thank you, Dr. Rahul. Next, we have Dr. Ranajit Chatterjee from Delhi, and he will have something to say against the driving pressure.
Thank you, the organizers, to giving me this chance to stand in front of you and go against driving pressure. And also, you know, when you talk in con, you have many of your works done by your predecessor. Rahul has already told the shortcomings of driving pressure. So many words are probable, many words that I don't know that came up. And what I want to say is that, yes, we are all concerned about villi, that is ventilator-induced lung injury. And this is the formula by which driving pressure has been given, P flat minus PEEP, and tidal volume and the static compliance of the lung has been taken care of, and we want to keep it as low as possible. That is what we want to be. Now, all that glitters is not gold. That is the problem. And it happens, you know, it is natural, because when we are treating about ARDS, we are seeing that ARDS, we are trying to find out a solution for the last 2 decades. And what we have found out, only a tidal volume comparison between 6 and 12 milligram. I don't think that is a very short area that Rahul was telling. That is a small area. 6 and 12 is double of it. And what we have done, moment something comes, we try to grab it. Like for example, the vitamin C by Marik. It came, immediately the whole world knew that Marik is Marik's protocol. Vitamin C, thiamine and steroid. Ultimately what happened? We saw that it is not effective. So the same thing happens with driving pressure. We were a bit cautious about jumping into conclusions. It happened with Zygris also in sepsis patients. Now see, this is basically the trial that created all the problem. You know, Marik, this in Amato has done a multiple mediation analysis of 9 RCTs. It is a physiological assumption and presumption that he made. It is not an intervention. Please try to understand this. We have been passed on a message that driving pressure of 15, a static value, a mathematical phenomenon, mathematical value can suffice a complex physiological situation in a pathological lung. That's what has been done by him. Multiple mediation analysis, it is a statistical, unique statistical thing done to see the color of the guinea pigs in 1920. In the 1950s, it was used for social science studies. It has been incorporated into medicine. And he has done a secondary analysis of RCT and it is not equal to an RCT. And there are so many challenges of multiple mediation analysis. The complex interaction with the mediator is driving pressure. Moderator, you may be giving not good amount of nutrition. Your diaphragm is not working. What you are going to do? Confounder, you have a lot of confounders. For example, you are using a different type of ventilators here. Colliders, you may be having AKI, you don't know only driving pressure is the initiator of mortality in ARDS. Do you want to mean that? And driving pressure is measured when patient is paralyzed. I'll come to that. So true driving pressure, when you are measuring and the patient is spontaneously breathing, you are grossly underestimating that. And if at all the findings are so valid, does it mean that you should set pre-plat as high as you want as long as the driving pressure is low? Is it so? Or conversely, does it mean that a low PEEP plat, but a quite low PEEP harms patient? So that is the questions that should come. So basically, we are dealing with a dynamic situation. And we are going to give a static solution to it by a number. Cyclic gradient of pressure, that is the transpulmonary delta P, is not being measured. And Amato here, he presumed that static P is a surrogate of dynamic transpulmonary pressure. He presumed. Where from the presumption and assumption is coming here, I don't know. Now see, I am showing you. This is one of the ARDS. This is another ARDS city. 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 Everywhere driving pressure of 15. Is it possible? Does this number suffice everywhere of this different situation? Now let us come to the guideline. I think Gracili here is sitting, he has given this guideline. And see, Amato is also there. That is the reason I have written his name there. What they have given in the 2023 guidelines? Not a word about driving pressure. Why? Because they first of all recommended against paralyzing first. So if you don't paralyze, you can't measure the driving pressure properly. And you are unable to make a recommendation for or against PEEP titration guided principally by respiratory mechanics, maybe driving pressure. And they themselves questioned that how can you measure that adequate PEEP? Severity and pattern of the lung injury, lung and chest wall mechanics, tidal volume, positioning, spontaneous breathing efforts, cardiac function, intravascular volume, vascular tone, not my words, their words, and lack of standardization. What type of ventilator you are using? What type of standards you are using in your ICU? And what is the time frame? At what time you are titrating your PEEP? 5 minutes, 10 minutes, 15 minutes? We don't know. So we don't know about optimal PEEP, but we are going to measure the safest driving pressure. We're giving a number to it, mathematical solution to this complex problem. See, by Wheeler, he is also a part of this guideline. He has come to a driving pressure of 19. And this is showing 15 as a driving pressure to be maintained, and they are already given a guideline, but nobody read the star mark. The limit of 15 centimeters is speculative, as no safe limit of driving pressure has been seen. Now, all these tests, do they suffice? With the same driving pressure, the obese patient, pregnant patient, pediatric patient, he has already shown that it does not work in obese patients, neither in patients without ARDS, nor in patients in thoracic surgery. Nowhere driving pressure is the predictor of mortality. So what is the problem? Lack of high quality clinical trials. All are retrospective trials and observational studies. They are not targeting intervention but some physiological targets, giving a mathematical solution to a complex physiological situation of tidal volume, P plateau, delta P, to a pathological lung condition. And what is the optimal driving pressure then? So what is the solution? The solution is maybe transpulmonary driving pressure. Maybe the better surrogate of lung stress. It might obviate the contribution of the chest wall, and this hypothesis may be a basis of better clinical trials, and a more detailed physiologic understanding of driving pressure and its determinants are needed to prove that it is a valid and reliable tool to set a ventilator in patients with ARDS. So this is very important. We should not pass on this message from this platform that go for a driving pressure of 15 or go for 14. It's wrong. Or go for 19. What is your driving pressure that you want to set? What is the lung condition of the patient? Whether your patient is having some confounding factors or or not. You have a heterogeneous patient lying there. Only one driving pressure will tell you whether the mortality will increase or not. Yes, we have to follow that. And what should we do? The first step is to physiologically understand the driving pressure. Then we go for some pilot studies that already he has shown. I think I can get 2 minutes, you got it. And I'll complete it in a minute. Pilot studies like R2 trial that is already coming. Once I do a pilot study, then I will go for a randomized control trial which has not been done, all retrospective studies of a multi-center, maybe multinational, and a heterogeneous group of patients. And then incorporate into clinical practice after excluding all the confounding factors that are there. And not to use this type of statistical jargon and put it in front of you and tell that driving pressure is the best pressure that can be seen. It is wrong. This message should not go. We should be a bit more, in fact, I'll say practical in this situation, and then we'll decide on driving pressure. Still now, it should not be put, because they themselves have not put it into the ESICM. They are very important guideline. They are giving a message to the whole community, world community. And they have not come with a driving pressure guideline, no limit. So, my dear friends, please look before you leap. Please go through the studies properly, see what the studies are saying. These are not RCTs. These are basically some physiological interpretation to a complex physiological situation, and no mathematical solution can be given to this situation. Thank you so much. Thank you.
Thank you so much, Dr. Chatterjee. I now invite Professor Grasselli to give us a balanced view after that really passionate presentation.
Yeah. So, first of all, thanks for the invitation and thank you for being here. I must say that, if I'm able to, okay, these are my conflicts of interest. I must say that I agree with most of what has been said by previous speakers, and so I try to put things together, and as usual, if you want to do it, it's better to go back to the basics, and the basics are that what we want to do, what we want to achieve with mechanical ventilation and ARDS is to avoid ventilator-induced lung injury. Of course, we want to grant viable gas exchanges, but we want to, and keep the patient alive, but we want to avoid the damage that we can do with a ventilator. So we know that ventilator-induced lung injury is, there are different mechanisms, but when we talk about driving pressure, we concentrate on the risk of delivering excessive tidal volume and excessive pressure to the lung. So we want to avoid what is called barotrauma or volutrauma. And we know that the effectors of barotrauma and volutrauma are stress and strain, which means that if you apply an excessive stress or strain to the lung, then you overstretch the lung and you risk to damage the lung, okay? Let's see what is stress and what is strain. Stress is end inspiratory transpulmonary pressure. And we know that transpulmonary pressure is the difference between airway pressure and pleural pressure, and we can estimate pleural pressure using esophageal pressure. So we use plateau pressure as a surrogate for transpulmonary pressure, but we know that this is not a perfect surrogate because depending on the ratio between the elastos of the lung and the chest wall, the same plateau pressure can correspond to completely different transpulmonary pressure. Then we go to strain, and strain is the change in volume of the lung relative to the resting lung volume. So it's the ratio between tidal volume and expiratory lung volume, or FRC, if you don't have PEEP. And the surrogate is tidal volume normalized to the predicted body weight, because we know that the predicted body weight is in normal subjects in physiological condition has a strict relationship with the size of the lung. But again, this is not true in ARDS, and we know that the same tidal volume can be associated with completely different strains depending on the size of the body lung. And then we also have to remember that stress and strain are linked by a mathematical relationship. So in a way, they are two faces of the same coin. So if you apply a high stress, you by definition apply a high strain, and vice versa, okay? So what is physiologically driving pressure? And then there is also this point. This is a very interesting paper published by Alessandro Protti and the group of Luciano Gattinoni in 2013. It's an animal study that shows that if you apply the same global strain, so you go to 2.5 times the total lung capacity, but you progressively reduce the dynamic strain, then you improve the outcome of the animals, okay? And this is the basis for the use of driving pressure as a surrogate for strain. Driving pressure is the difference between plateau pressure and total PEEP, so not really the applied PEEP, but total PEEP, so you have to take into account also the eventual intrinsic PEEP, and it's tidal volume divided by compliance of the respiratory system. And we know that the compliance of the respiratory system has a linear relationship with the size of the lung that can accept the ventilation. So driving pressure is a surrogate for strain. But again, as it was said before, we should take into account transpulmonary driving pressure, while we usually talk about airway driving pressure. But still, from the physiological point of view, driving pressure is probably a better way to scale tidal volume than scaling it to predicted body weight. Or at least it has a stronger physiological rationale. This was demonstrated by the study by Yamato, and as it was correctly said, this is a very interesting statistical exercise. It's mediation analysis that shows that in some way that the deleterious effect of high tidal volume and of high plateau pressure is mediated by their effect on driving pressure, meaning that if you keep driving pressure low, you can probably accept higher plateau pressure and higher tidal volume. But again, this is not a randomized study, it's a mediation analysis of randomized studies. And more or less the same message is conveyed by this study. Again, it's another secondary analysis of randomized studies by Ewan Golliger that shows, as you can see there, that the using driving pressure to scale tidal volume is probably better than using the formula of tidal volume of 6 ml per kilo of predicted body weight. The lung safe study has been cited already, so I'm not going through this for the sake of time, but this is a secondary analysis of the lung safe study that tried to analyze the modifiable factors that can contribute to improve the outcome of patients with ARDS. And as you can see there, tidal volume apparently does not has no influence so much on the outcome of the patient, but you have to take into account that these are patients recruited in the lung safe study, so patients with ARDS who were already treated with relatively small tidal volume, and the fact that the variable that seemed to have the major impact on patient outcome was driving pressure, with a clear inflection point above 12, 13 centimeters of water. Okay? That's a very recent and new approach. It's called, it's an emulated trial, so it's another interesting statistical approach. So they took a lot of patients from a registry, and then they simulated the trial, comparing driving pressure with driving pressure limited ventilation compared to traditional ventilation. And as you can see there, apparently targeting driving pressure has impact on mortality different from tidal volume and plateau pressure. Do we have randomized studies on driving pressure? Only one. This comes from Brazil, and it's on 31 patients, okay? So who were randomized to conventional ventilation, so 6 ml per kilo, PEEP according to the PEEP FiO2 table of the RDS network, and plateau pressure below 30, or a driving pressure limited strategy, so patients in the intervention group had a progressive reduction in tidal volume to target a driving pressure of 10 centimeters of water. What they showed is that this approach is feasible. Of course, you will have more respiratory acidosis in the intervention group. No difference in hospital mortality, as you can see. I mean, a difference which is not significant because of the low number of patients. So this is only a feasibility trial, and there are no randomized studies. And this is the reason why in the guidelines we did not provide any recommendation on driving pressure. And this, as you can see there, the word driving pressure appears only 3 times in the guidelines, one on the tidal volume domain and the second one in the prone positioning domain. So we recognize that there is an important room for improvement and for studying, but there are no randomized studies, so no evidence that justifies any recommendation based on driving pressure. We will have the evidence. So this is taken from the clinicaltrials.gov. As you can see there, if you put ARDS and driving pressure, you get like 42 studies on that. There are many studies. We are participating to a large platform trial led by the Canadian, led by Ewan Gallagher. So hopefully we will have the evidence. So I think that the physiological rationale behind using driving pressure to scale tidal volume and so to drive ventilation in ARDS is very strong. But still, we lack the evidence from randomized studies, and so until then, we should stay with the recommendation from the guidelines, or at least this is what I believe. So thank you very much for your attention.
Yeah, we have some time for questions, please. Dr. Marcus.
I would like to thank the 3 speakers for giving this emotional and rational discussion. I really liked it. But there's one concern. We are moving now from driving pressure to mechanical power of ventilation, and one of the elements or components of mechanical power is respiratory rate. Now, if I'm thinking of reducing the driving pressure, I'm thinking of maybe changing something in the PEEP level, but also tidal volume reduction. But then what to do with the respiratory rate? Of course, this is also just a number and all mathematical approaches that have been performed, but what do we do with the respiratory rate in this case? Give me a practical advice.
Well, this is a very important question, because I believe that respiratory rate is neglected, and there are also other factors in the driving pressure in the mechanical power formula, like the peak inspiratory flow, for example, which are still neglected. So for respiratory rate, I don't know. Personally, I think, and it also comes from the formula of the mechanical power, that driving pressure, tidal volume is probably more important in the generation of ventilator-induced lung injury. And so what I do personally is that you can go to, let's say, higher respiratory rates in ARDS, provided you don't generate intrinsic PEEP, which is not very common in ARDS, especially in stiff lungs, because when the lungs are very stiff, they inflate and deflate very quickly, so it's difficult to generate intrinsic PEEP. If you generate intrinsic PEEP, you have to take that into account when you calculate compliance and driving pressure too. But again, if what counts is the amount of energy which is transmitted to the lung, the more frequently you transmit the energy, the higher will be the damage to the lungs. So for sure, we will have to take into account also respiratory rate. And this is my point of view. But
I have the same point of view, but one of the aspects that we often forget in the treatment of ARDS is permissive hypercapnia. If you look in the several observational studies that have been performed, you see it's hardly being used with almost always a normal pH, for instance. What is your opinion about that?
Well, if we go to hyperprotective tidal volume, if we want to reduce driving pressure, I mean, if the direction we take is to reduce progressively the amount of energy that we transmit to the lung, you will have to accept some degree of hypercapnia, unless you want to combine that with some form of extracorporeal removal of CO2.
So I thank you for that point of permissive hypercapnia. I was always like that we should go for a debate on permissive hypercapnia. You see, when we gave this name, the permissive hypercapnia, if you go to the dictionary, permissive means permission with some amount of suspicion. We are not sure that we want to permit it or not. God has given us the value of carbon dioxide between 35 to 45. We can't reduce it. We know that if we go for low tidal volume, it will go up. We go up 70 and give a name permissive. Why should I permit a bad thing that is going to happen inside my body if I'm not going to compensate it into the first 10 days? Tomorrow we'll say that the poor people are roaming around. Let's have some permissive robbery at my home, permissive theft at my home. Do we do that? So the point is, let me complete. I am completely against this guideline. Now we have come up with a new tool. Let us go for low tidal volume ventilation. Let us not allow this hypercapnia to go up. Let us go for extracorporeal CO2 removal. Remove that extra amount of carbon dioxide from the patient and let the carbon dioxide be between 35 to 45, it is there. Why should I go for it? Because this name has to be changed. The glossy term was given because of inability, not due to what we want to permit.
But let us forget the word permissive and just speak about hypercapnia. May I remind that in the past we have always tried to normalize the gas exchange for as much as possible. High tidal volume, for instance, was one of the aspects in that way. So we are accepting, and maybe we should call it permissive hypoxemia. We are accepting hypoxemia in our patients because we know we are causing damage. We're trying to get everything normal. And if a patient is severely ill and we try to reduce power or driving pressure or harm caused to the lung, there may be hypercapnia as one of the approaches.
Yes, you are right. You are telling about hypoxemia also? Because permissive hypoxemia has also been tried in 2012. And permissive hypotension has already been tried. And now permissive uremia is also coming. So you are permitting more or less everything. So we have to see that whether how much we want to permit. You are right in your sense, you are right. But again, I have reservations for permissive hypercapnia. I don't know what my other speakers will say.
I'm not too passionate about it the way you are very passionate about it. What I'm trying to say is exactly, I think all three of us sort of came out and said the same thing, that if you are going to compromise on one parameter in the variable, it is going to be at the expense of something else building up. So if you're going to reduce the respiratory rate or tidal volume, your hypercapnia will be a problem. If you're not going to target oxygenation and you're going to target mechanics, hypoxia will be a problem. So I think the premise of all of this still goes to what basics we talked about, cause minimum harm to the already damaged lung. So we really don't know, and I'm, despite saying a pro for driving pressure, I really don't know whether driving pressure will become that parameter or we'll have 4 more parameters come up in the next few years, which will actually talk about it. So we are still as lost as we were. Now we know that prone ventilation has improved oxygenation, prone ventilation has improved mortality, and low tidal volume. I think these 2 things are, I think, quite established. Any of your views on
Dr.
that?
Subhash, Dr. Todi?
Yeah. Just a comment, we do a lot of variables, whether it is a flow or a rate or a PEEP or tidal volume or driving pressure. At the end of the day, we want to reduce ventilator-induced lung injury. We still do not have a good bedside biomarker or whatever to assess that in an individual patient, so that whatever variables we do, are we harming the patient or not? I think that is something that we need to do more work on, that there will be, as you said, many more variables coming, but what are we doing to the patient? Are we injuring the lung more? There has to be a better validated marker for that in order to assemble, all these variables.
I agree. The markers we have now are physiological markers. If you mean a biomarker like cytokines, inflammatory markers, and so on, well, there are, for example, the studies by Caroline Calfee. We are now starting a randomized study that is based on bedside phenotyping of the patients, because now it's possible to, at least with the parsimonious model that has been developed by Caroline, it's possible to see at the bedside if a patient has a hypo or hyperinflammatory phenotype. And in this case, probably our approach to ventilation or to drugs is different in the 2 subphenotypes of ARDS. So that's something that many studies have been done, for example, measuring inflammatory biomarkers in BAL. And I agree with you that it would be very important to have a biomarker for ventilator-induced lung injury. We don't even have a good biomarker, the perfect biomarker for sepsis. So it's sort of the search of the holy grail, but it's an important approach.
Troponin of the lung is still awaited, sir. We don't know whether it would come or not.
I just have 2 points here. One is about the driving pressure. It's nothing but the plateau minus the PEEP. So if the person has a phenotype of hyperinflammatory and needs more PEEP, then are you going to allow the plateau pressures to be higher than 30? That's one question. So looking at a driving pressure is just a derivative of the plateau and the PEEP. So I don't think we should be emphasizing too much on it. And Dr. Marcus made a very, very important point on the respiratory rate. When we talk about cardiogenic shock or cardiac failure, we are always trying on one hand to improve the oxygenation, to the perfusion to the heart. And the other hand, we are trying to reduce the consumption. And here the respiratory rate being very high is a consumption problem. So we better sedate them and take care of the patient in the first 4 or 5 days and do not allow them to have a very high respiratory rate. And that's why I think the power of the ventilation has come into the practicality of management of ARDS. And I think respiratory rate needs to be looked at, because we know that P-silly also is a phenomena which happens because of the patient hyperventilating. So it's just a physiological parameter which the patient is expressing. Very similar to fever. Do you treat the fever? You don't treat the fever.
Yeah, of course. Well, if you mean respiratory rate in spontaneously breathing patient, I completely agree with you. The problem is that if you have a patient with severe ARDS, you want to sedate and paralyze the patient, and you want to target low tidal volume, low driving pressure, low plateau pressure, it's in some way, unless you have an extracorporeal CO2 removal system, in some way it's inevitable to go up with the respiratory rate. So I'm not sure that, I mean, sedating patients can be a way to reduce the respiratory rate if you want to keep a spontaneous breathing. But if you have paralyzed patients, then it's you who decide the respiratory rate based on pH. So the first observation is that driving pressure is plateau pressure minus PEEP, so it's basically compliance. Okay, it depends on compliance. It doesn't mean that you can accept. I think that you can accept higher plateau pressure higher than 30 if you can demonstrate that the contribution of the chest wall is significant to the pressure, to the driving pressure delivered to the patient. So, for example, in my unit, when you have to apply very high PEEP levels, or when you think that the patient can have a significant reduction in the compliance of the chest wall, then we measure esophageal pressure, which is not perfect though, but it's let's say a proxy of the pleural pressure, of the average pleural pressure surrounding the lungs, and then the lungs are very homogeneous. So for sure, transpulmonary pressure, there will be regional differences in transpulmonary pressure, in transpulmonary driving pressure, but it's better than nothing. So in that case, if you want to go higher, if you want to accept higher than 30 centimeters of water of plateau pressure, you probably have to estimate the contribution of the chest wall. While but it's my personal opinion, just a personal feeling, not supported by the evidence, I'm not so concerned to apply a relatively higher tidal volume, let's say to go to 8 to 9 millimeters per kilo, if the driving pressure remains low.
No, my question, sorry for the same question again, but if you have two patients, one patient has a PEEP of 10 and he is having a plateau pressure of say 35, your driving pressure is still 25 or 20, which is not what you want. Whereas another patient has a PEEP of 15 and a driving pressure, sorry, a plateau pressure again of 35. So there the driving pressure is better. So what would you actually compromise? It's all about the PEEP. Finally, you are managing the PEEP to try and allow your plateau pressures and your driving pressures, because it's just the most important part of the definition.
You'll have to sacrifice one of the things.
One of the two, which is better we still don't.
Either you decrease the tidal volume to 4 ml, then you allow the permissive hypercapnia or the carbon dioxide to go up, and use the technology to actually take it out then by like a ECOR or something. Or you allow the plateau pressure to be high. So that's going to be a difficult one. The evidence for plateau pressure is at the moment better than the driving pressure. Exactly. So I would stick with the plateau pressure below 30.
Can I have the last one? Yeah. So the overall discussion was started with the Marcus said is basically about the mechanical power. It went along, and I think the question was touched nicely. So what he meant is when we think of the driving pressure, so when we look at the work of the ventilator is pressure into volume. When we look into the power of the ventilator is the work into the respiratory rate as well. So in a certain patient, when I'm using a power of somewhere around 4 joules for 15 times, if I use that power of 4 joules for 30 times, obviously it's going to harm more. This is where the concept of mechanical power is coming, and there are the elements of the mechanical power where if you double the tidal volume, your power increases by 4, where you double the respiratory rate, your power increases by 1.4. So if we allow the permissive hypercapnia to happen and reduce the rate, of course it will do less harm because the same amount of power is being applied for lesser number of times and the villi might come down. This is what he meant, I believe. Yeah.
So you're right, Bharat, we got that. The problem is lung is also one of the most important organs which actually takes part into your acid-base control, because the CO2 starts rising, your pH drops down. Then your other problems start to arise. So that's the difficult balance to get. We agree that the power, there is no brainer that if you open and shut the lung down for 15 times versus 30 times, you're going to cause more shear injury to it. Absolutely no doubt about it. And the power is also going to make a difference.
Right. So if PCO2 of 55 and your pH is maintained somewhere around 7.23, 7.24, then we should accept it rather than getting the PCO2 to 35, because by increasing the rate or tidal volume, of course, what he said is you cannot be permitting it, but by increasing the power, you're damaging more.
As long as the permissive doesn't come and rob in my house, I'm okay with that.
And yes, and remembering the fact that permissive hypercapnia above 70 definitely increases the mortality. I think we should take a holistic approach to the whole thing, remembering all the organs are also involved in this situation. We should end the debate here, remembering William Wassler's words that medicine is a science of uncertainty and an art of probability. Thank you so much.
Absolutely. Thank you so much. The one benefit I use of driving pressure is to get my DM students to stay bedside. After the mechanical part and driving pressure has come, we just, ARDS patients, make charts. Write tidal volume, write the driving pressure, plateau pressure, that at least gets them to stay by the bedside, look at the ventilator, and think about what's happening to the lung physiology. And that itself does a lot because you're more careful about what's happening, you're watching the patient as a whole. We move on to the next talk. It's Dr. Samir Jog from Pune, and he's going to talk about non-invasive respiratory assist devices in ARDS.
Thank you, organizers, for giving this talk. This is completely different from what we heard. This is non-invasive respiratory assist devices in ARDS, which is NIRADS in ARDS. Both are short forms. Indian perspective, the VAP incidence and the severity of VAP is significant as compared to the Western country. And this is the data from Tata Memorial Hospital in Mumbai, that almost 50% of our patients develop VAP, and that too with metallo-beta-lactamase and Acinetobacter. So the one single tool which can avoid VAP is possibly non-invasive ventilatory support to ARDS, and this will be my stress on the today's talk. Of course, non-invasive support offer these benefits, but the most important benefit in Indian context is less chance of VAP or VAT. Giacomo's team did excellent work about ESICM guidelines, but they said that unable to make any recommendation about HFNO or over the conventional oxygen to reduce mortality. And they advocated that HFNO compared to conventional oxygen therapy should be given to acute hypoxemic respiratory failure regardless of immunocompromised or COVID status. This is the guideline ESICM published a few months back. And again on NIV and HFNO they wrote, we are unable to make recommendation for or against the use of HFNO or CPAP for reduction of mortality, and we need an RCT on HFNO versus NIV or HFNO versus CPAP to decide whether which non-invasive support is better. So the questions are whether HFNO or NIV for which patients, means at what level of PF ratio, what level of PCO2, what level of mechanical power we should use, upper limits of HFNO, NIV, how much we stress, and when to intubate. That's $1 million question. The whole story of NIV in ARDS started in 1995 with this Massimo Antonelli's paper in 1998, which talked about NIV can be used in hypoxemic respiratory failure. But over the years, the data for NIV or non-invasive support is quite conflicting, and the mortality ranges from 8 to 100% and 22 to 69%. So data is quite conflicting on NIV in ARDS. And in 2015, the new tool, which is non-invasive tool, came into existence, which is high flow oxygen by Florali study, which showed that there is significant benefit of high flow nasal oxygen, though intubation at 28-day rate statistically not significant, but you can see the numbers. With HFNO, the intubation rate was 38%, with NIV it was almost 50%, and conventional oxygen 47%. But more importantly, what I learned from Florali study is if the patient has got moderate to severe ARDS, that is PF ratio below 200, then there is statistical significance that HFNO can definitely avoid mechanical intubation, and it is associated with some benefit in mortality as well. So this is the scheme we usually follow in ARDS management, that till PF ratio of around 150, in mild cases and some cases of moderate, we use non-invasive respiratory assist devices. But the moment PF ratio goes beyond 150 and some other indications like other organ dysfunction or lung mechanic worsening, we intubate these patients. So Alexander Demule in 2016 suggested this flowchart for using non-invasive devices and suggested that if PF ratio is below 150, we should intubate and stop non-invasive assist devices. Brochard's review article published in New England Journal of Medicine about NIV, which told us that there is an area of uncertainty about NIV, that combination of interventions such as prone position with NIV or prone position with non-invasive methods or use of extracorporeal gas exchange with non-invasive methods can be used, but this we really don't know, we don't have data for this. And COVID gave us an excellent opportunity to study the extent of non-invasive respiratory assist devices. This is the study from Pune branch of Indian Society of Critical Care Medicine did during the COVID period of 2020 and 2021, before Laurent Brochard published his review article on NIV. So in that position, all of us has gone through that. We had significant limitation of manpower, ventilation, ICU beds. So we thought that we will take a retrospective analysis of the patient in whom the PF ratio was below 100 and what happened to them. So it was not a prospective study, it was a retrospective study of very sick COVID ARDS patients in whom PF ratio was once documented below 100 and they never got a chance for intubation because of lack of many things during COVID. We came to conclusion that almost 35% patients were treated successfully with either HFNO or NIV or both, because many times we have used sometime HFNO and sometimes CPAP or sometime NIV. 59% of patients intubated for the failure of HFNO and NIV, and 4.5% did not get an access, because we know this was a very severe condition at that time because of a lot of logistical problems, and died on HFNO or NIV. Those who needed invasive mechanical ventilation after failure of HFNO or NIV, in them the mortality was almost 87%. So this was a quite eye-opener for us. Of course, the patients were only of ARDS and not only COVID ARDS and not something else. So we cannot extrapolate this whole data to our routine ARDS patients, but this is a good eye-opener for us. So high flow nasal oxygen and NIV can definitely be useful in some 1/3 of patients, even the PF ratio is below 100. This is the study which we did by retrospective analysis. So I am not claiming that you should use in PF ratio of 100, but this can be done and has been established by us. But our multivariate logistic analysis showed that patients in whom age is above 50, presence of medical comorbidities like liver cirrhosis, chronic lung disease, COPD, or chronic kidney disease, baseline admission saturation of 90% and below, and presence of any non-respiratory organ dysfunction, for example AKI or shock or encephalopathy, some encephalopathy, not complete. These are the indications where you should not use non-invasive respiratory assist devices, and they should go for invasive mechanical ventilation as early as possible. So beyond the guidelines, just show you an interesting case in our ICU which we did. This was a 29-year-old female H1N1 ARDS, was admitted in other hospital in Pune, developed significant pneumothorax on NIV, and ICD was inserted. And they switched from NIV to HFNO and patient became relatively stable, but saturation was not maintaining adequately. So they shifted to our ICU, and her husband was pulmonologist. So he said that my wife will not have intubation, try HFNO and try extracorporeal ECMO in her. So we did awake ECMO in her. We can see the both cannula, retrieval cannula as well as drainage cannula, both are in femorofemoral. This is not femorojugular but femorofemoral ECMO. And we did this for 14 days on HFNO, and at the end of 14 days the pneumothorax resolved, ECMO cannulas were out, and she recovered and went home. I'm just showing this an interesting case, not protagonist of ECMO or not protagonist of HFNO in all cases, but this can be done beyond the guidelines. And this we routinely do, HFNO plus CPAP of 7 to 8 centimeters, this we commonly apply, and we commonly do HFNO with prone ventilation in our patients, and many patients are quite comfortable in this position. So you should think of non-invasive respiratory assist devices even if patient PF ratio is below 150 on individual patient merits. That's what I would like to say. Thank you very much.
Thank you, Dr. Sameer. Next, we have a message coming up from President, World Federation of Intensive Care and Critical Care Society, Dr. Hidalgo, please.
Hi everyone, I'm Dr. Jorge Hidalgo, the President of the World Federation of Societies of Intensive and Critical Care. And I want to take this opportunity to congratulate Dr. Pratik Kumar, the President of the Indian Society of Intensive and Critical Care, and his executive committee for taking the initiative to celebrate the ERDS Day. Today marks a significant milestone in our collective journey towards improving the understanding, diagnosis, and management of ERDS, a condition that continues to challenge even the most experienced healthcare providers across the globe. ERDS remains a major cause of morbidity and mortality in critical care units, affecting patients with a wide range of underlying medical conditions, including severe infections, trauma, and other medical emergencies. Despite of the advances in critical care medicine, ERDS presents a unique and complex challenge due to its heterogeneous nature and the diverse patient population it affects. This underscores the importance of our continued effort to refine our approaches to both prevention and treatment. The purpose of ERDS Day is not only to raise awareness about this life-threatening condition, but also to foster a collaborative environment where healthcare professionals can share knowledge, experience, and innovations. Through this exchange, we aim to enhance our ability to provide the highest standard of care to our patients, ultimately improving outcomes and saving lives. These days also serves as a reminder of the critical role played by a multidisciplinary team in the management of ERDS. From intensivists, pulmonologists and nurses, respiratory therapists, physical therapists, and all the supportive staff, every member of the healthcare team is vital in the care of patients with ERDS. It is through our combined expertise and dedication that we can make a real difference in the lives of those we serve. As we gather today, let us commit ourselves to advancing the field of critical care by embracing innovation, research, and education. Let us also remember that at the heart of our effort is the patient, the individual who places their trust in us and the most vulnerable moments in their lives. It's our duty, our privilege to honor that trust by striving for excellence in everything we do. I would like to extend my heartfelt thanks to all the organizers, speakers, and participants who have made this day possible. Your contributions are invaluable, and together we can move closer to a future where ERDS is better understood, more effectively treated, and less feared. Thank you for your dedication and commitment to critical care. Let us continue to work together to improve patients' outcomes and bring hope to those affected by ERDS. Wishing you all a fruitful and inspired ERDS. One more time, my congratulations to the Indian Society of Critical Care, leading by his president, Pradeep Kumar, and all his executive, and wish you all the best in this incredible meeting. Thank you.
Thank you, Professor Hidalgo. So moving on, we will be switching gears a bit. We'll be talking about pediatric ARDS, and as we know, over many years, the knowledge about ARDS was being extrapolated from adult to pediatrics until 2015, when the first Pediatric Acute Lung Injury Consensus Conference had a unique definition of pediatric ARDS. So to start on that, we would have Professor Brenda Morrow. She's a full professor in the Department of Pediatrics in the University of Cape Town, and she'd be talking to us about pediatric ARDS, the burden of diseases in South Africa.
Good day, and thank you for inviting me to present to your forum. I'm really presenting a very brief snapshot of a small amount of the work that we have been doing in South Africa on pediatric acute respiratory distress syndrome, or PARDS. So, as we all know, pediatric acute respiratory distress syndrome, PARDS, is a heterogeneous clinical syndrome associated with high morbidity and mortality. May be caused by acute lung injury either directly, for example, as seen with pneumonia or inhaled toxins, or indirectly as a consequence of systemic inflammation, as seen in sepsis, for example. PARDS as a syndrome is variably characterized by acute, widespread inflammation of the lungs, diffuse alveolar damage, and lung capillary endothelial injury, with associated hypoxemia. Until PALIC 1 in 2015, we really relied on adult guidelines for the diagnosis and management of PARDS, and in 2023, the pediatric guidelines were updated in PALIC 2, of which I was an expert panel member. The executive summary and 11 section articles can be accessed through Pediatric Critical Care Medicine. I was lucky enough to be one of the leads of the PALIC 2 subgroup specifically addressing PARDS diagnosis and management considerations in resource-limited settings. For me, PALIC 2 really highlighted everything we did not know about PARDS globally and specifically in resource-limited settings, including my own setting in South Africa and sub-Saharan Africa generally. I think it's worth highlighting that despite the wealth of new knowledge and research on PARDS in the last 10 years, PALIC 2 was only able to make one strong clinical recommendation. All 33 other recommendations were conditional only, based on low certainty evidence. The only strongly graded clinical recommendation for the entire PALIC 2 process is the strong recommendation to keep PEEP levels at or above the lower PEEP, higher FiO2 table from the ARDS network protocol. And that's really because a number of pediatric and adult studies have shown increased mortality if lower PEEP is used. So 2 years of PALIC 2 analysis, thousands of studies analyzed, and we could only make one strong recommendation. So clearly there's more we don't know about PARDS, and a lot more work is needed in really understanding the condition and how to manage it. When we start looking at the burden of the disease in epidemiology, the first and obvious study is the PARDI study, which I think everybody is familiar with. This is the largest multi-site epidemiological study on PARDS to date that reported an overall incidence of PARDS over all settings of approximately 3%. Severe PARDS was associated with increased mortality, and importantly, being from a middle-income country was also independently associated with increased mortality in children with PARDS. But importantly here, although 10 of the 27 study sites in PARDI were categorized as being middle-income countries, 9 of those 10 were categorized as being upper middle income. The other was lower middle income. No low-income country was included, and there was no data at all from Africa. Now, considering the burden of childhood disease and comorbidities prevalent in poorly resourced regions, which may place children at increased risk of PARDS, I really do feel it's important, in fact critical, to conduct research in low middle income settings, including Africa. If we start thinking about PARDS in resource limited settings, and Africa perhaps specifically, what we do know is that the burden of childhood disease and mortality is disproportionately weighted towards low and middle income countries, where children have considerable challenges as well in terms of the social determinants of health. Considering the burden of severe childhood disease in resource-limited settings, it seems likely that the prevalence of pediatric ARDS and associated mortality and morbidity is also going to be higher in these regions. But the literature that we reviewed during PALIC 2 really showed us that research on PARDS has not been conducted in these settings. We have research from well-resourced countries, and in fact, the recommendations for the diagnosis and management of PARDS have also been biased towards higher income contexts. From India and Morocco, we identified single-center retrospective studies from 2021, 2022, but there really are no prospective or have been no prospective epidemiological studies from poorer regions, and nothing at all from sub-Saharan Africa. So the resource-limited setting subgroup of PALIC 2 really concluded that PARDS is still poorly described in resource-limited settings. From epidemiological studies, many retrospective studies, and many of the studies not actually specific to PARDS itself, we identified a number of potential precipitating factors that are uncommon in high-income settings, but that clinicians in resource-limited settings should be aware of. These include pneumonia, which is still one of the biggest killers of children in resource-limited settings. It includes dengue, malaria, diarrheal disease, opportunistic infections in immunocompromised patients with HIV infection. And we also need to consider the social determinants of health that could increase the risk of developing or exacerbate critical illness, thereby predisposing to higher rates of and higher severity of PARDS, as well as potentially worse outcomes. Our final research statement was that research on PARDS is urgently needed in resource-limited settings. We need this to inform the development of appropriate evidence-based recommendations for these settings. And so with this background, I'd like to just present briefly some of the work we've done in the South African context. And with the time constraints, I can really only focus on the epidemiological work. But this is where I work. This is Red Cross War Memorial Children's Hospital at the tip of Africa with the iconic Table Mountain in the background. When you look at this image, perhaps you are asking whether this constitutes a resource-limited setting. And I know this argument has been presented to us in the past. Our hospital is a tertiary, publicly funded pediatric specialist hospital that provides services to children across the country, predominantly from the Western Cape. We have one of the largest dedicated PICUs in the country, and if you step into our unit, at face value, it looks fairly similar to a unit in a high-income setting. But South Africa although South Africa is classified by the World Bank as an upper-middle income country, it's also recognized as being the most unequal country in the world, with a Gini index and Gini coefficient over 60, and huge disparities between rich and poor, including access to healthcare services. Healthcare infrastructure and services are provided to the vast majority of the population through a highly resource-constrained public health system, including hospitals like Red Cross, and a much, much smaller but well-resourced private healthcare system that serves the minority of the population. The vast majority of patients, over 85%, admitted to our PICU come from areas like you see on the right here, with high levels of overcrowding, poor access to basic amenities like running water and toilets, no electricity, unsafe transportation, and poor access to healthcare services. When you look at the South African situation, in total we have just under 5,000 adult and pediatric high care and ICU beds, serving it with a total ICU bed population ratio of about 1 in 10,000, but that includes adult beds. A quarter of those are situated in the public health sector, although the public health sector serves over 80% of the population. And under 20% of the available ICU beds are dedicated to pediatric patients, and that despite children constituting more than 1/3 of the population. There's also a marked disparity in critical care services amongst different provinces in the country, with most ICU beds concentrated in the major centres of the Western Cape and Gauteng. Now, using our example, I think that the definition of resource-limited settings has to consider context and not just World Bank classifications. And this then was appropriately the definition used for PALIC 2, and one which is increasingly being used for global critical care research, that resource-limited settings need to consider a range of resource limitations. It might include being in a country classified as being low or middle income, but it also includes limited access to critical care services, limited availability of critical care services, and a lack of infrastructure and medications, equipment, healthcare personnel. So what is the situation related to PARDS in South Africa? Well, in 2019, colleagues in Johannesburg published this retrospective study of 34 pediatric patients receiving high-frequency oscillatory ventilation in the Chris Hani Baragwanath Hospital in Gauteng. 33 of these 34 had confirmed PARDS using the PALIC 1 criteria. Interestingly, this cohort represented 1/3 of patients admitted to their PICU with respiratory failure. Interestingly, prior to transitioning to high frequency, you can see that in general, patients were not receiving sufficient PEEP as per the latest strongly recommended PALIC 2 guidelines. In general, the FiO2 was very high, and you can see it was sitting at 1 for a number of patients, 100%, and the PEEP was relatively too low, according to new recommendations. But high frequency was shown to be an effective rescue ventilation in that cohort, with rapid and sustained improvement in gas exchange. And importantly, this study was done in a context where there is no ECMO support option. There were adverse events, though, related to the high frequency, including pneumothorax and and new or increasing vasoactive support. And I think it would be useful to repeat this study, considering the new recommendations, and before changing to high frequency, rather titrating to optimal FiO2 PEEP levels. And obviously redesigning this now as a randomized controlled trial may also improve translational ability of the study and allow some conclusions to be reached for the appropriateness of high frequency ventilation where ECMO is not available specifically. Now, the Chris Harney study showing that those patients constituted 1/3 of their respiratory failure patients really suggested that PARDS was a huge and overlooked problem in our context. We had no idea really of the burden of disease. So in our center, we set out to evaluate the true burden of PARDS in our PICU population. We started with a single center study, which we then expanded to multiple government-funded PICUs through South Africa, all serving patients mainly from impoverished socioeconomic circumstances. And the multi-site study really just confirmed the single-site one, so I'm only going to mention that one. So this was a cross-sectional descriptive study conducted in 8 pediatric ICUs across 4 provinces in South Africa. We collected data over 6 single study days from February to July 2022 in a standardized manner. We included just over 300 patients, and if we look at this, 71 of those patients were classified then as being at risk of PARDS using the old criteria, while 95 patients fulfilled PARDS criteria. Of those on mechanical ventilation, severity was then classified as mild, moderate, and severe PARDS occurred in about 18%. So this translates to an incidence of almost 31% of PARDS in a PICU population. This is substantially higher than previous reports from other sociogeographic settings, including the PARDI study. If we look at our patients, they were young, with a median of about 10 months old, and the majority, the trigger condition was respiratory disease. 18% were non-invasive ventilation or high flow, and 63% were invasive mechanical ventilation. And importantly here, the rate of comorbidities were very high, of almost 60%, including congenital cardiac disease and HIV infection or exposure. Respiratory disease and disease severity were found to be independent risk factors for the probability of developing PARDS, whilst male sex, risk of mortality, and receipt of neuromuscular blockers on the study day was associated with severity of PARDS, but I'm not suggesting causality in any way, which we can't do from the study design. The take-home message really is that the prevalence of PARDS in South Africa, an upper middle income country according to World Bank, but in reality a profoundly resource limited setting, was about 10-fold higher than previous international reports. And given that 3 independent studies in South Africa have reported similar rates, I think this finding is likely to be valid. And this is just of children admitted to the PICU. We didn't include those receiving non-invasive ventilation in the wards, for example. To really confirm that respiratory disease, which is still the main cause of under 5 mortality in South Africa, was the main trigger condition for PARDS and not sepsis, which may be the main factor in many high-income settings. Importantly, I think these data pave the way for further prospective epidemiological studies in the African setting. We've not yet studied the outcomes of these children in the longer term, for example. We also have the opportunity, given the unfortunately high numbers of children with PARDS, to conduct clinical trials to really identify appropriate cost-effective interventions to improve PARDS management and outcomes in this setting. So watch this space. Hopefully we can mobilize our newly formed Pediatric Intensive Care and Critical Care Africa Consortium to answer these important questions so that we really can properly understand and optimize the care and outcomes of children with PARDS in Africa. Thank you for your attention.
Thank you, Professor Morrow, for enlightening us on pediatric ARDS. And moving on, I would like to invite Dr. Arun Bansal. He'll be talking about updates in pediatric ARDS diagnosis and management, how to stay current.
Thank you so much ISCCM for giving me this opportunity. So I'll be speaking on the updates and pediatric diagnosis and management. So PALIC 2 guidelines came up in 2023. Brenda has already highlighted those. So based on that, I'll just be speaking on this, some of these issues in management of PARDS and how these guidelines have come up on the horizon based on the evidence. So the definition which is there for the definitive parts, it has some changes. They have included the invasive and the non-invasive ventilations. So they have included the oxygenation index criteria for invasive mechanical ventilation, and non-invasive ventilation has been included as PO to FiO2 ratio less than 300. And they have also said that you stratified the severity after 4 hours of the initial diagnosis of PARDS based on the severity of PF ratio and SF ratios. Then they have also come up with possible and at-risk PARDS. So the possible PARDS is when the child is on nasal CPAP or BiPAP or high flow. And at risk is when there is oxygen supplementation to maintain the saturation more than 88% but doesn't meet the criteria for PARDS or possible PARDS. What do they say about the modes of ventilation? So these are the adult study in which they have compared the pressure control versus volume control, and they did not find any difference in the mortality outcome. This is another systematic analysis from adult data on the pressure control versus volume control. They did not find any difference in ICU mortality or in the length of stay. We have some pediatric data on that, though there are not many on the various modes, but they have compared the conventional versus the high frequency, and in that they have found no difference between the outcome in conventional ventilation and high frequency ventilation. This is the study which we did in our unit at PGI, which we compared the APRV mode with the control conventional mode of ventilation, published in the Blue Journal. This study was halted in between when we had, there was observed in the intermediate analysis that in the APRV mode the mortality was quite high. So the trial has to be aborted in between, and we showed that APRV is not so safe in pediatric ARDS. So the guidelines said that there is no recommendation of specific mode for PARDS patient. So they have also included the non-invasive and the invasive, and they had said that you can divide based on the when to start non-invasive and invasive based on the severity of the illness. What are the various oxygenation targets? This is study published in PCCM in 2020, in which they have divided the patient into protocol group versus non-protocolized group. The protocol group was seen that they have increased usage of permissive hypoxemia, that is between 88 to 92%. And in that group, in which there were other factors also in the protocol, including hypoxemia, they found that there is lower mortality associated in that group. So the association between oxygenation and mortality is U-shaped. So both hypoxia and hypoxemia, hyperoxia are bad and should be avoided. But we can have certain permissiveness in that. We can go slightly low in the hypoxemia between 88 to 92. So that's what the guideline says, recommend that in mild to moderate you can target the saturation between 92 to 97%, and in severe ARDS between 88 to 97%. What about the various pressures? So there are no pediatric RCTs or observational studies in PARDS evaluating relationship between P plat and the outcome. So the guidelines say that in the absence of transpulmonary pressure measurements, the P plat should be less than 28, but in children with reduced chest wall compliance, you can have slightly higher P plats. What about the driving pressures? So this is one of the study from Gangaram, in which there is a retrospective data in which they have compared the low delta P driving pressure versus high, and they found that the children in low delta P had lesser duration of ventilation, more ventilatory free days, decreased length of stay and decreased hospital length of stay, but no difference in mortality. On the right we have the study from Netherlands by Martin Nijber, in which again it has shown that when you decrease the driving pressures, the mortality is less. So again the guidelines recommend that keep the driving pressure below 15 and the plateau pressure less than or equal to 28. How do we manage the tidal volume in this group of patients? This is again a 2020 study in PCCM, in which the higher tidal volume was shown to have independently associated with increased mortality And with every increase in ml per kg, the mortality increase, the odds ratio of increased mortality was almost 1.5 times. And there were decreased ventilatory free days associated. This is one of the study in critical care medicine in which that they have shown that the non-adherence to pelvic recommended tidal volume is independently associated with higher mortality and longer duration of hospital stay. So the guidelines recommend use physiological tidal volume, that's between 6 to 8 compared to supraphysiologic. And if you need to come down below 6, you have to remain between the targets recommended for P plat and the diving pressure. But definitely when you are going below less than 4 ml per kg, use it with caution. So these are, if your child is having severe ARDS, you can play in the window between 4 to 6, but in mild to moderate, go between 6 to 8. What do they say about the PEEP? So this is again a very interesting study by Robbie Kamani, published again in Blue Journal. That A figure is of all ARDS cases in which they have shown that the mortality decreases if your recommended high PEEP is there. If below the recommended PEEP or the protocolized high PEEP, the mortality is high, and if they go above the recommended high PEEP also, the mortality is high, and it persists similarly in if there is a PF ratio of 200 to 300 or 100 to 200 or less than 200. So the high PEEP, if as recommended, is good, and it should be followed based on this PEEP and FiO2 table, and one can titrate the PEEP based on the oxygenation, hemodynamic and compliance. And that's what these guidelines have tried to incorporate, that use the low PEEP, high FiO2 table and keep the PEEP at or above the targets which are in those table. Any recommendation on the neuromuscular blockades? We don't have any data on this in pediatrics, and it's very poorly studied. So, but the recommendations say that use it minimally, but if you have to use it, use effective neuromuscular blockade along with your sedation, and don't use sedation alone if you are not able to achieve effective and protective mechanical ventilation. So the evidence for that is with very low certainty or evidence. Any evidence on the inhaled nitric oxide? There are recent 3 good studies on that which have been published recently in last 5-7 years, but all of these have shown that there is no difference of US of INO on the mortality, but there is some benefit in improved oxygenation in one of the studies, and but otherwise there is no difference even in the ventilatory free days or other parameters. So we have very poor evidence on the use of inhaled nitric oxide in pediatric ARDS. What do we say about the prone HFOV or recruitment maneuvers? So the prone positioning, this is a Cochrane review in 2022. It was shown that if you see the mortality in the carbon dioxide and PaO2 FiO2 ratios, if they are compared, there is no difference has been seen in any of these, and it does not improve your either oxygenation or PaO2 FiO2 ratio. There are no studies on mortality on prone in pediatric patients. High frequency ventilation, when compared with CMV, and we see the any evidence with mortality or survival. This on the top is a meta-analysis of 4 studies, and on the bottom right is meta-analysis of 7 or 8 studies. Again, there is no difference between the initiation of HFOV versus CMV in these group of patients. Recruitment maneuvers, we don't have any RCTs comparing recruitment maneuvers in parts. We only have 3 observational clinical studies, and that too of a total of 57 pediatric patients. But all of them have said that it is safe to use staircase recruitment maneuver approach. But again, we don't have enough evidence to say that whether it affects your outcome in either hospital stay, ventilatory free days or mortality. Anything on the use of corticosteroids? These are again few of the recent studies which have come up after the first guideline in 2015 to now, and all of them have shown, the top 2 have shown that there is no difference in mortality, duration of ventilation, PICU stay, it doesn't make any difference. Only the last study of around 78 patients has shown that there might be some improvement in survival in these group of patients if steroids are used. So the recruitment maneuver, HFOV and prone position, they say that they cannot recommend for or against in these group of patients. Lastly, what have they come up on the ECMO? There is again not much studies or data, but that they have recommended is that patients with a potentially reversible cause of severe parts, ECMO can be considered. And if they have adequate cardiac function, use VV ECMO over VA ECMO, and you can have good outcome in individual, some of these group of patients. And that too, this evidence is very low certainty of evidence. So to summarize, this is what the whole guidelines are. There are many others, but I just focused on few of these points which are clinically relevant in our group of population. So thank you so much.
Thank you so much, Dr. Bansal, for enlightening us on pediatric ARDS. Thank you. So we move on. And as we know that there have been several definitions of ARDS in the last 57 years. And now we have a new global definition on ARDS. And to give us a perspective on that, may I invite Dr. Marcus Schulz. He'll be talking to us about that.
Thank you so much. And while awaiting my slides, first of all, I have to say that I'm always getting a little bit nervous when I see such an empty room. It can mean three things. The topic is not interesting, which is obviously not the case. I'm a boring speaker. I hope it's not the case. Or the lunch is very good, and I think that's actually happening outside. So I'd like to thank the organization for inviting me. I really like this initiative. It's very good to have a day dedicated to the topic of ARDS. It's for many complications and syndromes and diseases in the ICU already the case, but not yet for ARDS. And I really hope that this will be continued after this first session. With regard to the topic I'm going to discuss today, I have no conflicts of interest, I have no disclosures, I have not been involved in any of the consensus meetings in the past or have written in guidelines, but I do have an opinion, of course, about all these definitions. While I'm going to present, I would like you to have 4 questions in mind. I will come back on these questions later on. So, do you like to distinct ARDS from acute hypoxemic respiratory failure? Do you really like to have this complication in your hands? That you can say, this patient is having ARDS and this patient not. Then the second question is, are you a lumper or are you a splitter? Lumper meaning you put everything together in one bag and say, this is just a collection of patients, they're all having ARDS and they get a certain treatment. Or do you think we should split that group? You're actually also a splitter when you want to distinct ARDS from acute hypoxemic respiratory failure, by the way. Do you use the definition? And if you use the definition, when do you use it? Do you use it in patient care? Do you use it in research? Or do you use it maybe in education? Or maybe in all three? And do you like the phenomenon or the idea that we're having about subphenotyping? Should we continue using that? Is this a good model to think of in the future? So, talking about the definitions of ARDS, we recently were thinking a bit in a Delphi group, what is actually the problem? The problem is, it's so difficult to come with a diagnosis for something which is so hard to understand. What is ARDS actually? And when I'm talking to my colleagues in the field or colleagues at my work or to people here in the room, I think we all have a sort of less idea what ARDS is. So it's an inflammatory disease, it's related to an insult, we call it a risk factor nowadays. It's coming with inflammation in the pulmonary compartment, maybe also with some coagulopathy, and it's all leading to this complication of flooding of the alveoli and a disruption of the membrane, resulting in hypoxemia, but also into a stiff lung, low compliance, etc. We also know it's a complication that lasts for some time. It's not just there for an hour. It's something that develops and it takes time to come over. It can take several days. It can also continue for a long time and in the end actually result in fibrosis. And we know that there are certain interventions that we would like to do in these patients to prevent the lungs against additional harm by the mechanical ventilator, in this case, for instance, by using a low tidal volume or a sufficient level of PEEP, I don't know what a sufficient level of PEEP actually is, but a sufficient level of PEEP. Probably not below 5, but whether a high level of PEEP is better, we don't know. And when we're thinking about a definition, the questions are actually, are we talking about the same disease when we come with a definition? Is every patient then captured in the right way? This is about reliability. So intra-observer reliability. For instance, a PF ratio can change because of the PEEP level that you're using. It can even change by the tidal volume that you're using. And the one patient may have an ARDS definition per definition when you simply lower the level of PEEP. Is this what we're talking about? And the same could be true for imaging techniques, for instance, for lung ultrasound. There's also the question about feasibility, of course. In the real time or in the real world practice, what can we do? There has been some mention about biomarkers for inflammation, for instance, in BAL fluid, if you like. But if you cannot measure these biomarkers, and actually nobody can measure these biomarkers on an individual patient, then it's not going to work in a definition, right? And the same may be true, for instance, for blood gas analysis. If you cannot perform a blood gas analysis in your setting, does it mean that your patients are not having ARDS? Probably that's the wrong way of thinking. And then there is phase validity. It's about, are we all agreeing that we're looking at a similar group of patients? This is, of course, diving into the subphenotyping of patients. Are we talking about similar groups of patients, or are all ARDS patients alike? Well, we have learned over the last years that there may be some subphenotyping possible, for instance, by work done by this group, showing that there are different groups with, very important, different responses to the level of PEEP. In the one group, a higher level of PEEP is beneficial. In the other group, it's harmful. So then actually using the title of a paper that was already shown by one of the previous speakers, what do we do then with a new definition? What is going to change? This is a table coming from a Lancet Respiratory Medicine paper of several years ago that was summarizing all the elements or components of the ARDS definitions that were in place until then. And you count 4, and I will add the last 2 in the next slide. And what you see is that we are all more or less using the same components over the last 20-25 years, not really changing something, maybe with PEEP or without PEEP, maybe use of compliance measurements, maybe some other small things, but in fact we were always doing the same. Now we had the Kigali modification, and built upon the Kigali modification the new global definition. The new global definition of ARDS. And again, if you look at all these components, it's not really changing so much. So new maybe is that we are now accepting also an SF ratio instead of a PF ratio, that we can use lung ultrasound in addition to CT scan or the chest X-ray. And yes, maybe patients can also be not on an invasive form of respiratory support, for instance, patients with high flow nasal oxygen. So that's making it maybe more global. But is it new? I have my doubts. So what is really new and what is then global? Well, the inclusion of high flow nasal oxygen patients, but be aware that we are actually creating a 4th group. On top of the 3 PF groups, we have now an additional group, and they really behave different with regard to prognostication. So lengths of stay in the ICU or mortality is different. We have some evidence from that, but in respect of time, we will not discuss that. Ultrasound, we all like it, to use it at the bedside, but you have to be trained, and we do not actually know what are the cutoffs for a lung ultrasound score, which works best for patients with ARDS. So there's definitely new research necessary here. I already discussed the SF ratio on top of the PF ratio that can be used if you do not have access to blood gas analysis results. But be aware that, for instance, the SF or the SpO2 can be influenced by a dark skin, and we are not sure how this translates into prognostication of our patients. And finally, yes, this is a bit of a worry actually I have. If you don't have everything in place, or if you lack everything, I should say, then we can say that the patient is having ARDS. Is this not too much lumping of patients together? Especially in research, I will be very careful in just putting then everyone in one bag and say, we're talking here about patients with the same complication, ARDS. So what did we do over the last couple of months? We performed a Delphi to generate consensus statements. I would like to stress that we did this Delphi not to come to a new to a new ARDS definition. Absolutely not the case. We were just asking ourselves the question, together with a large group of Delphi panelists, what is the purpose, what is the meaning of having an ARDS definition, and what do we think of all the components and also the new parts in the new global definition? So as you can see, it was a Delphi methodology that we used. Some people here in the room have been participating as a steering committee member. We had 40 panelists, 40% of them were female. They were 33% coming from low and middle income countries, covering 6 continents worldwide. And we had 4 strict rounds in the first quartile of 2024, and then we had the data ready. So we had agreement on certain of our questions or statements, if you like. So the first question is more or less related to, should we lump? Should we have an ARDS definition? Should we really think of a group of patients that we can capture with one definition? And taking a cutoff of 80% for agreement as good, so there's a good agreement, that's an acceptable level of agreement, you can see from the clinical care perspective, it's already high, but it's even higher in research and education. So it's very reassuring, yes, we like to have an ARDS definition, maybe even more in research and education. But if you look at all these different components that have been in previous definitions or in the current definitions, it's a bit scattered what you're going to see. And I will show you now these heat maps just to give you an indication of what was the answer or what was the level of agreement that we were receiving. You see the scale on the right side, and here you can see it for clinical care, research, and for education next to each other. And what is remarkable to see is that we all agree more or less in all 3 domains that there is an important factor in timing of onset, risk factors, PF ratio, that's what we like, SF ratio is what we like, and also the imaging is what we like. So there's a high level of agreement actually in all domains. But there is also a lack of agreement or less agreement, for instance, with regard to the respiratory system compliance. We like it in research, but not at the bedside. Extravascular lung water, we like it in research, but not on the bedside. And the same, surprising maybe, for driving pressure. So we like it in research, but at the bedside, the panelists were not coming to an agreement and are actually not agreeing at all on this topic. And there are even some of these elements proposed or in the previous definitions that were not seen as very useful, here indicated with a red arrow. So for instance, plasma biomarkers, there was no agreement. And there was actually a very low agreement on whether we should use that. Mechanical power, it's the upcoming player, but there is no agreement on that. Only in research, but not in the clinical care and, for instance, in education. And so I can go on a bit. But what is more interesting is when we were asking questions about the subphenotyping. So actually, we are already doing a bit of subphenotyping. When you think of the PF risk groups for death, that's what we use. That was in the previous definitions, it's in the newer definition. There are other ways to think of subphenotypes, for instance, a recruitable lung tissue or non-recruitable lung tissue, inflammation or less inflammation. If you look at the utility of the oxygenation ratio, this was actually quite surprising. So if you look at the agreement in all domains, you can see that the whole group was saying we do not agree on using the PF ratio or SF ratio alone. If it's in combination with something else, it's maybe something to work with. For instance, a PF ratio that stays low for a certain period of time, like 24 hours later after standard of care or best possible care. There seems to be more agreement with regard to the subphenotyping. As you can see here, it's most of the time in research and the need for future research, but in clinical practice agreement stays a bit low. definitely means we have to do more research there. And there were other remaining research questions, as we called them, and this was an open part of the Delphi, so the panelists could give their feedback on what was left undiscussed by our statements, and there was a clear indication that we needed to talk about inclusion of patients on non-invasive devices. Lung ultrasound, there's much research needed there, according to what the group was saying. SF ratio, can it really replace the PF ratio? More research is needed. And finally, the topic of subphenotyping, which is attractive to think about, but it's in clinical practice difficult to use. So coming back to those 4 questions that I asked you at the start of my presentation, do you like the distinct ARDS from acute hypoxemic respiratory failure? Are you a lumper or are you a splitter? Do you use the definition? And if so, when do you use it? And do you believe in subphenotypes? Based on the Delphi, I think we can say, well, you like to make this distinction. So we like to have an ARDS definition. That was a clear message that came out of the Delphi. Well, we are lumpers, but actually would like to be splitters, but we do not know how to split our groups at the moment. And we use it in care, we use it in education, and we use it in research alike, and we are absolutely not sure about the future of subphenotypes. And future research is definitely needed to see how we can implement the information that comes from the present studies into clinical care. This I would like to stop and give back the word. Thank you so much for inviting me and for giving this lecture.
Thank you, Dr. Marcus, for this, giving us these wonderful insights. Can we have a few questions from the floor?
Thanks, Marcus. I'm curious about your opinion. Do you support the distinction between ARDS and acute hypoxemic respiratory failure? Your personal opinion, not the Delphi.
My personal opinion is no. That was actually the main driver for starting to have this Delphi or this Delphi study in place. I'm not so convinced, and actually quite of my work in research was focusing on non-ARDS patients. So if you do not like the idea of ARDS patients, so to lump them together, what's then the sense of the lumping to the other side? That's a question I ask myself more and more nowadays. But let's be honest, a patient with a PF ratio of 320, is it different from a patient with a PF ratio of 290 if all other components are the same? It's just a cutoff that we use and say, based on the cutoff, this is a group of patients that is having the per definition ARDS, but it's a man-made decision and it's not driven by the real statistics.
Thank you. Thank you, Dr. Marcus.
You're welcome.
We move on to an interesting short panel discussion on the pros and cons of the global definition in ARDS, for which may I invite the panelists, Dr. Bharat Jagyasi from Mumbai. Dr. Marcus, you would need to be on the dais again. Professor Grasselli, Dr. Sharmili Sinha from Bhubaneswar, Dr. Prachi Sathe, Madam from Pune, and Dr. Ashit Hegde from Mumbai. And to moderate the session, may I invite Dr. Subhash Todi from Kolkata.
Thank you. Thank you, organizers. You know, most of the points have already been discussed, and I was trying to find out what are the points which are left that we need to discuss on global definition. So I thought about some of these. Let's start with the concept. You know, whenever you read the global definition or ESICM guideline, the first thing is the conceptual framework. And all the conceptual framework starts with, it has to be a low compliance entity. So my first question would be to Dr. Schulz, During COVID time, there was a concept of L-type and K-type, low elastance, high compliance ARDS. It has never been mentioned in any of these, either ESICM or global. So is that an obsolete entity? What's your opinion on that?
First of all, if we look at the Delphi results, the panelists are not having the same opinion. They don't think that the compliance should be used. Now, the reason for that is that measuring compliance or calculating compliance could be too difficult.
True.
And I agree, that could be a problem. Going more deeper into what you were saying with regard to the two different phenotypes, as it was called, or subphenotypes, with regard to compliance in COVID-19, it was found very early in the pandemic, but thereafter there have been no reports that confirmed its existence or its presence. So one of the things, and I'm not sure, one of the things I think what happened is that maybe very early in the COVID pandemic, too many patients were intubated with relative good compliance, but because of their severe hypoxemia, they were immediately intubated, and that was a patient group which has a remarkable good outcome. Later on, we were more intubating patients that were having stiff lungs, if you like that concept, and those patients, of course, having a higher mortality. So I think the subphenotype, with a high compliance in COVID-19, was actually created by us. And later on, when we learned about how we could treat COVID-19, it disappeared. But I'm curious to understand
Dr.
from the others what they think.
Can I just make one comment?
Yeah,
here?
Prachi, just a short one, because a lot of things.
I wonder whether a same patient, when he is going through the whole trajectory of ARDS, develops different types of compliances and different characteristics of the lungs. That is why we cannot really divide it.
Ashit, short
That's
one.
what I mean, traditionally we think that ARDS has to have a poor compliance. I mean, I understand that this was early on, but still it was ARDS, wasn't it? I mean, it eventually evolved to low compliance, but...
initially it was high...
but it's still qualified as ARDS if you...
That's right. Dr. Giacomo, any comments? Dr. Griselli?
Well, you know, I published some papers that, and I'm convinced that COVID-19 is ARDS. I mean, at least from the definition standpoint, is ARDS. Of course, COVID is a disease, ARDS is a syndrome, and so a disease must have some peculiar characteristics. So the classical model we have in mind that the severity of oxygenation is dependent on the amount of intrapulmonary shunt that you have. So of the amount of collapsed lung is a bit different in the early phases of COVID-19, where probably you have more a problem of inhibition of hypoxic vasoconstriction and so on. Still, if you want to talk about compliance, I mean, the normal compliance of the respiratory system of a healthy man is around 100 ml per centimeter of water. And so if you see 50 ml per centimeter of water is still reduced compliance. And there are studies on the lung safe, a secondary analysis published by Panvar in the Blue Journal that shows that even in the lung safe patients, so before COVID, a good proportion of them had a compliance above 40 ml per centimeter of water. So personally, I think that I completely agree with Marcus. I mean, in the early phases of some diseases, you may have more compliant lungs. The point is that you should recognize that because you should adjust your ventilation to that. I mean, it's probably not rational, not rational to apply 20 centimeters of water of PEEP to a guy who has 50 ml per centimeter water of compliance. That's it. But
thank you. I think one of the reasons of these definition is to catch ARDS early. As I read the global definition, use of HFNOs, and also that we can catch ARDS early. And one of the concepts of this L-type was probably some of the diseases might have more a vascular involvement rather than an alveolar epithelial involvement, might be more hypoxemic and might not have that compliant problem. So that there is a conceptual difference. So coming to risk factors now, At one time, we used to say pulmonary and extrapulmonary because, pneumonia and aspiration are pulmonary risk factors. And sepsis, pancreatitis, trauma, burns are extrapulmonary. They are all, as we said, lumpers and splitters. They are all termed into as a risk factor for ARDS. And is that definition still tenable, or they do not matter? Bharat, what's your opinion?
No, sir. They usually risk factors, if you say per se for the definition, do not matter, because what we are looking into, in my opinion, is a syndrome. So whatever may be the reason it has caused, so of course we have to go with that. And the risk factors we identify, it's important in a way, because we identify those risk factors, and if some preventive measures comes in and we are sure about it, then we can be working it. But when it concerned with the definition or diagnosis, then risk factors, I am not sure.
Okay.
I think you can split patients in many different ways, or groups of patients, I should say, not the patient, of course. You can even split based on gender and say you have females and males, and maybe there is a difference. But for me, this splitting, this subphenotyping only makes sense if it's having consequences. For instance, the way you are going to ventilate a patient or set a PEEP level. And latent class analysis showed us different phenotypes, or suggest there are different phenotypes. This phenotype of pulmonary versus non-pulmonary or extrapulmonary is not coming out of that. But the interesting thing is that the latent class analysis is also suggesting that these groups, if you make them, are having different responses to treatments. And I think that's very important.
If at all there is a different response to the treatment.
Yeah, response to therapy might be different into these two classes.
No, I think usually what begins as pulmonary ultimately becomes extrapulmonary. When you have a pneumonia, but eventually there's systemic inflammatory response as well. So
once it goes into multi-organ failure, but to start with, as a risk factor.
In the past we thought that pulmonary uses, less PEEP, and extrapulmonary, all that, they're more like, but like you said, all the differences are no longer prominent, but probably ultimately everything becomes a systemic thing. I don't think.
So they are probably not that important. At one time people used to differentiate. Another risk factor is tropical infections. We have like leptospira, typhus, typhoid, dengue. They can present as ARDS, and they will fulfill all definition of ARDS. Do they have the same prognosis, the same trajectory? Anyone from the panel? Sharmili, what do you think?
Yes, I think that's a very important point you raised. And in this part of the world, we have plenty of cases of these tropical infections, and dengue, scrub typhus, I think, are topping the list. And in my experience, I have seen coming from coastal states that plenty of cases of these cases who present with tropical infections, that is mostly scrub typhus and dengue, they present as multi-organ dysfunction to start with, and they'll have a predominant involvement on the lung as well as part of the multi-organ derangements. But they are the ones compared to the classical ARDS that we talk about, like say COVID pneumonia or pulmonary pure pneumonia related aspiration related ARDSs. They do very differently, and they do better actually. And they are the subset of cases I think we should be more aggressive, because despite their severity of illness, if you do their Apache or SOFAS course on day 1, day 2, their performances or recovery is much faster. Recently we had a case actually, she as a 35-year-old lady who presented with severe ARDS and acute kidney injury. These were the two predominant organ dysfunctions which lasted throughout her course, and hemodynamics were stable. She was somehow maintaining on the non-invasive ventilation for a long time, but we are surprised to see that disproportionate to her radiological appearances on the X-rays and to her renal functions and the metabolic derangements on the blood gases, she was holding on. On day 3, we got the report of scrub typhus positive, and on day 5, she was absolutely out of organ support, coming down to a few liters of oxygen, and you discharged her. But the difference between scrub and dengue related ARDS is what I have noted is, dengue is much more florid. There will be high grade of fever, but scrub typhus may not be having those kind of fever, and it is a bit more indolent to evolve, but dengue is more florid and it comes out in a very fairy manner compared to scrub typhus. So yes, I would agree in summary that this tropical infection related ARDS has seemingly got better prognosis compared to non-tropical related ARDS, and in this context this global definition does matter, because most of us, including African and some part of the South America also, come under this category of resource limited categories, where blood gases may not be available, but on the downside of it, including this ultrasound B lines to relate or to find out this lung consolidation areas also might have a catch, because I would be surprised like if the areas do not have facilities of blood gas analysis, having an ultrasound also may not be possible in these areas. So I think that is a caveat that needs to be addressed.
I think some of these ARDSs in the tropical diseases may be ARDS mimics, whether you would call a diffuse alveolar hemorrhage, which most of the dengue and leptospira with bilateral infiltrate and hypoxemia turns out to be, whether you call it because histologically they might be completely different from a diffuse alveolar damage. So that is one of the problems in, I think, of the tropical disease induced ARDS. And the second is, ARDS is conceptually cytokine mediated disease. And in, like for example, in falciparum malaria, the lung biopsy had shown malarial parasites into the capillaries of the lung. So they are not cytokine mediated lung disease, and if you are treating the malaria, the outcome would be definitely be better than a cytokine mediated lung disease. So there might be a subtle difference, and probably more work needs to be done on that. Since we have quite a few to cover, so I will skip to the exclusion criteria. You know, most of the guidelines, they have just one line on excluding cardiogenic pulmonary edema. And they have mentioned, you know, the previous definitions were on pulmonary wedge pressure. Now they are saying echocardiography. I understand the systolic heart failure, but most of our patients have diastolic dysfunction. So how do we exclude heart failure from non-cardiogenic pulmonary edema if it's a predominant diastolic dysfunction? Any of the, what are the tools? Is it echo? Because echo is not very good for diastolic heart failure.
Yeah, can I?
I think it's important to read from the new global definition that it's not saying you should exclude it, but it should not mainly be caused by. And I think that's a nuance that is very important, because quite some of our patients are having, as you say, diastolic dysfunction, and then you would exclude them from the group having ARDS while they have everything regarding to ARDS.
But in order to know that whether it is mainly diastolic heart failure,
so
then
there would be
you know
some trigger factor as well. If we go by the history, if we take it, of course, if it's a purely diastolic failure, then history would be immediate sudden onset rather than going back and looking into the history of the fever of the patients. Or
so you have to look for risk factors and the timing.
Risk factors, timing, and associated symptoms, comorbidities. No associated symptoms.
So,
I mean, what exactly the patient.
So not a very good gold standard way of excluding heart failure.
We could consider using NT-proBNP
Pro-BNPs and markers like that.
See, it is in ideal world we can say cardiogenic and non-cardiogenic.
But they might be mixed.
There can be mixed. There are so many things which are mixed. And in other exclusion criteria like atelectasis or something. But as Dr. Marcus said, it is not completely exclusion criteria.
Right.
It is with that super added ARDS. It is not purely that.
Actually, if you look at diastolic heart failure component, diastolic component completely contributing as a predominant contributory factor for causing ARDS is very, very unlikely in isolation. It would be combined with, it will be very difficult to completely isolate diastolic dysfunction if it is existent. Echo is one of the factors and second, one of the tools, and second will be a pro-BNP. Pro-BNP, if it is in thousands, it definitely indicates myocardial dysfunctions, and definitely it has got a contributory factor. But apart from diastolic dysfunctions, I would, many times it strikes to me in clinical practice, suppose we just talked about this tropical infections of scrub typhus and dengue for that matter. How do you exclude completely there is no component of scrub typhus myocarditis or even dengue myocarditis for that matter? So it is difficult technically and the from the physiological point of view to completely isolate these two components. What Dr. Marcus says, I agree, is a predominant, if it is systolic heart failure, we see that flooding of those alveoli in the spaces, and that could be causing significant hypoxemia, which would call for ARDS. But diastolic dysfunctions alone causing hypoxemia to that degree is usually not so seen in clinical practice.
So one can have both. These can coexist, and one need to identify in every individual patient and treat them accordingly. Coming to, I will skip the timing, coming to the setting. You know, I think the use of high flow and use of SpO2, FiO2 was basically to take it in a resource limited setting. I will take it one step forward. If a patient is in ICU, you know, if you have high flow available, doing a PF ratio might not be that difficult to you. Question is, can we identify hypoxemia, a moderate to severe hypoxemia in the ward where we do not use high flow? Can we identify ARDS in general wards? I'm sure patients are who is hypoxic in the general ward. What is their PF, what is their SF ratio? Because, you know, the standard nasal cannula or face mask, the FiO2 is very much variable. It depends upon the minute ventilation. So any thoughts on that? In that setting, we assume as if the patient has come into ICU, but most of the patients come into the ICU from the wards.
Yeah, exactly. But in the ward, we are monitoring what is called as MUSE, early warning signs. And a patient who is becoming dyspneic or starts requiring maybe nasal or at least the mask oxygen would obviously come to ICU, and then the further identification process would start by putting them on.
But what is their criteria of hypoxia? That's what I was interested in. What is their SF ratio?
It is, I don't think it is SF ratio that is mentioned in the MUSE criteria which we are
No, that's the
using.
general criteria of severity.
Yeah.
You know, MUSE and the others. But that is
So
something I have not seen it being mentioned in the global.
May I make one correction in what you were saying? I think HFNO is now included not because it's possible then also to have patients in low and middle income countries to get a diagnosis of ARDS, but simply because HFNO is more frequently used. If I look in my ICU, I'm not sure if it's the same in your ICU, but in my ICU, most of the patients that come with acute hypoxemic respiratory failure first get a trial of HFNO. And whether that's good or not, I don't know, but I see it happening. And it's also what we saw in COVID-19. In COVID-19, the first waves, we intubated many patients. Later on, we started to learn that with HFNO, a large group of patients could be managed. Now, the question that is coming now is it correct to say that the patient that is having this form of respiratory support can also have ARDS, or is that then a different patient? And it's coming maybe back to the question about this low versus high compliance. A patient that can be managed with high flow nasal oxygen because of hypoxemic respiratory failure, or acute hypoxemic respiratory failure, can fulfill the ARDS definition, but might be a complete other group with regard to prognostication and also therapies as compared to a patient on a ventilator. And this is what was a lot of concern about in the Delphi group, and I remember that there was also a lot of discussion within the consensus group that came with the new global definition. Actually, they write it in one of their tables, this deserves more research. And what also came out of the Delphi is that we have quite some concerns that there are no cutoffs given for FiO2 and the airflow with high flow nasal oxygen. And this may matter as, of course, for the PF ratio, if you calculate it, or the SF ratio.
Any other thoughts? Because HFNO is not used in the wards. So how to just
using pulse oximetry, and as long as you don't give, like they said in this definition, the saturation should be less than 97 because once
but
it's
we
100,
don't have the FiO2.
PO2 is. No, but so once it's less than 97, you have a reasonable, and then less than 300 is what they mentioned, 325 or something. So as long as you don't use a pulse ox saturation of 100, because at that time saturation becomes completely unreliable. It could be
true, but if you have a saturation of 96,
you know it is somewhere around, less than 100. You know the PO2.
True, but a saturation of 96% in the ward does not mean he might have infiltrates in the X-ray.
The nasal prong, have the rough correlation between the, the FiO2 you have for every 4
That's a low flow
per liter. You have a rough, but does it really matter? I mean, I think all this is really important if you're going to do research, but if you're going to treat him, I don't think it really matters whether I think this is really more for the inclusion criteria for a research, but in actual practice, I really don't think we treat them any differently, like somebody said.
Yeah, we keep on increasing the oxygen flow, and once it reaches the maximum, still hypoxic, you transfer. But just to think about what would be the roughly estimate, as we are saying that in HFNO, if you have 30 liters flow, that is what the definition said, and you have a fixed FiO2, then you can calculate the SPF FiO2 ratio, provided SpO2 is below 97%. So coming to this oxygenation device, the high flow nasal oxygen, the cutoff was 30 liters. Why was that taken as 30 liters in HFNO? Any of the panelists?
I think they said that can be some amount of PEEP with that. I mean, at 30 and above, that's what the...
But HFNO, if you open mouth, there is zero PEEP, even if you have 30 liters.
That is their logic. I am not saying
So what do you think, Prof. Marcus?
Well, there are other beneficial effects of high flow nasal oxygen apart from the oxygenation and maybe some PEEP when you close your mouth, etc. And I think that the literature that they found was suggesting that 30 liters would be a nice cutoff to use. If it's correct, it's a question, we don't know. But that's where the 30 liters is coming from. It was not that, like, let's stick up a finger or let's do some voting. This is based on the literature.
Dr. Grasselli?
Yes, two things. First, I agree with Marcus, the idea of including patients on HFO is because HFO is really used now very frequently. We used it also in the ward, for example. Second point is, I don't know if we need a flow cutoff, but for sure we would. I think that we need, not only for SF ratio, but also for PF ratio, we should probably have also an FiO2 cutoff, because this ratio change a lot with FiO2. So if you have 200 of PF ratio with 40% of FiO2, it's completely different than you have 200 of PF ratio with 100% of FiO2. So this is something that is lacking in the Berlin definition, in the new global definition, and also timing. So timing not really related to how much time elapses from the risk factor to the diagnosis of ARDS, but are we really sure? I mean, you have a patient with ARDS, let's say with acute hypoxemic respiratory failure, bilateral infiltrate, and you exclude that it's mainly due to cardiogenic pulmonary edema, effusion, or atelectasis. Then you intubate those patients. How many of those patients, if you ventilate them with a reasonable tidal volume and PEEP, will fulfill the criteria of ARDS after 24 hours? Because if you look at the ROSE study, for example, on neuromuscular blockers, after 24 hours, those patients, many of the patients were on pressure support.
Yeah.
And this is something that Jesus Villar, with his temper very, keeps repeating, but I agree. I mean, most of our patients, immediately after intubation, they have ARDS, especially if they were dyspneic and using their muscles to breathe. When you paralyze them, you put them to sleep, and you intubate them, they have ARDS. If you measure a blood gas immediately after intubation, a certain percentage of them don't have ARDS after a few hours.
Yep.
And so if we believe that ARDS exists, those do not have ARDS.
So one should have a remeasured, say, after X number of hours, and if they are still fulfilling the criteria, they might be the ones who have probably the true ARDS. And
maybe, I don't know.
Dr. Villari actually used that criteria to put in the DEXA study that he did. He waited for 24 hours, and the patients who fulfilled the criteria of moderate to severe ARDS at 24 hours.
Yeah, but he did that for a purpose. Huh?
Yep.
He did that in his studies to have an enrichment of
enrichment,
the group, having
yeah,
a higher
prognostic
mortality,
enrichment,
which from a research perspective is very attractive to use.
Yep.
But from a clinical point of view, and also from an education point of view, is not making too much sense. Maybe I agree with my friend here saying, listen, if you intubate a patient, PF ratio and the chest X-ray are saying to me the patient's having ARDS. And are we now incorrect in saying that after a couple of hours, when I have using a higher level of PEEP and maybe put the patient in prone position, that the patient is not having ARDS, but I'm giving treatment. If you say a patient is having a septic shock, but I give a catheter and I give norepinephrine and then the shock is gone, the patient is not having shock anymore, that's of course not true. We are giving treatment for that. And it's making it more and more complex. Of course, the one patient in which you say, after 3 hours, everything is gone, patient is on 5 PEEP, 21% of oxygen, this was not ARDS, per definition. It's against the whole construct. Yeah. But the patient that continues 10, 15 centimeters of PEEP, I would consider that having ARDS, even if the PF ratio is not fulfilling the criteria anymore.
Sure. We have 4 minutes left. I will open it to the audience if they have any questions to the panelists on the global definition, or I would go along. You know, the 2 big positive trials in critical care, there are very few trials which are positive. One is prone ventilation and one is low tidal volume. Both were on older definition, the older Berlin definition, and low tidal volume was even before that. So in what way do you think this new global definition, do we require a big RCT on this definition, on some new paradigm? So what is your vision on the utility of this new global definition? Any of the panelists?
To be honest, I think this is not necessary to repeat those studies because there might be a subtle change in the definition, because I really think that the new global definition is a subtle change. But, and this is another point, and this is a personal view I have, and I'm not sure here, I'm curious to understand about the other thing. The one positive study, low tidal volume versus high tidal volume, for me, the outcome is not that we should use a low tidal volume, but we should not use a high tidal volume. And then we have to realize that those patients were included in around 2000, 1998, 2000. I remember very well, it was at the start of my career, these patients were heavily sedated and had neuromuscular blocking agents for many days. It's completely different from the patients we see nowadays. Patients come in, we give HFNO, we intubate them if necessary, but we go for spontaneous breathing as soon as possible. We prone these patients much earlier. And it could be that we can accept, and I think you were saying it as well, maybe we should not be afraid of a tidal volume of 10 if the driving pressure is low. Maybe that's just normal. And if people then say to me, but there is this ARMOR trial that says that you have to use this, then I say, yeah, the ARMOR trial was 25 years ago. A lot has changed since then.
So any final comments from the panelists?
I would just like to add one thing. The way this definition has been modified from Berlin and with this KIRLE modification has been accepted, I would imagine to incorporate one more line in this definitions, like they have incorporated this NIV, HFNO of 30 liters and NIV of certain pressures. Also to probably, as you raised one question once about few liters of oxygen going in the ward, how to pick up those patients. Probably for the resource limited setups, probably some few liters of oxygen maybe for a patient who is on more than around 3 to 4 liters of oxygen. They also should be picked up, as you said, like for their SpO2 if you are recording. And then the PF ratio can be, or the SpO2 FiO2 ratio can be calculated, and they can be also screened, or an alarm can be raised so that they could be brought to high dependency unit or intensive care units for further monitoring and early intervention than not. Because if the definition, all the purpose or intention has to be to include and detect those patients early, then might as well we can include this liters of oxygen, because in COVID times we have all seen a horde of patients where they're just requiring higher oxygen. We didn't have enough HFNO to cover to all those patients, and we have kept those patients on 4 to 5 liters of oxygen. They were just tachypneic, but their work of breathing was not there. They were not in respiratory distress, as we classically see. So those group of patients, if they are habitating in the wards, probably this few liters of oxygen, if you add one more line in this global definition, that would make it more complete, and especially for this resource limited setups, where they can be probably picked up early than not.
But that's a different system altogether. That's a low flow system, and what we are looking into is the high flow system. So the system which has been incorporated, high flow system, with the assumption saying, okay, we have some good perfusion of oxygen inside, which is keeping on the high flow at least, and the high pressures, and which is keeping some alveoli open, so that we mimic out those versions of ARDS which would be picked up in the ward, like someone who has a pneumonia. Of course, the SpO2 ratio will be less. But when you infuse a high flow into those patients, SpO2s will improve. So system is not the same.
Validity might not be there.
50 liters is a low flow system. It's not.
NIV, as you say, the HFNO, when you say 30 liters of oxygen, but if the mouth is not, I mean, if the mouth is
that is for the PEEP.
then it's not causing any.
There is no PEEP in that. But if you see those patients, even with the 30 liters, they are not able to speak. The amount of perfusion is going inside.
Oh yeah. The FiO2 is fixed. In HFNO, you dial the FiO2 and that's what they get. And so I think our time is up. Samir, you had a question? Please.
Hello. Can I ask one provocative question?
Yeah, go ahead.
Yeah. There was an editorial published by Jolly Vincent and Arthur Slutsky in 2020 in Intensive Care Medicine. And the heading of that editorial is, "We have never seen a patient with ARDS." I repeat, they have written the editorial called, "We have never seen a patient with ARDS." On this background,
what was the reason for that? What was the bottom line?
The bottom line is, we just want to diagnose the primary disease and treat it and use lung protective ventilation, that's all. We don't require any definition or any separate syndrome of ARDS.
That's what Professor Marcus said. You know, this was the question which was put in the Delphi. Do we need ARDS or not?
No.
And
well, actually, Art Slutsky, the one you were mentioning, is a member of the steering committee, and we posed that question or that statement actually to the panelists. And if you ask the panelists, do you agree or not? They say, we agree. You should make a diagnosis of ARDS. But to be honest, I am on the other side. I think I don't need to name or to have a name for a complication or for a syndrome that I only partly understand, and I make probably many mistakes. Only if it makes sense with regard to the therapy. And if I ask you, not you personally, but if you take care of your patients, if a patient is having a PF ratio of 350 or 290, do you apply lung protective ventilation? Probably you will do it in both. Right? And that's the question. So the question is, are you a lumper or are you a splitter? And actually, we want to be both. Because of different reasons. Because of how we perform education at the bedside, how we give certain elements of care, or how we perform research. And in research, we want to use maybe other groups or create other groups than in a larger group for other reasons than whether it's going to work or not, an intervention, I mean here. What do you think?
Thank you. Thanks a lot to the panelists. We'll wind up. The debate will continue. At the end of the day, we'll have to take care of our patients to the best of our ability. Thanks. Thanks a lot.
Thank you to all the panelists and the moderator for a wonderful session. And I think after 6 hours, if we land up with a question that have we ever seen a case of ARDS, that demands the next topic. So to address these nebulous areas, we have the next talk on ARDS, why we need to have a fresh perspective. And to deliberate on that, may I invite Professor Dhruv Chaudhary from Rohtak. Sir, over to you.
Good afternoon, everybody. I think most of these things have been discussed, but the question which was asked on that day, as far as the talk was concerned, was why we need to discuss and what should we look at it in terms of ARDS. I think it's, two things are extremely important when we are looking at If I look simply ARDS as in the way it started in 1967, that it is adult respiratory distress syndrome as we see infant respiratory distress syndrome. If you see the two components which over a period of time have got refined, answer is very simple, it is not a disease. This is basically what we are seeing here. It is an arbitrary term used to describe a large spectral disease leading to epithelial and endothelial injuries in the alveolus. That's what we are looking. Can somebody do it? I can see it on the screen here, please. Excuse me, gentlemen. I'm not able to, all right, I will see it there in front of me, right. So it is basically to describe a large spectrum of diseases which lead to the injury of the alveolo-capillary membrane. And it reminds me sometimes that what we see in patients of kidney injury, especially in the setting of nephritic syndrome, because here you have an air as well as a blood overlap with the two basement membranes. There you have a tuft of bacilli, a tuft of vessels in which you have a solid tissue also. So looking at it, the inflammatory disorders which happen, there is a so wide variety which is there. And we today know that you have a minimal change, focal segmental, diffuse proliferative glomerulonephritis. We don't have that sort of pathology to define different characteristics of ARDS with us. So I think that becomes an important issue with us. And the causes are so varied and we are trying to lump it together. As a student of medicine, whenever there is a syndrome, we always talk in terms of a lumping of symptoms together and then trying to find out what has caused it. Like you have a patients of coming to you with the fever post-monsoon, we all call them as an acute febrile illnesses or monsoon malady or tropical illnesses, because sometimes it is becoming different for us to do it and each may have a different treatment required which is needed. So rather than a specific protocol for ARDS cases, the underlying disease causing ARDS should be addressed. And what Samir Jog was asking about that editorial makes some sense. But nevertheless, as one of the panelists said, we need to have a holistic approach as well as a segmental approach. That's what we are looking at it. Now, when we stop out diagnosis of ARDS without going further into what leads to it, I am a physician by choice. And obviously, as an internist, when I look at it, I always see whenever there is a patient who has come to us with an acute lung injury, what is the cause? What has caused it? Because you need to treat the cause. What you are treating all the time, and we're talking about the consequence of a disease. If you see it in patients of scrub typhus, which is a tropical syndrome where they are all edematous, the day edema starts settling down, the lung starts healing too. Therefore, I think it is very, very important for us to understand the disease processes which are causing acute lung injury. No doubt about it is an acute lung injury. If you can have an acute kidney injury, why not acute lung injury? So respiratory support, the oxygen, they are the ways and means of providing support system. They are there, but they are not primarily the panacea or the treatment. And that is the fundamental mistake which we are doing it. It's not that we don't have to do, we dialyze the patient. No doubt you need to give oxygen, you need to give ventilation, and as you go up, you may provide an ECMO. Because whenever there will be an inflammation, it needs time to heal. The tissue needs time to heal. I think that is important, and that's what we buy, and along with it, we try to ensure that oxygenation takes place. So these are the various causes. I have taken it from the Lancet, which a beautiful article, 2 series, which has come up, which explains a lot of things which we have been discussing. Look at it, nothing working together. The only thing common is the physiological phenotypes which we are seeing in terms of which we are defining acute lung injury or ARDS in mild, moderate and severe form. And now we are looking that probably in indolent form come up what you call in the nephrology as a rapidly progressive renal failure. And you are defining them in terms of 1 to 2 weeks, 2 to 4 or 6 weeks, and then chronic respiratory failure. So I think it is extremely important what we are looking at it, what we are defining. But when you are talking about all these things, please never ever forget the underlying disease causing that inflammation. Now this is a cartoon which tells you the normal alveolo-capillary membrane on the left upper side. Then you have an alveolar inflammation if it is coming primarily from the respiratory cause. Then you are having something which is coming from the systemic cause that helps you, that affects the endothelium. And obviously we have both endothelium and the alveolar epithelium is involved, you have a full-blown picture of it. No wonder when you see the classical ARDS picture which have been defined had a low predominance. But when you saw it during the COVID, when practically everything was involved, it could have been any lobe which has been there, and same way when aspiration is there or whenever inhalational injury is leading on to there, you may have a dominantly upper or middle lobe involvement. So it is important for us to understand what is the basic pathophysiology, which has basic etiology, which has initiated that pathophysiology. That's why we need to have a relook, not only simply ARDS. What has caused the ARDS, and can I identify certain subtypes which already has been discussed in terms of phenotypes or subphenotypes or endotypes in order to have a better outcome. Because in terms of oxygenation, already you are reaching to the levels which we are coming up in terms of optimal outcomes, and now we are looking at it, the injury which is being caused by the mechanical ventilation. Therefore, that also leads to a question, do we need to use ECMO earlier so that we can provide these patients an adequate amount of rest so that healing takes place? I think these are the questions which have started coming up. I won't go into details of the pathophysiology, and the way forward people have tried to give a complicated name of prognostication, enrichment or predictive enrichment. But what is very important, if you see it, what the comparison has been done with the lung cancer. We used to make a diagnosis of a lung cancer. Today we know if it's a non-small cell, I have 18 different types, whether it's an ELK, whether it is an EGFR, whether it is an exon 19 or exon 21, etc. So same way now we need to look at ARDS, what are the specific etiopathogenesis and what are the factors, when during all these periods we tend to forget what are the host factors. Why the same illness is triggered in A patient, this ALI, whereas in a B patient it has not been able to trigger it. So we need to understand that component, what is causing acute lung injury and ARDS. So what is missing? Already on the definition, I won't go, Professor Schultz has already talked, and I happen to be participated in that Delphi sphere. Second is the etiology, we are underplaying it, and by and large somebody said that we need to exclude everything. Then it comes into the domain as we see acute exacerbation of COPD. You rule out every other cause, and the small segment which stays most dominantly with the viral etiologies become an acute exacerbation of obstructive pulmonary disease. But when you see it here itself, the same thing, I put it up, that etiology, viral pneumonias, where will you put it up? All end of the day end up causing your hypoxemia, severity of which decides the outcome besides other multi-organ dysfunction because of these chemicals or the cruise missiles which the body has released. So pathology becomes an important, and that is where the role of the dual CT is going to be coming up more and more important, because biopsy is a problem. Kidney we have been much easier. Here it is much difficult. So we hardly know any data from the dynamic phases of the ARDS, that what is happening at the alveolo-capillary level. What we are coming to know primarily either from the animal models or we are coming to know primarily from the postmortems. But what is happening in between what we do it, that is why the so-called mimics, they do so well, because you identify diffuse alveolar hemorrhage, you identify acute interstitial pneumonias, you identify pneumonias and you treat it. Whereas you are not able to identify the cause, etiopathogenesis is not very sure about it, except that we presume that it is a sepsis somewhere which is the commonest cause, that is also associated with other multi-organ dysfunction. That's why you are finding the challenge. So we need to look at it, that what is causing, what defining it, and how we have to go it. So the role of dual energy CT scan is going to be very important, which can pick up microthrombosis, which has been done very elegantly by it during the COVID epidemic. And therefore you will realize it, that if your D dimers are shooting up, is there a microthrombosis which is happening, like we talked about in what discussed in the COVID, that is pulmonary intravascular coagulation, which is a component of the inflammation but has not been given due attention in ARDS. Immune modulation. COVID has shown us that probably when you are finding after an illness it is more than 7 to 8 days, then you start getting liver lung dysfunction, that probably there is something wrong with the immune modulation, there is something wrong with the immune reactions, and probably when you start looking at the cytokine syndromes, one component is the lung, another component cytokine syndrome is the cardiovascular system. So is it a part of a cytokine storm which is happening, and can we modulate it? That is the question which is there. If you treat it, what are the answers? One is physiology, which we look, outcome, yes. probably there also the role of the CT needs to be evaluated in the setting of the trials, whether it is making a difference. And obviously that means that we need to refine the parameters which we are looking in terms of outcomes of these patients. I think these are the few questions which need definitively an answer. And with this, I leave it to your food for thought. Thank you very much.
Thank you, sir, for the wonderful lecture. We move on that despite whatever we have discussed and despite all the therapeutic advances, why do we fail to improve outcome in ARDS? To speak on this, may I invite Dr. Rajesh Mishra from Ahmedabad.
Hello, am I audible? Is it working? Am I audible to all you? Okay, fantastic. So, thank you. I'm not going to talk anything negative. The talk looks like why we fail. I'm just going to try to summarize whatever has been spoken so far since morning, why we fail to improve outcome in ARDS patient. Can I have my next slide if it's not working? So, if you see the history of mortality, when we came to know about ARDS, where it was 70 to 80% mortality, and then somewhere in 2000 we realized that lung protective ventilation improves outcome, and that has been a major drop in the mortality. And after that, we have been not doing very great. Even ECMO came, even driving pressure came. Mortality remains in different setting according to the cause around 30 to 40% or maybe 50%. So why it is so? Can I have, it's not working. The first thing about the factor. ARDS, as everybody say, is not a disease, it's a complex syndrome where the trigger factors are different, pathophysiology is different, it's a dynamic process, and there are other related complications and comorbidity with the patient. And most important thing, we lack targeted therapy in ARDS. Whatever we are doing in ARDS is just symptomatic and supportive treatment. Nothing we are doing as a definitive treatment. So this problem, okay, have you changed too much? Can I go back? Can I go back? Okay, fine, and up. So if you try to understand the pathophysiology of ARDS, which everybody has explained, is first is the neutrophil trigger, followed by macrophage activation, and then it leads to the inflammatory hyper response. But this doesn't happen to everybody. This doesn't happen to all pneumonia. This doesn't happen to all trauma patient. Who is the patient who will get this kind of problem? We really don't know. And that is one of the problems we fail to recognize, and that creates problem. And at the end, when we have injuries, we get this kind of lung injuries, where we don't know in what phase of ARDS we have. We don't know is it really ARDS, something else we are treating, and that's another problem which we find difficult to treat. So whatever treatment we are doing in ARDS is a respiratory and cardiovascular support. We are not doing anything to really handle the neutrophil function. So since our treatment is not specific, so outcome is also not great, and that's where we fail. Again, this neutrophil dysfunction do not happen to everybody. As I said, it may be happening that somebody is very immunocompromised, they get bad pneumonia, but they will not get ARDS. Who will get ARDS? Whose neutrophil go out of control to cause that particular ARDS? We fail to recognize that subgroup of patient. Why it happens, we fail to recognize. Since we don't know the problem, why it is happening, we are not probably getting solution for that. The immunological and metabolic consequence which attacks the pulmonary endothelium or epithelium is unexplained. Same kind of hypermetabolic response will not cause same kind of injury in every patient. Which patient will get what kind of injury and what extent of injury, we really do not know. Again, it's unexplained. Probably, if we ever able to change outcome of ARDS, probably when it will be a specific disease and which probably modify its consequence or consequence of the neutrophil activation. There are some data coming from animal study which shows that if we do the gene-specific therapy to control the ARDS activation, which might change outcome, but we have to look to that. ARDS diagnostic criteria has evolved from 72 or 74 to till that time. It's more of the research value. Honestly speaking, it is same, it remains same confusing. This criteria really helps in identifying ARDS early? Probably no. It may be to categorize which category of ARDS we have for research purpose, but can be diagnosed early. Can be, like suppose an example of the GB syndrome. We know that if somebody has developing progressive weakness, you do NCV and there is demyelination, you are quickly able to diagnose even before CSF, GLG severe. But do we have any criteria? Even there are thousands of debate about oxygenation criteria. Are we dealing with ARDS or something else? So if you cannot diagnose the disease, and as I am a physician, everybody says I am a physician, I am also a physician. So very simple rule, if you cannot diagnose, you cannot treat. There is always delay in recognition and diagnosis of ARDS patient, even patients who are at risk for multiple reasons, and that's why we fail to change the outcome of ARDS. I have deliberately made this photograph. There can be thousands of reasons for this kind of picture, but they all look like same. And ARDS mimics it, one of the biggest challenges. The problem of ARDS mimics recognition is one of the biggest challenges. Most of the differential diagnosis which comes, they either need expertise or some of the invasive tests, which we do not want to do in any of our hypoxic patients. Maybe it is acute interstitial pneumonitis, maybe eosinophilic pneumonitis, maybe aspiration, viral pneumonia. Until we know the specific cause related with the history, real acute exacerbation of non-infective ARDS, which has a relatively very good prognosis, and unfortunately, when we deal with these patients who get secondary infected, everybody become ARDS, probably we miss the primary pathology. Outcome of these patients are much better than really inflammatory ARDS. So ARDS mimics are missed many times. In some of the studies has shown 20% of the time ARDS mimics are missed, and that again contributes to your mortality. Immune dysregulation. We know that when neutrophils are being hit, it causes hyperinflammatory response followed by hypoinflammatory, that is immunosuppression. But unfortunately, we neither have anything to control hyperinflammatory response or elevate the hypoinflammatory response. So that's again case. Once your disease has progressed from cellular activation to inflammatory mediator related problem, we do not have anything to control that. We can just wait and watch till patient either recover as shown. We do not do any secondary insult to the patient, and then patient gets better or goes home or goes somewhere else. But unfortunately, we do not have anything to treat this phase. Research. We have been working so much on ARDS. It's a heterogeneous disease. It's not a syndrome. We do not have we cannot design a very specific criteria because so much of variation in diagnosis, patient category. So if we cannot find right category of patient, what kind of intervention we are doing, we will not able to change the outcome. There have been a lot of trial in specifying the disease according to the high mortality group, so low mortality group, phenotyping of disease, agree. But it can really tell us that its prognosis is bad here in this subphenotyping based on the inflammatory response, injury type, what is the lung pathophysiology and cardiovascular change. But does it really help me in treating my patient or treating especially? Probably no. So with that, thank you for your attention, and that's what I have to say. I'm happy to take any question if anybody has.
So are there any questions from the audience? So if there are none, thank you, Dr. Mishra, for the wonderful talk. We go on to another message from one of the pioneers in ARDS, Professor Lauren Brochard.
Dear colleagues from India and other people attending the meeting, I wanted to celebrate with you this ARDS Day, and I think it's a great opportunity for the Indian Society of Critical Care Medicine to do that. ARDS has always been one of the syndrome which put everybody together. Even if we did not understand exactly what it was, we made a lot of progress for the benefit of the patients. And as you all know, we are still discussing strongly about the definition, because we have new ways to manage patients. We have new advances in the definition of the biological aspect of ARDS, which would help us to differentiate different forms of the syndrome. We have made enormous progress about non-invasive and invasive ventilation. And I know that these techniques, including all forms of non-invasive ventilatory support, are very familiar to most of the people in India doing intensive care. And ARDS has also been an opportunity to collaborate, to create links, and to create networks of people interested by improving the care of our patients. So very happy for you. Sorry I'm not here with you, but I'm really happy of your celebration and hope you will enjoy it and make it something memorable. So happy meeting and happy ARDS Day. Thank you very much.
Thank you, Professor Brochard. We go on to an interesting talk on ARDS phenotyping by Dr. Carolyn Calfee. She is a professor of medicine and anesthesia at the University of California.
Hi there, my name is Carolyn Calfee, and I am honored to have the opportunity to speak with you today on World ARDS Day. I'm sorry not to be able to be with you live and in person, but I'm pleased to have the opportunity to talk with you today about ARDS phenotype. These are my disclosures. So I think we all, as critical care practitioners, know that critical illness, including ARDS, is defined by syndromes. And while we think of those syndromes as distinct, for example, sepsis on this slide being life-threatening organ dysfunction caused by a dysregulated host response to infection, and ARDS as acute hypoxemic respiratory failure with bilateral radiographic opacities, not primarily due to heart failure. In reality, these are very blurry syndromes that do not represent, in fact, discrete pathophysiologic diagnoses, but a mix of different underlying pathologies. And the way we define these syndromes, for example, ARDS, has really changed very little, in fact, over the past now 57 years that this syndrome has been in existence. This is from the original description of ARDS published in The Lancet in 1967, a case report of 12 patients with bilateral chest radiographic opacities with fluid in the lungs, hypoxemia, stiff lungs, not primarily due to heart failure and occurring in the setting of a primary risk factor. And while some of these features have changed around the margins, the essence of the global definition of ARDS, published earlier this year in the Blue Journal, really remains the same. Now we've quantified it so that it can be present in intubated patients, non-intubated patients, and in resource-limited settings. But at its heart, this remains a syndrome defined by signs and symptoms. But if we think about the wide variety of patients we actually see with ARDS, and here are two represented chest radiographs from patients in one of our ICUs in San Francisco, both patients mechanically ventilated, both patients with bilateral opacities. We think, well, okay, these patients both have ARDS, but do they really have the same process going on in their lungs? Well, in fact, one of them had vaping-associated lung injury associated with e-cigarette use, and the other had COVID-19. So does it really make sense to think that these two entities would be treated, certainly from a pharmacotherapeutic point, the same? It may or it may not. And while we've cured mouse ARDS many times over, we have really never found a drug that's consistently effective for human ARDS. Now, corticosteroids is on that list with an asterisk. Of course, despite trying to ask this or answer this question now for over 5 decades, we still don't have a total consensus on the field on whether or not corticosteroids work for ARDS. But here are some of the many agents that seemed so promising, only to really fail in translation to large-scale human studies. And we can think about lots of reasons why that might be, but one of them might be the heterogeneity of these patients. I think we actually do understand the pathophysiology of ARDS fairly well right now. I'm not going to review this in detail since you're all here at World ARDS Day, presumably because you're interested and you think a lot about this. But I think we really do understand a lot of the pathophysiology now, much better than we did certainly 5 decades ago, yet we're no farther along in terms of pharmacotherapies. So that gets us to this question of whether reducing the heterogeneity that's inherent to a clinical syndrome like ARDS might help solve our problem. We can think of this as that old expression in medicine. Are we lumping things together? Are we splitting them out? We can think about this as splitting. We can think about it as precision medicine if we'd like to sound fancier, but it's really just this idea that if we can identify more homogeneous subsets within this broader syndrome, we might do better at finding treatments. And in other fields of medicine, this approach has had great success. So think about breast cancer, where hormone receptor status has a profound impact on the way these tumors respond to treatment. BRAF receptor status in melanoma, or a little closer to home as pulmonologists, Th2 high versus Th2 low asthma. So could we potentially achieve similar progress in critical care? What about in ARDS? So how could we think about splitting up ARDS? And there are many ways that we can think about doing this, and in fact this concept has been discussed and debated really since ARDS was originally defined. Some of these ways we think about often in practice, like Berlin Severity, which may dictate whether or not we use treatments like proning or ECMO. Some we talk about more, but don't quite affect our practice yet, like pulmonary, non-pulmonary, or focal, non-focal. And we can also think about splitting patients based on biological processes, more endothelial dysfunction, more epithelial injury, for example. I would argue that I think we're looking for a way to split our ARDS patients in order to identify treatment responsive subgroups. So we can split them 10 different ways till the cows come home, but the real question is, can we identify groups that respond differently to treatment? So one way to approach this problem is by letting the data tell us what the subgroups are. And our group has used an approach called latent class analysis. That's a type of statistical modeling that's based on the hypothesis that there are distinct subclasses or subgroups within a broader heterogeneous group of patients. So if you see the figure on the right-hand side of the slide, it asks the question, does that data distribution in the black line better reflect one homogeneous group or actually 2 underlying latent classes? And with modern computing now, we can ask this question of dozens of different variables simultaneously and test the hypothesis regarding the best fitting number of classes. Importantly, this can be independent of clinical outcomes. In other words, you can just tell the computer, just look at all the data you have when a patient comes into the ICU, and don't look at what happens to them afterwards to try to find these subgroups. And it's explicitly not driven by treatment response. So even though I said I think that's why we care about subgroups, these subgroups are not sought on the basis of treatment response. So when we've done this in ARDS, we actually find a very consistent signal of 2 distinct phenotypes in patients with ARDS, and more recently, we've extended this work to sepsis. These phenotypes are characterized by differences in inflammatory biomarkers in the plasma, and so we've termed them hyperinflammatory and hypoinflammatory, even though we're not really sure that's the most important pathophysiologic difference between the groups. They have widely divergent clinical outcomes, as I'll show you in a moment, particularly mortality, and they've now been replicated in more than 10,000 patients in adults and pediatric populations, in randomized control trials, and in cohort studies. And importantly, even though we didn't use treatment response to identify the phenotypes, they do appear to respond differently to treatments in secondary analyses of numerous randomized controlled trials, including PEEP, fluid management, simvastatin, and activated protein C. This just gives you a sense of the markers that define these phenotypes. This figure shows the continuous variables that define the phenotypes on the x-axis, sorted by their standardized variable value from highest difference between the groups on the left, biggest positive difference rather on the left, to biggest negative difference on the right. So the variables that define the phenotypes are those that are on the extreme edges of the diagram. And you can see right away that the so-called hyperinflammatory phenotype, which is about a third of the patients consistently, is defined by higher levels of inflammatory plasma biomarkers like IL-6, IL-8, TNF receptor 1, and PI1. That group is also defined by lower levels of bicarbonate, of protein C, reflecting disordered coagulation and fibrinolysis, and systolic blood pressure. Now, interestingly, ARDS risk factor is different between the phenotypes in that non-pulmonary sepsis is more common in this hyperinflammatory phenotype, but it does not discriminate between them. So this is not just, for example, sepsis versus trauma. Pneumonia, for example, is evenly split between the two groups. So I mentioned earlier that the clinical outcomes of these two phenotypes are quite different. This table shows mortality by phenotype in selected studies of ARDS patients ranging from the mid-90s to the mid-2010s, and you can see throughout that period that the hyperinflammatory phenotype has in most cases double or more than double the mortality of the hypoinflammatory phenotype. Even in pediatric ARDS at the bottom, where mortality is quite low, fortunately, the hyperinflammatory group does much worse. All right, now what about this difference in treatment response? I'm just going to show you an example of this from the HARP-2 trial of simvastatin led by Danny McCauley and published in the New England Journal in 2014, simvastatin versus placebo, no difference in survival. But when we stratify by phenotype, in fact, we now do see a difference in survival. With the hypoinflammatory patients in blue, it really didn't matter whether you were randomized to simvastatin or placebo. And in contrast, in that hyperinflammatory group here in orange and pink, the patients who were randomized to simvastatin had significantly better survival. Now, this is a secondary analysis. It needs prospective validation before it affects our treatment, but it really suggests that there's been this treatment-responsive subgroup hiding within this broader population of patients. This is a similar type of figure from the Prowess shock trial. Now we've actually moved to sepsis. As I mentioned before, these phenotypes are just present in sepsis in essentially the same way they are in ARDS. And you can see here that we see, again, a similar pattern where if you're in that hypoinflammatory phenotype, in fact, you do worse if randomized to activated protein C. And the opposite pattern is true in the hyperinflammatory phenotype. So how has this changed my practice? Well, it hasn't. Not yet, anyway, and that's because, as I mentioned a moment ago, I think prospective validation of these findings is essential before we start letting it influence our care for patients. So will this be realistic, and how might it be accomplished? Well, we've been working hard for the past several years in order to translate this type of work to the bedside. This is work that's been led by my colleague Pratik Sinha, who's pictured here, to use biomarker-based classifier models comprised of 3 to 4 variables, or clinical data-only classifier models that use machine learning to identify the phenotypes. These appear to be accurate for classification in retrospective studies with areas under the curve of 0.88 to 0.96, and prospective validation is now underway in 2 different studies, including the FIND study, which is testing real-time phenotyping using measurement of IL-6 and TNF receptor 1, has completed enrollment actually of 520 patients in the UK. And the I-SPY studies in the United States, led by Laura Esserman and Clark Files, have enrolled over 250 patients in a similar real-time phenotyping effort. So these are really testing, is it possible to measure these assays in the time frame we need them in a critically ill patient so that we could think about doing a clinical trial. And in fact, that clinical trial has been designed and will be starting in summer 2025. It's called the PANTHER trial for Precision Medicine Adaptive Network Platform Trial in Hypoxemic Acute Respiratory Failure, or PANTHER. It's being led by Danny McCauley from Queen's University Belfast. This will be an international phase 2 precision medicine trial doing real-time biologic phenotyping for inflammatory phenotypes in a platform trial format. The population will be adults with ARDS with either hyper or hypoinflammatory phenotypes. The initial interventions will be either simvastatin or baricitinib, though it's a platform trial, so new interventions can come into the trial. The comparator group will be usual care, and the outcome will be 28-day organ support-free days. This is the design of the trial in brief. Adults with ARDS are enrolled and phenotyped in real time using measurement of IL-6 and TNFR1 into the hypo or hyperinflammatory phenotypes. Both groups are then randomized to standard of care versus the interventions I mentioned before, and then each of the phenotypes can be compared within the phenotype, the active treatment to usual care in an adaptive design. So to conclude, are we, as this recent perspective in Nature Medicine posited on the cusp of the precision era in critical care? I think we might be. This group of international experts posited that we are transitioning from what they termed the acceleration era of critical care into a new era where we have precise classification of our patients based on underlying biology that's really augmented by translational critical care research. I think we're nearly there. A lot of these studies that I mentioned to you, like the PANTHER trial, will really be a test of whether or not this approach has legs or will really benefit our patients. And that's really what we're here for, to try to make a positive impact for our patients. But the data we have right now suggests that we might be moving towards a framework where, out of our old paradigm of categorizing patients in syndromes, we start to think about a new paradigm where we categorize patients on the basis of treatable traits that may cross those syndromic diagnoses. So to summarize, there are many different ways to split or phenotype the heterogeneous syndrome of ARDS. Biological phenotypes of ARDS have been identified in more than 10,000 patients and appear to extend to sepsis as well. These phenotypes appear to respond differently to numerous different treatments and secondary analyses of clinical trials, and may be what we think of as a, quote, treatable trait. Real-time phenotyping methods appear to be feasible in clinical studies, and the upcoming PANTHER trial will test phenotype-targeted treatment. Thank you so much.
Thank you, Professor Carolyn Calfee, for a wonderful talk on ARDS phenotyping. More and more research is being done here to provide personalized and precision-based critical care to our patients. So another question that comes up in the next short panel discussion is early extubation in ARDS patients. So whether we are early or whether we are late, we'll be discussing in this. And for this, the moderator is Dr. Srinivas Samvedan from Hyderabad. Sir. And the panelists for these sessions are Professor Marcus Schultz from Switzerland, Professor Eliza Estensoro from Argentina, Dr. Pradeep Kumar Bhattacharya from Ranchi, Dr. Gunjan Chanchalani from Mumbai, Professor Syed Mohid Ahmed from Aligarh, Dr. Anand Dogre from Nagpur, Dr. Swagata Tripathi from Bhubaneswar. May I request all the panelists to be on the stage. Over to you, sir.
Okay. Thank you, Saurabh, for that introduction, and happy to be here, and thank you for giving me this opportunity of engaging this very learned and distinguished panel on what looks like an interesting topic for discussion. We've all been discussing about invasive ventilation from morning, what it can do, what it cannot do, and now we are going to talk about how about early extubation in ARDS. So we'll first start with Dr. Gunjan. May I ask you, why is this discussion actually needed? Why do we need to have this chat at all?
Thank you, Dr. Srinivas.
So since morning we have been listening to a lot of discussion about what is ventilator-induced lung injury, how barotrauma, volutrauma, ergotrauma is working with the ventilated patients in ARDS. So getting them off the mechanical ventilation as early as possible to reduce all these secondary injuries to the lung is what is the need of the hour, and that is the reason why it's mainly needed.
Dr. Marcus, would you like to add something more to this?
Yeah, I would like to rephrase the words a little bit. It's not early extubation, but timely extubation, and timely meaning as early as possible, with safety for the patient and outcome of the patient in mind.
Okay.
I'm very much in favor of that, because I think even if I like mechanical ventilation a lot from research perspective, education and giving care with a mechanical ventilator, I also am aware of causing harm.
Okay.
A lot, actually.
Right. So when we started learning about ARDS
I would like to add something about this. Because I agree with you, Marcus, no? To prolong mechanical ventilation, well, we know that it is damaging, no? Because if we prolong mechanical ventilation, well, more days in the ICU, more days in the hospital, and a greater possibility of ventilator-induced lung injury. So patients are more exposed to damage. But on the other side, there is good evidence that extubation, failure of extubation, produces damages too.
Yeah.
It is associated with greater mortality.
Yes.
Nobody knows why exactly, but it seems to be that a failure extubation or extubation failure could be connected to an ongoing deterioration that has not been diagnosed. So I think we are in a narrow path, here. On one side, we have to be afraid of being too conservative, but on the other side, we have to try not to hurry things, because this could also be bad for patients.
Okay.
May I then add just one extra thing?
Yeah.
I think that over the last 5, maybe 10 years, things are really changing. That we have entities like high flow nasal oxygen. We did not provide that to ARDS patients or acute hypoxemic respiratory failure. After extubation, we are doing that more and more, and we see that we save patients with that. If that translates in a better outcome of these patients, or it's still associated with a worse outcome, as you are suggesting, we don't know. So we are entering a new area with new modalities, which still makes me in favor, but I'm aware of what Elisa is saying. We have to be very careful, because too early, meaning could be more harm.
May I say something?
Yes, sir.
No, there are two sides actually. How much early is too much early, and how much late is too much late.
Yes.
So you have to balance. This is what I understand.
Okay.
And you have to decide the right time. So you think about the right time.
Yeah.
I would like to say, what should be the criteria on the basis of which you say it's early or late?
Right.
So you've got to set up a criteria that this is, of course, my target is this. Once you achieve that target, probably is the right time to go ahead with it. So you can naturally, otherwise, obviously, if you you take it too early, you might have an extubation failure. So you might have to re-intubate, and then re-intubation adds to your mortality.
Okay.
So that is the basic point.
Sorry, Dr. Dongre?
If I agree with everyone, but if I tell you this extubation early extubation in ARDS is not exactly early extubation in ARDS. It is basically a term which has come from rapidly improving ARDS patients, which were found in this ARDS NET trial. Almost 10 to 15% were rapidly improving ARDS patients, and they were extubated. They could be extubated on day 2 to day 4, and they were out of mechanical ventilation or out of support by day 7. So this is the word which has been coined because of this subgroup of patients which were found in ARDS trial.
Okay. So we go forward. When we started learning about ARDS when we were trainees 24, 25 years ago, we learned first about volutrauma, then we were taught about barotrauma, then atelectrauma, then biotrauma. Now is the era of ergotrauma, right? You talk about mechanical power. So does the concept of mechanical power, does it have any role to play in your consideration of trying to liberate these patients with hypoxemic respiratory failure from invasive mechanical ventilation? We'll go Dr. Eliza first. Mechanical power, does it have a role to play in having this discussion about early extubation of patients?
It's for me?
Yeah.
Okay. Well, I don't know if it has a role. It has not been, I would say, systematically looked for, because we are speaking of patients that are getting better, that are that have spontaneous breathing trial, that they are improving in general, no? And for the other point of view, well, mechanical power is the energy transmitted by the ventilator. So maybe in these patients that have in this phase of ARDS spontaneous breathing, it's difficult to measure mechanical power.
Yeah.
It's controversial, which is the value of measuring mechanical power, because the force is that the ventilator execute or give to the patient or transmit to the patients are opposite to the spontaneous intents of the patient. So they collide and they overlap.
Okay.
So it's controversial what means the value.
Yeah.
So there are some, I would say, studies. One study from your group, no, a very interesting study, which was recently published in PLOS One. Would you like to comment it? Because I prefer you to comment it. But
I think you're referring to a study in which we looked at the effects of automated ventilation, so a form of ventilation in which everything is in the hands of the ventilator and no longer in the hands of the user, which is tidal volume, respiratory rate, etc. And interestingly, this automated mode results in less mechanical power. But I have also a little bit of doubt, because if you look at how the ventilator is then getting to less mechanical power, it's simply a reduction in respiratory rate. Because you set the ventilator so that it's allowing a little bit of permissive hypercapnia. And then, of course, it will do what we doctors or nurses do not want to do or just forget to do, and you result in less mechanical power. If I think of the concept of mechanical power, I like the concept or construct or the idea. I like it a lot. It makes sense, right? Every energy you put in a system may result in heat or harm or whatever. But the question is it now mechanical ventilation, power caused by the mechanical ventilator, or is there also power generated by the patient him or herself? And it can be during spontaneous breathing on a ventilator, but also a patient that is spontaneously breathing without the help of a ventilator. That's then what we call PSILI, if you like that approach. And I think we have to hold this all in mind. But it's extremely difficult if you look at the calculations that we use, the equations that we use for calculating mechanical power. I sometimes don't understand how they work, because they're way too complex. I'm a simple-minded person, so I have to admit sometimes I don't know what I'm looking at. If you compare them to each other, they are giving very different numbers or results of the calculations, but we also don't know how, and this is what Elisa already was saying, we don't know what the mechanical power is of a spontaneously breathing patient on a ventilator, and not even what a patient is doing him or herself when it's not being supported by a ventilator. So for all these powers, if you like, all this energy, I don't know. But if you ask me, can you reduce mechanical power by early extubation? The answer is yes, because the mechanical power I create with the ventilator is per definition zero at the moment I move away with the ventilator. But what happens to the patients and the power generated by the patient himself, I don't know.
But what I liked for that is, from that study was that the values of mechanical power in those patients that were on controlled ventilator, no, being whatever the group was, well, were high. But the mechanical power of the patients that were spontaneously breathing in both of the groups were lower than the groups on controlled mechanical ventilation. So that lower, what does it mean? Is an underestimation of mechanical power because of that collision between two two opposing forces. So it's difficult really to
Yeah.
to understand the concept in a patient who is spontaneously breathing. Yeah.
Pradeep sir, would you like to add to this?
Even after extubation, I say that the distress of the patient is continued. So you see that yes, although we have extubated, but patient is in discomfort. So then how you are going to define that yes, where is the role of mechanical power? How you are going to evaluate that?
Well, in that case, could be a case of what silly patient-induced lung injury. That could be the case, exactly.
Yeah, I thought, see, if you take it this way, that primarily whenever the patient is on a ventilator, primarily what are we doing? We are supporting the patient's respiration. Ventilator is not a management, I mean, it's not a therapy. I mean, it's not an antibiotic. It is primarily what we are giving as support to the patient to overall reduce its work of breathing, to overall reduce his energy, overall. And it's again at the same time it's giving a support to the lungs characteristics, internal characteristics. So whenever the patient is on a ventilator with a support, probably the mechanical requirement, the energy requirement will be reduced, provided it is given an adequate support and it is synchrony with the mechanical ventilatory parameters and mechanical support, the mode especially. But whenever the patient is not with the same support which he requires to generate a tidal volume or respiration, then probably the patient is working more. Okay. So the synchrony is very important, the support is very important, probably then we will reduce whatever power you're talking about. Yeah. So that's very important.
So from theory we go into practice. Okay, we all now understood that we have to consider appropriate timing of liberation from mechanical ventilation. So what category of patients should we consider for this strategy of early liberation? We'll start with Dr. Swagata first and then Dr. Dongre.
So I've been listening to the discussion till now very well. I'm a very simple-minded person. Like I said, I believe in standing next to the patient's bed and looking at the patient. And I think what we all heard here is that any respiratory failure, especially ARDS we're talking about today, is primarily a disturbance of the respiratory drive on top, along with the structural disturbance in the lung parenchyma that causes a diffusion abnormality. The component which is actually possibly leading to the mechanical power or the trauma of the added trauma to the lungs is either when we ventilate the patient on a ventilator or we do not support the patient enough and the patient is ventilating spontaneously. But the idea is the same. It's just the drive being allowed to take very deep breaths or at very high rates. We're just trying to avoid that. Either it is self-induced or it is ventilator-induced. But there is that thrust of extra work done on the lung which damages it. So which kind of a patient is more suitable for early extubation? First of all, even a tube in the mouth is traumatic. That can add on to the discomfort and the drive. So the things that we want to look at is if a patient was having a high drive, the first things we're looking at is that drive coming down, which is the background disease to a large extent. Is he now breathing better on the same support than he was breathing earlier with less sedation? So is the sedation coming down appropriately? Are the pressures coming down appropriately? And then yes, as everyone over here agrees, with the kind of infections that happen in our ICU, we really want to get the invasive tube out. So the question we ask ourselves every day is, why should I not extubate this patient? So what are the reasons why I don't extubate the patient? Does he need too much sedation? I cannot extubate. Does he have too many secretions that will not come out on an NIV or an HFNO? Yes, I cannot extubate. Is the lungs not better? I cannot extubate. If the lungs are still, if the drive, like I said, is too high, I cannot. But if they don't start, if they are saying no on all these points, then I would definitely like to extubate in a timely manner as soon as possible.
Okay, Dr. Moed, Dr. Anand.
Well, as she has pointed out all the parameters or monitoring systems, respiratory wise, as we are talking about ARDS, this in near future, I might be going for IL-6. That give me a phenotype, whether this phenotype will go for early extubation or late extubation. Number one. Number two, at current scenario, I'll go for PaO to FiO2 ratio. If it is more than 200 to 300, I'll definitely look at him, whether we can do extubation or not. And then pulmonary index, ROX index, those are the oxygenation parameters which are there. If they are well within limits, then I will go for an extubation or think of an extubation. Then respiratory mechanics, I look at the ventilators. I find that PP is around 10 to 12, not much, and patient is breathing at a comfortable rate. Yes, I will think of an extubation. So these are the category. And as far as the causes are concerned, extrarenal, other than pneumonia, yes, I will think first. Say poisoning, snake bites, other pathology. Cardiac, I will try to improve the cardiac functions and then get them extubated first.
So Dr. Mohit,
yeah, whatever he said is absolutely on the dot, but I would like to add some recent things like diaphragm excursion test. If you do an ultrasonography, probably that helps you to see whether the patient is going to sustain your extubation or not. Or, you know, diaphragm thickening fraction can also help you out. So these are some of the findings which probably can help you out to see whether the patient is going to tolerate your extubation. So otherwise, or whatever he says, and then basic what is important is the underlying pathology is nearly, like for instance, if you said we can now extubate at the PaO2 ratio by around 100, 150. So that again, we need not make it absolutely on the dot, but we can achieve that and then extubate, because we know that after extubation, we have another system which is going to support the patient, especially the HFNO and the NIV.
Dr. Marcus, would you like to say something?
Let me try to put this in context. Although I'm working or have been working in Amsterdam in a so-called rich surrounding, my hospital is not rich. So we had to work with our hands and just looking at very simple things, and we were not allowed to do all kinds of difficult measurements because they were distracting, costly, taking too much time. And there were actually two things, and I liked very much what you were saying. You were saying like, you have to look at the minute ventilation of a patient. If the minute ventilation is normal, meaning not too low, but also, or certainly not too high, then you have probably a good chance that you can extubate the patient. If the PEEP level is low and if the FiO2 requirements are reasonable, it should not be necessarily 25 or 21%, 30 or 40% could be good as well. And if you do not have a severely positive fluid balance, and those are the arguments that we are using and have been using for 20, 25 years, and our reintubation rate was always very low. But those four things counted a lot. So if one of them was not all right, do your job first, or wait for a longer time before you take the tube out.
Sir.
From the clinicians, I as a clinician, I will not see the reports or investigation, but what is happening to the patient, that is more important. I'll disconnect the patient from the ventilator and put the patient on TPs. If the patient is tolerating comfortably TPs trial of a half an hour, I think, and maintaining all the hemodynamics, heart rate, blood pressure, saturation, everything is fit for extubation. I think that is the simplest way to go ahead, see and extubate.
So Dr. Gunjan, of late, high flow nasal cannula, high flow nasal oxygen has come in a big way, and we are probably very impressed with the way it can deliver CPAP a little bit and give you graded FiO2 delivery. Where would you see HFNC as an adjunct or a friend in your decision making for early liberation of patients from invasive mechanical ventilation?
So when you talk of early liberation from mechanical ventilation, there are two choices.
In ARDS.
In ARDS, yes, yeah. Yes. In ARDS, I'll be very specific. So there is, of course, NIV and there is HFNC. When I look at these two parameters, NIV has a little higher risk of PCL because of the pressure support that we give, and if the respiratory drive is very high, it can actually deliver a larger tidal volume, and which could be harmful. Whereas when we look at HFNC, what we really get is a CPAP, a continuous pressure, which really is not ventilation, but more of just a CPAP continuous pressure, which can help to prevent the atelectotrauma or keep the lungs open. Another advantage that we have with the HFNC is the humidification that it gives maintaining it throughout the day where the patient can talk, eat. We do not have this off time periods when we can lose the CPAP, and maintaining the ciliary function. So overall, I think it would go a little, I mean, as a personal way, I would prefer HFNC over NIV because of the disadvantages with NIV give. But yes, if somebody cannot sustain the tidal volume with HFNC, NIV is the way out.
So since you raised the issue of NIV, we will go to Dr. Marcus. Where does NIV come into play for early liberation of patients with ARDS from invasive mechanical ventilation?
I'm afraid I'm going to give a little bit a different answer, or an answer in a different way. And I think it's very much depending on what you're used to do or what you can do. And let me try to explain that a little bit more. If you are having a team that is experienced in applying NIV, then probably with NIV you can do a lot. If you're not experienced with it, and for instance in Amsterdam I know my team, unfortunately I must say, is not experienced with it, it always was a failure. So that's one part of the medal. On the other hand, if you do not have HFNO, you cannot use HFNO, that's clear. But also think of what happened in the COVID-19 pandemic with oxygen scarcities. If you use HFNO, you use a lot of oxygen. So sometimes you have to take a practical decision and either stay with the patient on a ventilator or use NIV, while your feeling is that you want to use HFNO. And yes, now you see what I prefer, HFNO, and that's because of the patient comfort. Patient comfort with HFNO is really different, or way better than compared to NIV. And I think that's the most critical factor. If a patient is not comfortable, the minute ventilation goes up, he or she starts to fight, and maybe somebody starts sedation, and you are in this circle, you will never come out, and the patient needs reintubation. So this is more my feeling, and I'm not sure if I'm right, but this is what I noticed over the last couple of years. And it's influencing me, how I look at NIV or high flow nasal oxygen.
Dr. Swagata, please.
Thanks, Marcus. Our unit, I'm happy to say, we actually very well experienced in an NIV, and we also have HFNO machines. So it's very interesting to see that there are this category of patients. So my team now asks the patient, they're conscious, we're assuming when we're trying to think about an extubation. So they're conscious, we take them out and we give them a choice of NIV versus HFNO, and there is a big subset which actually says, I like the NIV better than the HFNO. And when we give them that choice, I think we end up with better results. So even my nurses, like when they go and they explain to them, you have to put this mask on your face, they're well trained in this. And like we all know it's more of an art, the NIV. And some of them say that I like this more than that. I'll take it out when I want to talk or I want to have food, but I would rather have this. Sometimes we have both machines next to the patient.
So we'll stay with you, Dr. Swagata. We spoke about NIV, we spoke about HFNC. These are one end of the spectrum. The other end is the severely hypoxemic patient where you do consider extracorporeal support, right? Exactly. Do you actually consider ECMO, awake ECMO, as a strategy for getting patients off invasive ventilation early? Is that a concept we should actually be talking about? Early awake ECMO.
I know that's there in literature, but I was just talking to Dr. Grasselli and Eliza. We are not very experienced with it. So I know there are studies, may not improve mortality, but it is definitely an alternative. So I'll let others in the panel speak with more experience than me here.
Dr. Mohit, would you like to add to it?
I was just adding to what she was saying, the previous one. I would just like to add one thing. There's a subset of patients, where probably the patient is on trial for prone ventilation. Now in this subset of people, going for NIV is very difficult. Now there probably HFNO works very nice. Even a patient with a prone with HFNO, we've seen the study in the morning, Dr. Samir Jog has presented, and that was the study which was really, in fact, it has also been done in our institution. Patient with prone and HFNO works very nicely because NIV would not be that much appropriate. Patient might not be able to tolerate. So that's one thing which I just want to add it.
What about ECMO?
So ECMO, of course, there are a lot of studies, but though I don't have personal experience, but there are a lot of studies, they say that the prognosis of extubation before, extubating the patient when the patient is already on ECMO is a better outcome than to extubate and then to liberate the patient from ECMO than to go for an extubation. So this is again, there are mixed studies, but I found this is much more significant. There's systematic analysis on this and which have proved that.
Well, I would like to speak of a special subset of patients, which are COPD patients, no? Because well, they could have ARDS. So in these patients, we are not experts in VNI as in your ICU. So, but in these patients, we would especially make the effort to use non-invasive ventilation because there's evidence that in this subset, really it improves outcomes.
Okay. So we'll stay with you, Dr. Eliza. Invasive mechanical ventilation has a lot of consequences on the right heart, cardiac function, other organ functions. So where would you see other functions like a RV dysfunction, an LV dysfunction, or a multi-organ dysfunction as a confounder in your strategy for early liberation of patients from mechanical ventilation?
Apart from cardiovascular alterations?
Yes.
Well, there are things that we should pay attention to before taking this decision because we have to think in, I would say, muscle health, I would say, no? Because, well, it's extubation and weaning, because what happens is that extubation and weaning are not the same thing, but are parts of the same process. So they have determinants in common, determinants of success or failure. And one of those determinants is, I would say, how is the state of the muscle. So I would look, it's not that I would extubate or not extubate according to this, but we have to look at this. We have to look at the patients and see if they, for example, have undernutrition, no? Well, we can expect a tortuous procedure, or if they're extremely obese or extremely lean. Frailty is another of the determinant of a bad or a failure of success in this. We have to look, and before trying start the weaning and the extubation process, we have to be sure that other other conditions are fulfilled. For example, no? That having a good value of potassium, of magnesium, so discard hypokalemia, hypomagnesemia, hypophosphatemia. These are basic things, but sometimes they are overlooked. One has seen this intense of extubation with patients that have 2 of potassium. So we have to look at this very carefully and think in other diseases, metabolic diseases, for example, hypothyroidism or hypoadrenalism, that also are very much connected to extubation failure. So before putting a patient in or initiating this process of weaning and extubation, we have to look at the general state of the patient and things that can be rapidly modified, well, try to modify them as these metabolic disturbances. And I don't want to forget about hypercapnia, no? Because in patients that are hypercapnic, that can be because of residual sedation or residual neuromuscular blocking, but also can be hypercapnic because of the disease, because they are COPD. Well, we have to expect a reasonable number of failures there. So we have to be prepared for this type of patients.
I think we have been warned to liberate ourselves from here. So we'll ask one last question to Dr. Bhattacharya. So now in this era of Google driving medical therapy in our ICUs at least, how would you consider the family's reaction when you say, my patient is hypoxemic, your patient is hypoxemic, but I'm considering early liberation from invasive ventilation, when they know that that's the mainstay of therapy for ARDS? How would you consider speaking or educating the family about this innovative thought process?
I think unless I'm not very sure that I'll be able to do that, I'll not talk. First thing is that, because this is something which will be very scary otherwise, and they will later on they will hang on me and they say, you said this thing, but you are not doing it. So that is why it is very scary when I see that, yes, obviously when I see the patient is young, it is an acute short history, infection, patient has suddenly gone down into a stage where probably we see that condition of the lungs along with through imaging processes, through blood gas analysis, everything, once we are sure that yes, things are fine, and we can say patient's family members that within a week's time we will be able to take it out and to liberate the patient from the ventilator. Then we have to have a closed door meeting, and then possibilities. I think when we say we have to tell both the sides, yes, this is what I am thinking, I'll try my best, but it may go on the opposite side. That also I have to tell. One way talking, I think in this kind of situations like ARDS will be dangerous for anyone.
I think counseling of this sort should be done with utmost care, because re-intubation in extubated patient or with patients on HFNAC or BiPAP will result in higher mortality. One should keep in mind.
Last comment. See, my point is, what are we talking for? What we are talking an early extubation. So ultimately, you need to extubate. That's the point. No, you got to extubate, and you know that what is going to happen if the patient is being extubated early. So first is, if you have to be very confident on the parameters, the numbers, whatever you say, and the clinical aspect of the patient. So if you are confident that this patient probably is predicted to have an early extubation along with a good post-extubation status. So that means we first need to be confident. You then need to make the patient relative confident, bring him in under your confidence. That means you got to tell him the pros and cons. Most importantly, that this is my expectation, and you have to tell him that if you extubate, probably the infection which we are expecting, or probably patients, whatever the prolonged extubation problem could be relieved from. Right. And secondly, since we have certain gadgets with us, probably we would be confident on extubating this patient. But as we said, we have to be very safeguard ourselves as well. It has to be, it can go in any directions, but that does not mean that we cannot make the patient confident, patient relative confident, and counsel, and we cannot do an early extubation.
Thank you, Dr. Mohit. We have absolutely run out of time, so I can't take last comments, but I will summarize what we have discussed. I think early extubation probably is something we can consider in mild ARDS, but moderate and severe, we don't have enough experience to actually be considering this. NIV and HFNC have their strengths and weaknesses. Experienced units can use NIV, then other ones can choose HFNC. It seems like patients prefer NIV over HFNC when they are starved of the oxygen demand. Look at simple things like minute ventilation, acid-base status, the diaphragmatic excursion, fluid balance. These are simple things which can help you to decide which is the right time to liberate patients from mechanical ventilation. But at the same time, I think standing at the bedside and making those decisions in a personalized way for every patient is the only key, as it has always been in bedside critical care medicine. Thank you all for that insightful talk, and have a good day. Bye-bye.
Can I have a question to the esteemed panelist? Is it allowed?
Yeah, one question we can.
I am Dr. Sucheta from Nagpur. I would like to question the esteemed panelists that in an attempt to reach the prerequisite for extubation, like there is substantial risk of ventilator dependence and VAP as well. So it won't be prudent to accept the bare minimum criteria, and if the patient is conscious enough to pull on NIV or HFNO support. In perspective of ventilator dependence, to chase the normal criteria of extubation.
Normally in ARDS, now it is the protocol is on third or fourth day, if you find that patient is still not improving, you go for a tracheostomy and put them on ventilator, right? So in these cases, you can very well switch on, even with tracheostomy, either on BiPAP mode or spontaneous breathing. So that is very easy. It will not be a prolonged ventilation, as you say, or it will not cause an addiction. Other cases which are intubated and you want to take those tubes out, it is very difficult that one should have 24 hours intensive care, watch. Somebody must be there to intubate the patient. If you can't intubate in time, these patients on re-intubation will become hypoxic and you lose the patient.
So can we accept an, suboptimal criteria to pull on as a part of winning? May not be extubation per se, but as a part of winning from switching to mechanical invasive ventilation to non-invasive ventilation?
That's what we are talking about. We are talking about early extubation or timely extubation. Means we need to achieve at least bare minimum target which we want to. That means the patient should have, as you said, clinically oriented. Verbal command is the patient is conscious. The clinical parameters which we are talking about, the lung pathology is at least being recovering from what it was before. It's in the downtrending, means the patient is improving. And at the same time, we must see that patient will be able to sustain the post-extubation period. That means we have a very good support with us, NIV or HNFO with us, and then we have a very good clinical ground staff, because who's going to take the patient from extubation, liberate the patient from ventilation, and then they're going to at least support them. The monitoring of the during the post-extubation patient is very important, especially 24 to 48 hours, to see whether the patient does not need an extubation. So these things has to be there, and then you can extubate if you have a very good supporting staff.
I think in short, I'll tell you what you're asking.
All
the confident things that we are saying, all of us have taken dicey decisions where we have to decide benefit versus risk ratio. If it is a severely immunocompromised patient and you feel this is the best he's going to be, but it still does not meet all the criteria that we've been talking about, we will take that risk. But then, like we have all discussed, we'll talk to the family, we'll try our best that it works. So, yeah.
You must understand that first thing is that you should never take a half-hearted decision. It will be fatal. Second thing is that don't think that NIV is not associated with any kind of complication. So whatever methodology you choose, it has got its positive and negative side. You have to understand. So why you are in hurry? You see that your patient is going to get dependent. But dependency comes when? It is an old patient, frail patient, moribund patient, immunocompromised, not able to take his own, failure to thrive is just kind of scenario. So in those situations, you take a decision of going for early tracheostomy, put the patient on again the ventilator, and gradually you win. After doing a tracheostomy, you can take your own decision, and in a week's time you can wean the patient. Right. Yeah. Rather than taking a half-hearted decision of extubating and putting the patient on NIV.
Yeah, so because the risk of mechanical ventilation is more, the magnitude of what we are talking about, polytrauma or infection, all others are much more.
You need to be very clear on this. Just extubating the patient from invasive ventilation and putting him on NIV does not stop him from getting onto mechanical ventilation. They are both positive pressure ventilation. So it's not going to give you any advantage. So the concept is early extubation should not be read as extubation in a hurry. Right? It
should be a timely
extubation. So that's what we meant to say. Yeah. For those of you who were in the DEI meeting yesterday, this is the most perfectly balanced panel we have had. Thank you very much.
Thank you, sir. Thank you, ma'am.
Thank you, esteemed panelists, and Dr. Srinivas, our moderator. It was a very insightful and interesting session on a very important topic, extubation in ARDS, and the right word exactly is timely. It had very good take-home messages for the audience, online and offline. Thank you all once again. For our next session, I have the privilege of inviting Professor Sunit Singhi from Chandigarh, India. Sir will be talking about long-term pulmonary outcome of pediatric ARDS patients. Professor Singhi.
Good afternoon, everyone. And thanks to Dr. Bhattacharya for giving me the opportunity to be with you all today. After all that very exciting discussion about what to do and what not to do, and if we do, what happens ultimately is the outcomes. And I'll be discussing that in our children. This was not an area that was very well researched until recently, but thinking about children that their lungs are growing, it is very likely that they are at increased risk of long-term lung damage. And with that in mind, we in fact also embarked on a study with the review of literature showing that there are very limited number of studies at that time with small numbers with variable intervals of discharge. And abnormalities that were noted were mild, perhaps because most of the seriously ill patients have died. Very few studies noted a correlation between respiratory therapy, like FiO2 and peak respiratory pressures and pulmonary functions on follow-up. 2 studies, one pilot and one feasibility study involving 24 children with ARDS, of which 17 completed pulmonary functions, in fact was the base mark on which we embarked on our study. In the meanwhile, there had been other studies which, as the subject has evolved, 1/3 of children who survived severe ARDS had recurrent respiratory symptoms, and another study found that 1/4 of respiratory symptoms and half had abnormal chest radiograph, mainly informed chronic interstitial changes. So we planned a study which had long-term objective and a long-term plan to see what are the kind of morbidities. Another study during the same time, which came from and was published in 2017, again from a tertiary care PICU. They did pulmonary lung functions and patients' quality of life in 12 months after 12 months after the respiratory distress syndrome. And of these, all those children, they could follow up only 24 of them. 23 of them had quality of life testing and 17 completed PFTs. And what they found is that 1/3 of them have pulmonary deficits. PICU length of stay seemed to have some relationship with the outcome, but none of the other variables that we look generally in ventilation or severity of illness had an outcome relationship. They also showed that health-related quality of life was adversely affected, and that's what really is very important for us while we are managing these children. Once we have managed them in ICU, they have gone home and they need further care to ensure a good health-related quality. But children as well as the adults in this study felt that there is a continuing need to get medical attention. So our study was planned in our setting, how our children do. It was a longitudinal study where there were two landmarks, 3 months and 9 months to 12 months. We included all the children that survived ARDS in these 2 years, and it was defined as mild, moderate, and severe based on the Palissy criteria. All the records were made. Now these children were followed up, as I said, at 3 months and 9 and 12 months, and were evaluated for any residual respiratory symptom and sign, pulse oximetry, chest radiograph, 6-minute walk test, pulmonary functions, especially the peak expiratory flow and spirometry both. And what we found that most of children at 3 months, that is about more than 1/3, had respiratory symptoms, which did not linger on at 1 year follow-up. But the chest examination, which is normal in all except 13% or 14%, but PFR was less than 80% in about 20% of the patients initially, and even at the end of 1 year in 15%. These patients were not clinically symptomatic though. 6-minute walk test had impairment initially, but it improved after the follow-up. It looks like that our children had shown a good sign of recovery, probably because their lungs were evolving and they were able to compensate for whatever damage had been left. The proportion of patients with FVC being impaired was almost 70% at 3 months and 15% on second follow-up. This is something very important because that means that these children need follow-up on a longer term basis. An abnormal spirometry was noted even at the end of 1 year in 18.5% of patients. Most cases had restrictive abnormality in terms of pulmonary functions, but some also had obstructive ones. There was no correlation between these pulmonary functions and lung injury scores and oxygenation indices. So it was difficult to predict at the beginning or at the time of enrolling them that who would develop these abnormalities and impairments. It was, these papers were covered in an editorial, and at the same time there had been a review which have commented broadly on those 2 studies that I have just quoted. And 2 more studies came after this in 20 and 22, which had follow-up at either 3 months or at 1 year, and they all corroborated similar findings that there were abnormal spirometry in 30% in one study, another almost 50%, and they needed pulmonary OPD visits in 80% of the patients. So considering that, the PALISI, that is Pediatric Acute Lung Injury Consensus Conference 2, reviewed this whole subject and summarized their findings and made recommendations using a grade approach. It included 20 articles, but only few were really detailed. And what they concluded first is that there is insufficient evidence to generate any evidence-based recommendations. But they proposed 8 good practice statements for approaching pulmonary and non-pulmonary outcomes in ARDS, pediatric ARDS. The number 1 is that all patients discharged home should be followed up within 3 months of discharge. And this comes from one of our studies, another study. And a stepwise approach to the clinical evaluation of post-peak comorbidities should be done. And this is the basis for that recommendation. You can see that the graph on the right side shows the respiratory and pulmonary symptoms and functions, and you can see that at 3 months, almost 80% of patients with ARDS have respiratory and pulmonary function abnormalities, which persisted at the end of 1 year. On the other, see the last bar, in severe ARDS, it still persists. So proportion of patients with impairment in pulmonary outcomes persists even up to 1 year and maybe longer, but longer studies are not yet available in children. The second part of the clinical good statement is that they all should be screened post-discharge for pulmonary function abnormalities within 3 months, that they should be assessed by spirometry to screen for pulmonary function abnormalities within the first 3 months after discharge, and they should be referred to the specialist when deficit in pulmonary functions are identified. And almost all these recommendations have 90% or more higher agreement. Related to long-term pulmonary outcome is also the health-related quality of life comparison. And these are the studies which had been again reviewed and collated together, but I would just like you to see those large bars on the first, the second, and the third. And you can see that in severe form of ARDS, there is a very strong belief among the parents and children that their health-related quality of life is affected and that they are in need of continuous medical care or are likely to need more care. So what I have briefly brought out and its current understanding is that post-PQ morbidity may go unrecognized if they are not evaluated in a planned manner, that these patients are at risk of developing or having persistent respiratory symptoms and pulmonary function abnormalities post-discharge. 1/3 of children continue to have respiratory symptoms 3 months post-discharge, and up to 80% have abnormal PFT 3 months after discharge. Up to 1/3 also have abnormal PFT a year down the line after discharge. Post-discharge screening can identify all these children at risk who may benefit from targeted treatment and follow-up. So failure to manage and follow these deficits, particularly when severe, may lead to long-term morbidity in affected children. So that's what we know now, that all patients, all children with ARDS need long-term follow-up in a clinic setting in a planned manner. Thank you very much.
Thank you, Professor Singhi. We have time for 1 or 2 questions. Anyone? Thank you, sir. There are no questions.
As I told you, this is not a debatable topic.
Great, sir. Thank you so much. For our next session, I would like to invite Professor Grasselli. Professor Grasselli will be speaking on all-in-one ESICM guidelines on ARDS, definition, phenotyping, and respiratory support strategies. Professor Grasselli, please.
Okay, thank you. My disclosures. So this is the paper that has been published a few months ago. You have seen this slide many times today. The project was started by the ESICM leadership, and they appointed the 3 co-chairs, which is me, Luigi Camporotto, and Caroline Calfi, and 1 methodologist, who was Daniele Poole. We identified a large panel of experts, taking into account gender and international and geographical diversity. And we also invited 8 patient and family representatives who participated in voting and in reviewing the manuscripts. So we followed the usual grade methodology. So we identified 16 questions based on the PICO format that were determined by the members of each group. We analyzed only randomized control trials only on adults, patients, and in English. And we decided to exclude pharmacotherapy, so there are no recommendations on steroids. For example, we only included neuromuscular blocking agents, as Sheila showed us this morning, because they were considered as an adjunct to mechanical ventilation. Importantly, we decided to provide separate recommendations for COVID and non-COVID patients. The evidence was analyzed based on the grade methodology. We had meetings with the entire panel and also patient and family advocates. And of course, in the end, we voted on the recommendations, and we selected a threshold of 80% agreement to adopt a recommendation. The outcomes, so the primary outcome was mortality. We decided to select the longer time point available, so usually 60 to 90 days mortality when available. that were considered more important and more relevant than ICU mortality. And then the other outcomes were selected for each single topic by the panelists, and also selected based on the risk of bias, and mostly we selected, dates free from mechanical ventilation, duration of mechanical ventilation, intubation rates for the non-invasive support, and some selected adverse events, for example, barotrauma for recruitment maneuvers. So we had 9 domains. You can see in red those that were not covered in the previous guidelines. And you can see the name of the domain leaders there. And as I told you, we invited 8 patient family advocates from all over the world. We had 3 dedicated meetings with them, and we mostly asked them to help us to identify the most significant outcomes. So we asked them to rate the outcomes, and as you can see there, they gave the highest priority to hospital mortality, and then to, of course, ICU mortality, but also to quality of life and the incidence of intracranial hemorrhage. So let's go briefly through the domains. So the definition domain, we have spoken a lot about definition, so I'm not going through this. I just want to point out that our goal was not to provide a new definition of ARDS. It was just to provide a sort of conceptual framework to identify strengths and weaknesses of the current Berlin definition, and to open the door to a new definition that I must confess we didn't think that would have been the new global definition. We thought that the new definition should come from a multi-societal process, and the new global definition followed a bit different pathway. But anyway, many of the experts who worked on the new global definition are also in this panel. So, but again, we did not want to provide a new definition. We also had a domain on phenotyping that was led by John Laffey, but Caroline Calfee, of course, participated in it very actively. And again, here we wanted to give a definition of subphenotypes and to understand whether there is a heterogeneity of treatment effect. And we have heard by Caroline that there is a heterogeneity of treatment effect, and to understand if there is a link between subphenotyping and patient outcome, and of course the research question for future trials. And then the following domains are more practical domains related to how we want to manage the ventilatory strategy, the ventilatory management of ARDS. So we decided to cover also non-invasive respiratory support, and we had a dedicated domain on nasal high flow. Well, the first PICO is a comparison between nasal high flow and conventional oxygen therapy to reduce mortality or intubation. And as you can see from the forest plot, we were able to give a recommendation in favor of the use of high flow compared to conventional oxygen to reduce intubation, while we were unable to make a recommendation on mortality because on those trials that were meta-analyzed, there was a meta-analysis that did not show a clear difference in mortality. And we also think that the same recommendation can apply to COVID-19, downgraded the level of evidence for indirectness. The second PICO is the comparison between nasal high flow and non-invasive ventilation. And here you can see the diamond of the forest plot. They both cross the identity line. So basically no recommendation for or against the use of nasal high flow compared to CPAP and IV. In non-COVID-19 acute hypoxemic respiratory failure to reduce intubation or mortality, while there is a suggestion in favor of CPAP and IV as compared to nasal high flow to reduce intubation in COVID-19 patients. Non-invasive ventilation, the PICO question mirrored the same of the nasal high flow. So the first is the comparison with conventional oxygen therapy to reduce intubation and mortality. And here, the primary analysis that included only studies at low risk of bias did not identify a significant difference in favor of NIV, while if we include in the secondary analysis also the studies, smaller trials, then there was a signal towards a positive effect in immunosuppressed and COVID patients in favor of NIV. The second PICO question is a comparison between the helmet and face mask for the application of NIV and or CPAP. In the end, we decided not to provide a recommendation in favor of the helmet, despite that there is only one study that shows a strong difference in favor of the helmet. It's the study by Patel, published in JAMA, but as you know, it's only a single center study in a relatively small number of patients. So it's an important study though, but we felt that it was not strong enough to give us the right to provide a clear recommendation. And we were unable to make a comparison between NIV and CPAP because there is no evidence on that. So low tidal volume, when we started the process, I thought that this would have been very easy to do. I said, okay, why should we give a recommendation in favor or against? I mean, a low tidal volume, everyone is using low tidal volume. And I must tell you that this was the most debated domain, because if you look at the forest plot of the studies, you see that the diamond crosses the identity line. So technically speaking, or at least statistically speaking, there is no statistical significance in favor of low tidal volume, and we defined it as 4 to 8 milliliters per kilo of predicted body weight compared to larger tidal volume, and we decided to define them as traditionally used to normalize blood gases to reduce mortality. So this was a big problem because the statistician said, I'm not going to sign this paper if we issue a recommendation in favor of low tidal volume. We were all convinced that we had to give a recommendation in favor of low tidal volume, so we ended up with this statement, which is a strong recommendation based on the expert opinion despite the lack of statistical significance. Anyway, we are all convinced that we should use low tidal volume in ARDS patients, and the same applies also to COVID-19 patients. PEEP recruitment maneuvers, again, another very complicated topic. We meta-analyzed the same 3 trials that were meta-analyzed by Brill in JAMA, and no difference, so we were unable to make a recommendation for or against routine PEEP titration with a higher PEEP-FiO2 strategy compared with a lower PEEP-FiO2 strategy. As you may know, in the previous meta-analysis by Brill, there was a signal in favor of the use of high PEEP level in patients with PF ratio below 200, while there was a signal of harm for the use of high PEEP level in patients with PF ratio between 200 and 300. We did not perform a sub-analysis or a sensitivity analysis based on the severity of ARDS. So if you take into account the entire population of ARDS patients, so PF ratio below 300, there is no difference between lower versus higher PEEP. And also, we did not see a significance in favor of the use of PEEP selection based on respiratory mechanics, and we included also the ART trial here. So we included both studies on esophageal pressure, so the studies by Talmor, the EPIVENT 1 and 2, and we also included the ART trial because the ART trial, you know, it was based on PEEP selected based on the value associated with the highest respiratory system compliance, but no difference in mortality. For recruitment maneuvers, we classify the recruitment maneuvers in prolonged high-pressure recruitment maneuvers, as defined as the application of a pressure above 35 centimeters of water for at least maintained for at least 1 minute. And in this case, we were able to give a recommendation against, a strong recommendation against high-pressure, prolonged high-pressure recruitment maneuvers, again, also based on the results of the ARDS trial, mainly for safety concern, for the risk of barotrauma, while we gave only a suggestion against the use of the routine use of brief high-pressure recruitment maneuvers to reduce mortality in patients with ARDS. So, you know that it's the issue of recruitment maneuver is very difficult, because it's very difficult. Most studies are not designed to assess selectively the effect of recruitment maneuvers. Usually, recruitment maneuvers are inserted in a more, let's say, comprehensive strategy, also PEEP, tidal volume, and so on. So in the end, we think that we should not use let's say, an extreme open lung approach as it was used in the ARDS trial. For short recruitment maneuvers, they should not apply routinely. They remain a sort of rescue treatment, but of course they can be useful in selected cases. Prone positioning, no doubts, strong recommendation in favor of prone positioning mostly based on the results of the PROSEVA trial, and so we decided to give a recommendation based on the indication of the PROSEVA trial. So prone positioning applied early, combined with low tidal volume ventilation in patients with PF ratio below 150 and for at least 16 hours per day. Importantly, we only wanted to point out that prone positioning should continue even if there is no improvement in oxygenation during the proning session, because there are studies, or actually a secondary analysis of the PROSEVA trial that shows that the positive effect on survival was not necessarily linked on the effect on oxygenation. So it means that even if PF ratio does not improve, patients should be proned, and you should stop proning only when patients worsen during prone positioning. We also analyzed the evidence on awake prone positioning, and there is no evidence in non-COVID patients, while the evidence available at that time in COVID patients was in favor of awake prone positioning to reduce intubation, not enough evidence to assess the effect on mortality. Neuromuscular blockers, Sheila already told us. So this is a recommendation against the routine use of continuous infusion neuromuscular blockers based on the meta-analysis of the Accuracies and of the ROSE trial. I'll go back to this in a moment. And the final domain was ECMO, extracorporeal CO2 removal. ECMO, a strong recommendation in favor of ECMO as a rescue treatment for refractory hypoxemia based on the criteria of the EOLIA trial. So as you know, it's PF ratio below 80 for at least 6 hours, PF ratio below 50 for at least 3 hours, or refractory respiratory acidosis. So this is ECMO as a rescue for refractory hypoxemia or respiratory acidosis, and this is based on the meta-analysis of the CESAR trial and of the EOLIA trial. While for extracorporeal CO2 removal, mostly based on the results of the REST trial published by Danny McCauley in JAMA, we gave an evidence, a recommendation against the use of extracorporeal CO2 removal in ARDS patients outside clinical trials. Just few words. A couple of months after, the publication of our guidelines, the ATS published their guidelines. These were only the update of the 2017 recommendations. Different panels, okay, different number of picos, and same methodology. We have agreement in most of the recommendations, luckily enough. So we are, of course, in favor of low tidal volume, prone positioning, and ECMO, and against prolonged lung recruitment maneuvers. But there is also disagreement. And the first one is for PEEP. So the ATS guidelines suggest higher level of PEEP in moderate severe ARDS, while we, as I showed you, were unable to make a recommendation in favor or against a higher PEEP-FiO2 strategy. And the worst, I would say, disagreement is on neuromuscular blocking agents. If you read only the recommendation, you see a striking difference, because we made a suggestion, recommendation against the routine use of continuous infusion neuromuscular blockers. The ATS gives a suggestion in favor of the use of neuromuscular blockers in patients with early, less than 48 hours, and severe, so PF ratio below 100 ARDS. So I just want to point out that we are not so much in disagreement. I mean, we all know that for very severe patients, they are impossible to ventilate in the early phases of ARDS without neuromuscular blockers. So we wanted just to point out that we should not use routinely neuromuscular blockers by continuous infusion in every ARDS patient, irrespective of the severity. And of course, the reasons for disagreement are some methodological differences in the selection of the papers, in the interpretation of the papers, and mostly based on the opinion of the experts. Thank you very much for the attention.
Thank you, Professor Gracieri, for a wonderful presentation and summary of the guidelines. We have time for 1 or 2 questions. Anyone?
In prone position, when we do the patients put in prone position, what about this driving pressure concept on ventilator? Does it work?
Nobody knows what's the best way to ventilate patients in the prone position. So I can tell you what we do. I mean, we mostly keep the same setting of ventilation. Then when we prone the patients, if they are very severe, sometimes we do a recruitment maneuver in the prone positioning, and maybe we tend to adjust PEEP according to the response to the recruitment maneuver. Or we use EIT to understand better how the ventilation is distributed, how the ventilation and perfusion are matched, and if this can help us to find a different level of PEEP. I think that the driving pressure concept is still valid. I just remember you that Paolo Pelosi showed us that the effect on oxygenation of prone position is probably dependent on how much the compliance of the chest wall decreases after proning, because the more stiff becomes the chest wall when you prone the patient, the better distribution of ventilation you have towards the dependent lung zones. But I think that the driving pressure concept remains there.
Thank you.
Thank you.
If there is a...
Yeah, please, you can have a question.
Thank you, Professor. I just wanted to ask your view on the helmet NIV in ARDS patients.
Yeah. So the problem with helmet, the issue of helmet NIV is quite complex. I mean, if you think that the goal during assisted ventilation is to provide synchronized assist to the patient, the helmet is not a good interface, because the helmet has a large compliance. So when you inflate the helmet, it takes time before the pressure goes to the airways. So when you do an NIV with the helmet, you always have a certain delay between the trigger of the patient and the delivery of the pressure from the ventilator. And so there is a sort of dissynchrony between the patient and the ventilator assist. But there are studies now showing that this dyssynchrony is not so bad, because if the patient and the ventilator are too synchronized and the patient has a very high respiratory drive, the risk is that you have the delivery of excessive tidal volume. So in some way, applying pressure support ventilation or BiPAP with the helmet is a sort of APRV. So it's a sort of shift between two CPAP levels, okay? So the patient still breathes freely above two different CPAP levels. So now I think that there is quite a good body of evidence that in favor of the use of helmet as an interface for NIV. In ARDS, the problem with non-invasive support remains that if you want to ventilate non-invasively a patient with white lungs, you need to be very careful. I mean, you need to monitor the patient, and you always have to keep in mind that if you don't recognize timely that the patients are failing and you delay intubation, then this is bad for the patient.
Thank you, sir.
Thank you. Last question, yeah.
Thank you, sir. I'm Rakesh from Impulse. Sir, in the guidelines, so we have not come across the opposite alternate lateral positions. Say in case most of the patients, like say obese patients, morbid obese. So can we adopt, say, like in the opposite or alternate lateral positions, left, right also?
Well, there are no studies, no randomized studies on let's say positioning different from prone positioning. What I can tell you is that there are very, very few patients in whom you cannot apply prone positioning. I mean, if you have experience, we have prone patients, tracheostomized patients. I remember one who was like 350 kilo weight. We have prone pregnant patients after the 34th week of gestation. So there are very few contraindications to prone positioning. But of course, if you cannot prone the patients, and especially in patients with not homogeneous, like unilateral lung disease, lateral positioning or alternate lateral positioning can be an issue. In COVID patients, when awake prone positioning was applied a lot, but some patients were not tolerating it, someone was proposing what was called the Rodin thinker position, which is like the patient, awake patient, lying down with the chest on a table, which in some way reproduces prone positioning, but it's more tolerated from the patient, by the awake patient.
So, sir, may I assume the lateral also, sir, if in case not possible prone? So
I mean, you can try. The idea is that with proning, you change a lot the compliance of the chest wall, and so it's much better for the redistribution of the ventilation. But if you have, especially if you have unilateral lung disease, then you can use lateral positioning with the healthy lung below and the sick lung above.
Thank you, sir.
Thank you so much, Professor Gasrelli. Can you have a big round of applause for sir? So next there will be a short message from Professor Michael Matthey from University of California.
Well, good afternoon or good morning. It's a pleasure to be talking to you from San Francisco, California. I am Michael Matthey, Professor of Medicine and Anesthesia at the University of California in San Francisco. I know this is a special World Day for ARDS being celebrated in India, specifically in Delhi. Thank you for the invitation. I'm going to give you just a brief perspective on what I think are the major developments in ARDS over the last year. First and foremost, we have published a major new global definition of ARDS in the American Journal of Respiratory and Critical Care Medicine with 32 participants and co-authors. And the major purpose of this global definition was to make ARDS as a diagnosis relevant for the entire globe, including areas of the world that are resource limited. In addition, the goal was to recognize that many patients have ARDS who are being supported with high flow nasal oxygen or non-invasive ventilation and not necessarily intubated and ventilated. So currently the global definition allows patients to be diagnosed with ARDS with high flow nasal oxygen at 30 liters per minute or higher. In addition, for the relevance to global settings, it is no longer required for a patient to have a chest radiograph or an arterial blood gas. Oxygen saturation measurements are adequate and calculated for the SaO2 divided by the FiO2 to determine if oxygenation criteria are met. In addition, a ultrasound can be substituted for a chest radiograph. So over the next few years, we'll have the time to evaluate the utility of this broader definition, but we think it will help to diagnose patients at an earlier phase of lung injury and to also motivate testing new therapies at an earlier phase of lung injury, as well as more research into the pathogenesis and prognosis of patients with ARDS, including the major precipitating factor, sepsis, whether it is from the lungs or a non-pulmonary source. In addition, major new developments in ARDS are interesting new clinical trials to test ventilator strategies as well as pharmacologic therapies. And over the next 2 to 3 years, I expect the results of these trials will help us to understand new therapies, recognize new therapies for ARDS, including those that would identify in real time biologic markers that would allow us to categorize patients into specific groups that might respond better to pharmacologic therapies. I hope you have a terrific conference, and best wishes from the University of California, San Francisco, and our many colleagues around the world. Thank you.
Thank you so much, Professor Michael Mathey, for an encouraging word. So next we have a very interesting session, the quiz. It's an open house quiz. So I would request everyone to come in front because the prize is to be given as you answer. So you will have to, for that I would like to invite Dr. Ashit Hegde. And Dr. Pawan Reddy from Hyderabad. Yeah.
Well, I was assigned 40 minutes for this quiz, and I prepared 18 questions. I thought that should be enough to cover 40 minutes, but unfortunately for us and fortunately for you all, many of the questions have been answered during the course of the day by one speaker or the other. So really this is going to be more of a test of how much attention you have paid. So I don't think this is going to last 40 minutes. It's probably going to end up pretty quickly because most of the questions, but there are a few offbeat questions which I hope would take a little more time. Involves a bit of lateral thinking, but some of the other questions, like just a matter of how much attention you paid to the talk today. Like he said, there are some sweet chocolates for the people who give the right answer first. So please don't shout out the answers from wherever you are. You'll have to, the first person to come to the mic, any of them, there are 3 mics in the, so we'll get the chocolates. I mean, irrespective of whether you're the first to shout out the answer or not, the first person who comes to the mic, and Dr. Pawan, you'll have to decide who's the first person to. So please, unless none of you seem to be interested in answering, so none of you is moving away or closer to the mic.
I think everybody should move towards the mic, nearer to the mic. You run to the mic. So
they're very simple questions. Like I said, if you paid attention today, you're going to be able to answer pretty quickly. So it's like just a. So shall we start? Fine. Okay, waste some more time then take. Good. So shall we start? So, only 18 questions, so So this is a very simple, this is almost a full toss which anybody can hit for a sixer. When Ashbaugh, Petty et al. Described ARDS, the A in ARDS did not stand for acute. What did it stand for and why?
Mike, yes,
Mike.
yes.
Adult.
And why? Why adult?
Because there were cases reported of infant respiratory distress syndrome.
Yes,
to differentiate that, adult was introduced.
So to separate it from the respiratory distress syndrome of the neonate, it was called adult respiratory distress syndrome. Please come to the...
I'm Dr. Achyut from Visakhapatnam. Yep, thank you.
Dr. Achyut.
So like I said, this is going to get over pretty quickly, but...
Catch, no.
But this was a full toss, yeah. This was anybody could have hit this. But, thank you. So next question, slightly offbeat, but I think sure you'll get this as well. So A stood for adult to differentiate from the pediatric or the neonatal respiratory. So what is the connection between these three frames? In the context of ARDS, of course. Connect these three frames in the context of ARDS, of course. No, give me the whole answer. Just Berlin is one of them.
Standing at the mic,
Come to the mic and give the whole answer. No, the whole answer, everything.
Yeah.
All three frames.
I think it is the 1994 and 2012, the Berlin and the previous definitions where the ARDS has been defined.
And the third one?
And the recent one.
What is it? And what is the
global one? The global definition.
So why do you have that?
That global one.
Why do you have the Zoom there? Why do you have the Zoom? Why Miami? Why Barcelona? Why Berlin? Of course, the Brandenburg Gate is there.
The latest, the global one.
No, why Miami? Why Barcelona?
Miami? Why Barcelona in the first frame?
Brandenburg is in the middle. The Brandenburg Gate, that is Berlin, of course. Something to do with the definitions. I just want a little more specific answer. What to do with that? What to do with the definition? Three definitions. You're right. The ACEC, the American European Consensus, the Berlin, and the global. So
the principal investigator, there are prompts.
Not principal. Pretty close. There are many cities. So nobody else. Then I'll give him the prize. Okay. The connection is that anybody else wants to try.
Yes, madam. Please to the mic.
American European Consensus Conference, that's why Miami and Barcelona.
No. So what does it have to do with that? He said. What is the third one? What is the third one?
They met in Zoom.
Exactly. So who said that? Met on Zoom?
Yeah. Me.
So exactly. So that is the
and
question.
First time they met in Miami and.
This is where the panel of experts met to develop. So when for the ACEC, American European Consensus, they first met in Miami, then in Barcelona. For the Berlin, of course, they met in Berlin. And global definition was during 21-22, mainly COVID. So virtually all the meetings were on Zoom. They probably didn't meet at any formal location. They met mainly online, virtually. So these are locations where the panel of experts met. He thinks Zoom. I think that should be.
Can I get her?
He can sit. Because he gave a more. You can give one more chocolate to Venkat also. So, for which other serious condition, which itself is a risk factor for ARDS, is there a Berlin definition? Which other serious condition, that condition itself is a risk factor for ARDS? Of course, you can encounter this in critical care. There is a Berlin definition for some other serious condition. Pardon?
There is one more Berlin definition.
In critical care, some other serious condition. Who said polytrauma? Come to the stage. I told you, come to the mic. Before somebody runs before you, somebody beat him to the mic.
Polytrauma.
Polytrauma. The Berlin definition is for polytrauma. So the this is the polytrauma definition. So that is the definition of severe polytrauma according to the Berlin definition. So next time, please don't shout it out. Somebody could beat you to the mic and shout out. So you lose your chocolate. So that's the Berlin. What's your name? Please come to the stage to mention your name, and we need to spend some more time. Otherwise, it's going to get over pretty quickly. So,
I'm Dr. Sanjeev from Yashoda Hospital, Kaushambi.
Congratulations, Dr. Sandeep, and you got your chocolate, I hope.
Yes.
So this is Da Nang, one of Vietnam's largest and most livable cities. So what is the connection between Da Nang and come to the mic,
Kunjan,
please.
Come to the mic.
And ARDS.
Yes.
Come to the mic. Come to the mic. Somebody can, please, otherwise somebody can answer.
The Da Nang lung related to the Vietnam War that was there. That is where the ARDS got identified first.
Thank you. That's the right answer. Kunjan gets the... You identify yourself, so...
Kunjan, chocolate.
The previous names for ARDS, particularly in the context of battlefield trauma, were wet lung in World War II, shock lung or Da Nang lung, or even called the Nam lung, because that was actually the first American combat troops first landed in Da Nang, because they're an American base there and they tried to protect their air base. So this was called, before the term ARDS, these were the names because most of the ARDS in those days was in the context of polytrauma. So Da Nang lung, shock lung, wet lung, all of these were terms for ARDS before ARDS itself was defined. So we all know what VILI is, but what is VALI? Come to the mic, please. I can't hear you.
It's ventilator-associated lung injury.
No, that's VILI, ventilator-induced lung injury. It can't be such a simple question. I said we all know VILI is. It's not VA, not ventilator. This is something associated lung injury. I'm telling you, I just want the first V.
It's vaping-associated lung injury.
Vaping-associated. She talked about it when she talked about phenotypes. Vaping-associated lung injury. Vaping-associated lung injury.
Name, sir?
I am Zahid.
So since 2018, some of the classical, this is Valley called vaping-associated lung injury. Just a brief infographic about Valley. So after 2018, some of the common etiology of ARDS in the past are becoming less frequent, like polytrauma, blood transfusions, etc. But 3 newer causes have been sort of identified, all starting with C: e-cigarettes, COVID, and chimeric antigen receptor therapy, CAR therapy. These are the 3 newer etiological factors for ARDS, and compared, so they have become a little more common as compared to some of the classic factors, etiological factors for ARDS post 2018. So this is an article that came early in the 2000 surgeries, an article on blast injuries, and we know that ARDS can occur after a severe blast injury. In this article, he suggested that every patient involved in a blast should soon, pretty quickly undergo an ENT examination soon. Why did he suggest this?
Is it because of the middle ear pressure cavity changes in the blast?
Pardon?
Middle ear pressure changes.
Yeah, so what happens? What is examined? So what do you look for?
A ruptured tympanic.
Come to the mic. Somebody can beat him to the mic. So what is the tympanic membrane that will tell you?
And secondary injury, blast injury, secondary.
Rather the other way around. I think both of you. Anybody wants to say something? Yeah.
So blast injuries majorly have smoke inhalation, and that.
No, ENT. Okay, no, that was wrong. ENT. He was right somewhat. So I wrote the sort of little more correct answer. Yeah.
So the middle ear pressure, which leads to the tympanic member injury, will correlate the blast related the mechanical power or an injury, which can cause the ARDS. That's the link between a tympanic membrane.
Anybody slightly more accurate answer? Slightly.
If the blast can rupture your tympanic membrane, it can rupture your alveoli as well.
That's what they all said. Anything?
Yeah.
It's the other way around. The tympanic membrane is the first to get ruptured. So if your tympanic membrane is intact, it's unlikely that you will get ARDS. It's the other way around. So because the pressure required to rupture the tympanic membrane is the least. So if your tympanic membrane is intact, then he suggested that you don't need to worry too much about. So actually nobody gets a prize for this, or maybe all 3 can share it. No, that's not mine. So he said this, but there is no if there is no rupture of the tympanic membrane, then primary effect of blast and all is unlikely. So basically it's the other way around, that in fact he suggested they can even be discharged home. But subsequently there have been studies from Israel and other areas prone to blast injuries where this has been said that there have been patients with an intact eardrum who have gone on to develop ARDS. So while this might be true for the vast majority of patients, it's not a foolproof rule that if the eardrum is intact, they won't get ARDS, but something to go by, that because I think you require about 5, whatever this is 5 for the eardrum and about 80, 90 for the lung. So theoretically, yes, it makes sense that the eardrum is intact, the lung is unlikely to develop ARDS, but like I said, there have been exceptions to this rule. So what is the histopathological hallmark of ARDS? Hinted at by this slide. The histopathological hallmark of ARDS hinted at by this slide. Somebody come to this.
Diffuse alveolar damage.
What? No, not diffuse alveolar damage. What is the hallmark here? Dad. So this is dad. Okay. So.
Dad.
All terms for dad. So.
You don't get a prize because you don't come to the mic.
I'm sorry, that's what I meant. So you diffuse alveolar damage, of course these are all terms, other terms for dad. So diffuse alveolar damage is the histological sort of hallmark of ARDS. Of course, this doesn't have to, you can have ARDS without this, and you can have diffuse alveolar damage without ARDS, but the majority of patients have diffuse alveolar damage. So this is again a very simple question. I thought there would be residents, but any case, anybody can answer this. Why was predicted body weight used instead of ideal body weight or actual body weight for the ARDS-NET trial? Anybody can answer. It's just a matter of running faster to the, he's being a gentleman.
See, the lung volume doesn't depend on your weight, but on your height. So
I thought it would be residents. I know residents are all consultants, so pretty easy question. Just a matter of faster fingers or the fastest runner. So Venkat, of course. Venkat. So this is a slightly interesting question. You know the ARDS-NET trial was conducted across several cities across America, and that was the inclusion criteria, which all of you know. But in two cities, Salt Lake City and Denver, there was a slight difference in the inclusion criteria, minor difference in the inclusion criteria. What was the difference and why? Salt Lake City and Denver. They were spread across America, you know, those all the cities, and I've already pointed out Salt Lake City and Denver. There was a slight inclusion in the...
Sir, maybe the altitude. Altitude was more than 1,000 feet.
So what was the difference? What was the difference in the inclusion? Very good. What was the difference in the inclusion? You're right, because Denver is called this mile high city, so it's altitude in both these two cities. So what is the difference in the inclusion criteria in these two cities?
So the change in the PF ratio?
Absolutely. So I think between the two of them, I think you should get, I think both of them, he probably gets 1.5. So because of the altitude, the PaO to FiO2 ratio was corrected for altitude in these two cities, okay? Because these cities were at a higher level, like I said, Denver is in fact called the mile high city. So the PaO to FiO2 ratios in all other cities were 300, but in those two cities, probably the cutoff would have been slightly lower than 300, because as such, at those altitudes, the PaO to FiO2 ratio would be lower. So they were adjusted for the altitude in Denver and Salt Lake City. So that was the... So what do these numbers add up to? Again, this is more for the residents, but anybody, not arithmetically, of course, I know anybody add it up and say it adds up to 100 something, but what do this number, I want the identical actual term for this, what do all these numbers add up to in ARDS?
Dead space?
Not dead space, more accurate term, not dead space, not just dead space, you're half right. Pardon? No, I just want a little more accurate term. Somebody said dead space. Just a little more accurate term.
A little more better wording.
What kind of dead space?
Physiological dead space? Physiological?
Anatomical. It's not anatomical.
It's a device dead space.
What's the term for that?
Device dead space or anatomical one.
It's not anatomical, no? These are all...
Apparatus dead space.
So not apparatus, what's the other word for that?
Mechanical dead space.
What is dead space? There are 2 or 3 kinds of dead space. No, one is anatomical, one is physiological, and what's the third one?
Device.
You get half a chocolate, but somebody, this is a simple question. I thought...
Circuit or...
What's the term for these? Your tubings and your filter and all that, what do they add to? What kind of dead space? What kind?
Equipment?
Not equipment, it's called instrumental dead space. No? Instrumental dead space is the term. I mean, I think you got dead space, but it's still all instrumental dead space. And why is that important? Because when you're using low tidal volume ventilation, you have hypercapnia. Eliminating instrumental dead space might help bring down the PCO2 a bit. When you're having hypercapnia, worried about hypercapnia, you can eliminate all these instrumental dead space and try get rid of the HME, remove the Y circuit, all that you can cut the tube, all that you can do to reduce instrumental dead space and thereby reduce PCO2 levels. So this is PEEP in ARDS, and that's the story of Goldilocks. So this is something I should, what is the connection between PEEP in ARDS and the Goldilocks story?
She didn't like too hot and too cold, so it's a equilibrium.
Pardon? Yeah, so she didn't like too hot, too cold. So what about PEEP?
So PEEP should be optimal.
So what do you mean by, so you're almost right. So what is the actual term? It should not be too hot, not too cold, should be.
So tidal will to not high, low PEEP and high PEEP.
So what should it be? The term is not optimum. In
optimum.
Goldilocks, she didn't say optimum. What did she say? The soup was neither too hot, not too cold. It was
Just right.
just right, just right. Okay. You haven't read the story. So she found the chair not too big, not too small, just right. So the optimum PEEP shouldn't be too little or too much. It should be just right. Like you all know, if it's too little, it'll cause atelectasis. If it's too much, it'll cause overdistension. It should be just right, like the soup or the bed or the table in Goldilocks story. So it should be just right. That's the Goldilocks rule. In fact, there are lots of conditions where they say use this Goldilocks rule. It should be just right. Now, as an aside, I think the people have already answered. Probably should give a chance to others to answer. If, of course, nobody else can answer, fine. Now, this is supposed to be a classic study, which unfortunately, in my opinion, is flawed. This is about, ventilation lung injury. This is a little long, but of course, you have enough time. So, intact rats were subjected to large or low tidal volume ventilation with identical peak airway pressures. So, low volume ventilation with high airway pressures were obtained by limiting thoracoabdominal excursions by strapping during ventilation. So, the rats subjected to high tidal volume, high airway pressures developed pulmonary edema. Strapped animals ventilated with high airway pressure, but the normal tidal volume had no edema. And then rats are ventilated with large tidal volumes but negative airway pressure by means of an iron lung. And permeability edema developed even when the airway pressure was negative. So the authors concluded, this is supposed to be a classic study which a lot of people quote, but that the increase in tidal volume is responsible for ventilation-induced pulmonary edema and not high airway pressure per se. Therefore, they suggested that it would therefore be wise to replace the term barotrauma with volutrauma. So what is the basic flaw in their conclusion? What is the basic flaw in this conclusion that they made? This is a classic paper which a lot of people quote, but what is the basic flaw in their conclusion? A very basic error they made in coming to this conclusion. This is also talked about. Many people have talked about this. Nobody, then I get the chocolates, or anybody want to try? Gunjan wants to try?
On the mic.
He talked about peak pressures or plateau. Which pressure should you have? You're coming there, but which pressure should you have considered? Peak or plateau? Which one? Should consider that. So what pressure should he have considered? Pardon? Transpulmonary pressure. They should have considered transpulmonary pressure, not peak pressure, neither plateau pressure. They should have considered transpulmonary pressure, because what causes lung injury is transpulmonary pressure. So in the patient who was making negative effort, the transpulmonary pressure was 45. It was not negative. It was 30 minus 50. And if you have strapped the abdominal wall, again, your chest wall compliance decreases. So your transpulmonary pressures are going to be low. So basically, he mistook peak, it's not peak pressures or plateau pressures which cause that. So again, that's what somebody talked about when talking about driving pressures. You need to know about the chest wall compliance. You need to know about the transpulmonary pressures. They are the most important, what causes. Generally, if the chest wall compliance is okay, it doesn't matter. But in patients where chest wall compliance is poor, or patients are making a negative effort, that's how you get pressure, PCL, in spontaneous breathing, because of a negative pressure, because of a negative transpulmonary pressure. So that is what causes. That was the basic flaw. He mistook. He didn't look at transpulmonary pressure. They only looked at the peak pressure or the plateau pressure. It's actually the transpulmonary pressures that you need to look at. So this is again the two studies. The first study by Gattinoni et al. For proning, which showed improved oxygenation but no improvement in mortality, and of course then the Severity trial where oxygenation and mortality both improved. So just somebody to tell me all three important differences in the two studies which might account for the differences. If you are paying attention today, I'm sure you all should. Three differences in the two studies. Gattinoni's original study on proning, which was negative for mortality but okay for oxygenation, and the Severity trial. Three important differences. Okay, one is duration of proning, how much versus how much roughly? Roughly? 7 versus 17, yeah, okay. 7 hours in the first one and 17. That's one. Second?
Second was the tidal volume, sir. In initial studies, the actual body weight was taken in. Later, it was predicted body weight.
No, it was not, you are right about tidal volume, but it was not.
It was actually high tidal volume. It was not 6 ml per kg, it was predicted body weight, but it was more than 6 ml
It
per
was 10 ml per kilogram, right. So that's the second one is the tidal volume. So higher tidal volume. Third one? Yeah, what you said? Yeah, so what was the severity? In Proseva it was 150 and in the first one it was? It was 300. Okay, sorry, this has not come properly. So the three main differences was, like you said, they used high tidal volumes in the 10 ml per kilogram in the original study. They recruited patients with a much lower degree of severity at PA to FRD ratio of 300, and proning, of course, was much shorter in the study for 7. This is again something that all of you should get. Somebody should get off. Connect the two frames. Okay, again connect these two frames.
Sir ko aapko bhi.
So what is the left side? What is it showing? Petal, of course, everybody knows. Rose, everybody knows. So what's the left? What is the left side of the picture? That, of course, why would have that? Of course, anybody would say rose and petal, but why the left side of the picture? What is the left side of the picture depicting?
What are the left frames?
Pardon? How do you get, what is the origin of the NMBAs? What is the first NMBA? Come to the mic,
So the neuromuscular blockade curare.
Which country? Which country do you think they used it first? No. South America, you're right. In the Amazon, the hunters used, so they used to dip their darts in curare obtained from that plant of that tree, extract of the leaf. So that was how they used to use for hunting. The darts were dipped in curare, the original neuromuscular blocking agent. So Gunjan also gets something, you get something, somebody has got rose, of course identifying rose and petal is.
Gunjan to shop kholenge kya?
So this is the rose and petal study about, I really won't talk too much about that. And okay, now in ARDS, as we know, because of low tidal volume ventilation, quite often you have a lot of asynchronies, and quite often the idiot's way to treat it is to just paralyze the patient. But sometimes, that's why you use NMBS to, but sometimes, you probably can do other things. But the question is, there are two ventricular asynchronies which are common in low tidal volume ventilation during ARDS. So which are the two, A and B? Which is A? What is A? What is B?
A is reverse triggering, B is double triggering.
Why A? Why reverse? Why A is reverse and why is A reverse and why is it not double triggering?
B is patient isn't spontaneous.
So, and A? Why is it reverse triggering? Why? Yeah, you said B is making a spontaneous breath. A is not having a spontaneous breath. The preceding breath, if it is a spontaneous breath, it's double triggering.
Double triggering.
If the preceding breath, there is no trigger at all. It's a mandatory breath or a controlled breath, it is likely to be reverse triggering. So that's what I've said. When there's a, so you get the chocolate for that. So when there is a spontaneous breath preceding the double breath, they call it generally likely to be double triggering. And there is no spontaneous breath, it's more likely to be reverse triggering. So this is one of our former presidents, R. Venkatraman, with his bodyguard. So what new paradigm in the management of ARDS is being hinted at by this slide? President, I mean this is just a lateral thinking clue sort of. Our president, why did I select this president? You should know, R. Venkatraman with his bodyguard. What new paradigm in the management of ARDS? We all talked about low tidal volume ventilation, lung protective ventilation, all that, but there's some new paradigm now.
Sir, is it right ventricular dysfunction?
No, dysfunction, what? No, dysfunction, so you're almost half there. Gunjan gets it, she said RV protective ventilation, so RV is the president and that's his bodyguard, so RV protective ventilation, that's a new paradigm you get in the, so now your approach is to protect the RV, we all know that too much of PEEP, too much tidal volumes can cause an acute call pulmonale. Nowadays you want to protect the RV as well, not just low tidal volume ventilation. So Gunjan gets 2 chocolates for that and it's RV protective ventilation. So what is the connection with ARDS? What is this connection? How connect this slide with ARDS?
It's related to the finding the recruitable alveoli and giving optimal PEEP with
Just tell me one term, what is it called?
Recruitment.
Yeah, recruitment method or recruitability. That's it. Recruitment or recruitability. This is just a recruitment method, how you recruit. So the same people are answering. So this is something simple. All of you have answered. I just the last of the parameters I have. No, so the last parameter I have sort of blanked out. Just fill in the blank. The last parameter. This whole list of parameters, many of them are difficult to measure. There's one parameter which is reasonably simple and which I have blanked out, the last one in this list. After protein C, last parameter.
Sir, bicarbonate or systolic blood?
Bicarbonate is a parameter, the last parameter is bicarbonate. So all of you, some of you at least have been paying attention. And final question, okay. Final question. So inhaled nitric oxide has been used as a salvage measure in severe hypoxia. Why inhaled vasodilators? Why not IV vasodilators?
Because
the IV will worsen your shunting.
Shunting because of the shunting.
How does it worsen shunting?
We need some.
Sir, because it will not reach the diseased alveoli.
How does it worsen? How does it worsen hypoxia?
To improve VQ matching, we give
So how does it worsen hypoxia? That's the question. Yeah, you're right. VQ matching is better.
Bronchospasm.
How does IV worsen hypoxia?
That will go to the better perfused lungs.
I'm asking, how does IV better?
We do not want to dilate the lung which is not ventilated. We want to specifically.
So what does IV? What do IV vasodilators do? So what do IV?
They generally dilate everywhere, no sir.
So what do they abolish?
Hypoxemic pulmonary vasoconstriction.
They abolish hypoxic vasoconstriction.
Loss of hypoxemic pulmonary vasoconstriction.
So when you give IV, they abolish hypoxic vasoconstriction. So VQ mismatching is worsened. And when you give inhale, what happens? When you give inhale, what happens? When you give inhale, what happens when you give inhale nitric oxide? Only the alveoli which are ventilated get it. So I hope.
They told first.
Fine, thank you. That's it. I hope you all had. Not bad, it took managed 30 minutes.
So that's the end of our scientific session today. And remember, from 7 p.m. we have a very good cultural evening. So all of you are invited for this 7 p.m. onwards, and all felicitations will be done after during that time, 7 p.m. to 9:30. So please come back, go and take rest and come back sharp at 7 p.m. All faculties will be felicitated after 7 p.m. क्या चाहिए? कौन सा? हाँ, that slogan का भी उसी slogan वाला हुआ है क्या? वो तो शाम को ही होगा. That is if उसी में, हिंदी में, evening में ही है, उसके साथ ही है.